All right, everyone, we'll get started. Thank you so much again for yesterday. It was a blast. So I don't drink very much, but I went to the wine and cheese. And I'm going to be honest with you, I'm feeling really shitty this morning. So Amandeep Sidhu, it's my pleasure to introduce her because she's going to take over the moderating. So Amandeep Sidhu's, she is a perfusionist, was the head of perfusion here, has now moved on to work at Critical Care BC, and her purview encompasses perfusion services in terms of critical care delivery across sites. And more than that, she's also one of the medical leads at Critical Care BC as well. Incredible bridge builder, collaborator, healthcare professional, and so I'm super excited, especially this session focuses on mechanical circulatory support in the form of NRP, so she's going to moderate, and it's my pleasure to bring her up.
Thanks, Mip. Welcome everyone to day 2. So yesterday's journey took us through death and dying and organ donation, and so today we're really going to focus on post-mortem, transplantation, and kind of the journey for patients and families through transplantation. And so this morning's session is very exciting, it's new, it's novel, it's controversial, it's all of the things, and we're really lucky to have a diverse panel that's going to be speaking with us at the end, answering all of our questions. But to kick us off, we've got Dr. Dan Harvey, who is here from the UK. He is an intensivist at the Nottingham University Hospital, and he is very active in research and in publications. And as we heard yesterday from many of the people that presented, he is leading the SIGNET study that is really going to inform how we practice in transplant medicine. So Dan, do you want to come up and you can do your presentation? And then actually, you know what, before Dan starts, maybe we'll get everybody from the panel to come up and sit up here, and then we can announce you guys as you're presenting and head into the panel. Julie, that's you too. Sounds so. Thanks.
Good morning. Well, what an absolute pleasure it is to come to Vancouver and address this meeting. I really enjoyed yesterday. It was fantastic. So I'm really looking forward to sharing some of the messages and our journey from the UK. Little bit about me, you just heard. So I'm an ordinary practicing intensivist in a big tertiary neuro and trauma ICU, but I've also got a role with NHS Blood and Transplant, and previously with the Intensive Care Society in their legal and ethical advisory group as well as some research roles which you've just heard about. And I hope all of those might be relevant both to our journey in the UK and to some of the stories I'm going to tell you about that. Disclosures and conflict of interest. I do get some funding from the state for the research which is related to organ donation, and of course NHSBT part fund my salary. But I think the most important conflict of interest isn't a conflict of interest at all, but a disclosure of interest, because it's a real pleasure to come back to Canada, the home of my birth. My accent might belie that, but I call Ottawa hometown. And I've been involved in helping and collaborating with research in organ donation in Canada for a number of years now by the CDTRP, and it's a real pleasure to come back and try and continue some of that work and collaboration. Thanks before I start to some colleagues. The work I'm going to present today is not mine, but as a result of all the people in the UK who help drive up forward organ donation and transplantation, not least Alex Manara, who's recently retired from Bristol, my colleague Dale Gardner from Nottingham, who's also lead for organ donation in the UK, and Antonio Rubino, who's a consultant from Papworth in Cambridge. So the aims for today's talk, I'm going to talk about 3 forms of safety in NRP and how we might get there, share some practical experience in the UK, maybe highlight a few ethical and physiological challenges. We heard quite a lot of those yesterday from colleagues, and perhaps most importantly, some opportunities for our shared future. I'm not going to spend a lot of time talking about transplant outcomes, but some colleagues on the panel are going to do that in a moment, or discuss the surgical technique in a lot of detail. I am not a surgeon. We'll have a little look at anatomical variation, and we won't be looking specifically at country-specific regulation, although that's clearly important. Okay, so what is normothermic regional perfusion? Well, it's an ECMO perfusion technology, and the idea is to reoxygenate organs in the body of the DCD donor. Why would you want to do that? Well, it might allow you to give better organ assessment, to move away from the Mark 1 surgical eyeball into some physiological assessment of organ function. You will recover some of that organ function because of from the warm ischemia, and I'll show you that in a moment. The hope is that improves outcomes in the recipient. It changes the DCD process in theatre to something that looks a lot more like DBD, and therefore calmness in the operating theatre and a degree of safety. And it's much cheaper than the alternative perfusion technologies of ex situ. But that comes at a cost. So it lengthens the time in your donor theatre hospital. It's more expensive than just standard DCD, of course. There are ethical concerns we'll come to in a moment, of which mostly focus on thoracoabdominal NRP rather than abdominal NRP is the most controversial. And we worry, of course, that any error there threatens the entire program. So normothermic regional perfusion, you can see, is really the use of that ECMO circuit, but confined in the UK experience currently to the abdominal organs. And this is what it might look like. So you have a withdrawal of treatment in theatre and asystole, followed by a standard declaration of death at 5 minutes using our usual protocols, institution of normothermic regional perfusion for a variable amount of time, commonly between 2 and 4 hours, before retrieval of the organs and cold static storage. And here's the theoretical benefit of that. So you see ATP loss, so energy, cellular metabolism fall during the agonal period and functional warm ischemic time, and that you can then reperfuse that and improve organ function and perfusion before that cold perfusion period and transport to the recipient. I'm going to talk a little bit about 3 forms of safety in NRP, where it comes from. So the conceptual safety we talked about yesterday, does NRP conform to the dead donor rule? Some theoretical safety that might occur from considerations about anatomy and technique. And I think probably most important, practical safety, what that means in terms of complex technology in teams and performance, system safety, culture and governance, and a little bit about what our response might be to adverse incidents. Okay, so first of all, conceptual safety. Well, we talked quite a lot about this yesterday, so we don't want to spend a great deal of time, but NRPs come under significant ethical criticism over the years, and that mostly resolves around the restoration of circulation in the donor, which, as we heard in the US, may be problematic because of their definitions of death in the Uniform Determination of Death Act, because circulation is restarted in the body and therefore is not irreversible. However, the conceptual safety in NRP accepts that it's the brain circulation which counts, and that, of course, is what Sam spent some time going through yesterday, and that medical standards for death rely on the permanence of that, which it will not be restored, rather than a strict interpretation of the irreversibility, that is, it cannot be restored. And in the UK, that's certainly the brain circulation which counts, and that's been true since 1979 with our first recognition of death by neurological criteria, and indeed an update of that in 2025 for our code for the determination of death, specifically state that NRP protocols must ensure no circulation to the brain. And that's true, of course, too in Canada, and this paper was cited heavily yesterday, quite rightly, as an excellent bit of work that has really determined that the permanent loss of circulation to the brain serves as a surrogate for the loss of brain function. And there's an increasing global recognition that, in fact, it's the brain that counts when it comes to the determination of death. And that at that moment when death is declared after the 5-minute standoff time, then there is the possibility of restoring brain function. So it's critically important that any interventions that occur post-mortem do not restore circulation to the brain. What do we mean by permanence? In that situation, we mean it won't resume spontaneously, and it will not be restored through intervention. And we're quite familiar with those concepts because they're the ones that underpin our DCD programs and have done since the very start. They're the reason why we have such strict protocols about reintubation and for example, preventing cyclical ventilation when we're looking at DCD lung retrieval, for example. And NRP can be viewed as another technology that's not any different to that. It's just more complex and therefore has a degree of application which we need to think through carefully. As I said, this is an increasing unification of these concepts around the world, and I just highlight colleagues in Canada, but also in France and Spain that have put together some of this work that really is coalescing our understanding around the ethics of NRP, I think, to all of our benefit. Having said that, there are unresolved ethical problems, and this is an increasing area of concern within the literature and all of us as well in our clinical practice. And this paper from Nick Murphy, again in Canada, just highlights the number of articles that are currently in press that relate to ethical concerns, many of which are related to the possibility of donor harm, as I just mentioned, but there are more things to consider. And we can talk a little bit more about what the practical impact of NRP programs might be, but recognizing that they land on everyone in the whole of donation and transplant, not all of whom have the benefit of listening, to eloquent explanations of donor and family benefit that we heard yesterday, or of the technical rationale for our interventions that we also heard yesterday, or of meetings like this where we get a chance to talk about these things in depth. And I might just highlight, for example, theatre teams who will not have any of the benefits of much of that education or knowledge, understanding, and their consideration of advanced technologies like NRP need to be taken into account. So what about the theoretical safety then? If we're happy that certainly in the UK and Canada that a brain-based definition of death gives us a conceptual safety of NRP, does the theory of the application stand up to the same challenge? So Sam went through this yesterday, that really it's the lack of flow that then leads to a reduction in perfusion and a loss of function. And so it's critically important that we ensure that there is no circulation to the brain, because that will mean no perfusion and no function. And we need to therefore make sure it doesn't retain spontaneously, and we don't restore that circulation using NRP. So is that possible? Are there problems? Well, there may be. So in the we're going to talk a little bit today just about the growth of NRP in the UK, and I wanted to give you a history about what that meant, both technically and practically, but also personally, if you like, some of our own journey through the ethics and reality of this. So UK's NRP practice really started in two centres, in Papworth, in Cambridge, and in Edinburgh, and I just want to take a moment to highlight the dedication, commitment, perseverance, talent, and, if you like, technical application of those two teams. Because without innovators in not just in donation and transplant, but right across medicine, we will never make any progress. And I think that their insight and vision and ongoing determination to make some of these things happen is really quite phenomenal. Our job as a community is to make sure that that can be done safely and appropriately, and bring the entire clinical and public community with us. And we'll talk a little bit about that, but I think it's important just to recognise how much we value their contribution, but also recognise that we're all humans, and that when you are committed to those sorts of technologies, or that sort of development, or that's the thing that is the burning fire in your soul, and all for good reasons, because you want to improve the possibility of donors to donate, you want to improve the quality and a number of lives saved through transplantation, that can sometimes mean that you can miss some of the potential flaws or challenges in the implementation of some of that technology. And I think there's no doubt that in the UK, that was some of our experiences. And we heard yesterday as well about the possibility of psychological biases or heuristics, which might cloud all of our judgments into whether technologies can be safely applied in a certain circumstance. So, for example, here are some of the things, a little summary of some of the conversations in the UK over the last 10 years, that, cerebral circulation doesn't really matter. Conceptually, we disagree with those ethical concerns. Or, okay, we accept that some of those ethical concerns might be real. However, it can't happen because theoretically, the NRP does not allow flow back to the cerebral circulation. Okay, that might happen, but it won't happen because the volume of practical perfusion we're talking about is tiny. Okay, so perfusion may be possible, but it won't actually change the function in the brain. Okay, so you see this slow slip of conversations, and it's really critical that we recognise that we're all human here, and we need to make our decisions together in a way that we can bring the entire community with us. So why are we worried about theoretical reperfusion in specifically in TANRP, but also potentially in ANRP in normothermic regional perfusion? Because if you were to clamp across the supraaortic arch vessels, you might immediately assume that any reperfusion that occurs in the aorta cannot perfuse the brain. And of course, the vast majority of perfusion does indeed go through those major vessels. However, unfortunately, not all of it. So the advantages of this first technique, the simple clamp across the aortic vessels, is clearly very simple, but it doesn't recognize that there are some collaterals which are not dealt with. So the spinal collaterals which run through your anterior spinal artery and posterior spinal artery, and indeed through your inferior epigastric, internal thoracic, and to the subclavian, and thence to the vertebral arteries, and of course critically towards the brainstem. And a further worry might be that if you were to occlude the usual flow through those major vessels off the aortic arch, you might actually encourage flow via the collaterals. In other words, by clamping those arteries, you actually increase the amount of flow that runs through those collateral perfusion opportunities. Now, these were theoretical concerns until they became real ones. And I think there's something for the learning in all of us there, because when we think about theoretical concerns with a complex program, if you run that program often enough, you might find that those theoretical concerns become very real, and that's something for us all to consider. The other thing just to mention is the possibility of an anomalous anatomy, particularly aberrant vertebral arteries. So we know that, for example, that the right can originate from the aorta in about 0.7% of cases, and the left about 4.8% of cases. It doesn't really matter so much about the left because it's normally pretty easy to see, but the right can be very difficult and actually hidden behind those other vessels. And again, I'm not a cardiothoracic surgeon, so this will be the extent of of the anatomy you're going to hear here. But it's enough for me as an intensivist and a donation physician to know that this is difficult. And because this isn't, we know what difficult procedures are. We do difficult procedures every single day. And we know what error can sometimes occur there. It does not mean that that our teams are not proficient, doesn't mean they're not capable, doesn't mean they're not expertly trained, it doesn't mean they're not committed. It just means they're human. So if an error is if it's possible to make an error, if you repeat that often enough, you will probably make the error. In other words, are we going to miss an aberrant right vertebral artery that comes directly off the aorta that's not seen and not recognized? Probably. And that's a worry because of where your vertebral arteries then currently supply, and they critically, as we know, have come together to form the basilar artery, and the combination of various different vasculature supply considerable parts of your brainstem. And these problems were increasingly recognized over the last decade due to the development of NRP, and many people in this room were a part of some of both the recognition of those initial problems and of the potential solutions. And this is the theoretical safety concept that we subsequently developed. The concept that if you were to provide an alternative route for collateral flow back down those major vessels, either to negative or to atmospheric pressure, then even if there were a head of pressure built in the collateral circulation, then that would then drain preferentially back into the thorax rather than superior into vertebral arteries and into brainstem perfusion. And indeed, that was the concept that we published after the coming up with this idea in this joint proposal between the UK and Canada, of which some of us in the room, it was my pleasure to work with in this paper. And the thought occurred last night as we enjoyed the cheese and wine that potentially there were opportunities there as well for the same sort of brilliant bit of work. So I hope someone wrote it down because I inexplicably forgot. So, but no, in all seriousness, bringing together people who are committed and interested in this sort of work is completely vital to how we develop safe and expert practice, and meetings like this are an integral part of that, and it's a real pleasure to take part. So that's technique 2, if you like. This time we'll ligate those supraortic arch vessels and then use active or passive drainage system. Now, some advantages to that, right? You've got that theoretically low pressure diversion for any collateral flow that you might be developing through either ANRP or, more worryingly, TANRP, and accounts for that anomalous anatomy that you may not have either recognized pre-retrieval or during the retrieval surgery. But it is complicated and it is time consuming. And we know that time is a problem in DCD retrieval and transplantation, and complicated techniques are a problem in advanced clinical practice. We'll talk a little bit more about that in a moment. And indeed, this is what colleagues in Spain are doing, if you like, currently what we think is the best technique, which is to ligate supraortic arch vessels and then leave those Kefrolide ends open to atmospheric pressure. So not attempt to drain them back into the NRP circuit, but just leave the blood flow to run in the chest. And that will give you a low pressure diversion for collateral flow, will account for that anomalous anatomy, and is much less complicated and time consuming. Yeah. So that's currently what colleagues in Spain are doing with their TANRP practice. And of note, although we don't have the full details of exactly what the techniques are in other parts of the world, to my knowledge, the majority of colleagues in the US are currently using technique number 1, that is simple clamping. What about abdominal NRP? Well, this is much simpler for a couple of reasons. The first is that the absolute flow rates in abdominal NRP are lower than they are in TANRP. So if you like, the total flow that's running through that normothermic regional perfusion system is less. It's clearly at a significant distance from the cerebral circulation. The number of collaterals are lower. And as a result, the theoretical risk for perfusion of the cerebral circulation is less, but it's not zero. And so what do we do in the UK to try, and both as a safety protocol and as a monitor, is that we insert a large bore cannula into the ascending aorta and leave it open to the atmosphere. And that effectively is not only a potential diversion for any pressure that might build in the thoracic aorta, but it's also a safety monitor because arguably, were the clamp to slip on the descending aorta, you should see a jet of blood hit the ceiling. And that should be pretty obvious, even for those of us who aren't surgeons. So, just with the permission of donor families, that's what this process looks in time, and you can see that there's a head of pressure there in that cannula, and that I think is very reassuring, and we'll hear in a little while just about the fact that has definitely been reassuring in a single case of abdominal normothermic regional perfusion in the UK during our experience, where we saw the heart restart unexpectedly. So, and one of the issues with these techniques is what should you do if you feel or if you consider that there is a risk that there's been some technical failure in your normothermic regional perfusion technique that might carry the risk of reperfusing the cerebral circulation. So clearly, were the heart to restart in a case of ANRP, then that does carry that risk. Because if the heart restarts, you think, well, that's going to pump blood back into your thoracic aorta, and thence to your carotids, and thence to the to your brain. Because critically in ANRP, you have not put a clamp across that cerebral circulation. But the presence of the aortic cannula allowed the team in that situation to immediately assess the fact that there was no flow in the thoracic aorta and therefore no restoration of perfusion. You might well then ask, okay, well then why did the heart restart? And to be perfectly frank, not sure we've got a good explanation for that. It seems to me there are 3 ways to restart the heart. You can give it some electricity. We're pretty confident that didn't happen. You can perfuse the coronaries. Now that is theoretically possible if there was some collateral flow into the coronary circulation, aberrant anatomy that you weren't previously aware of. Although that would have to go, essentially across the diaphragm seems unlikely, but not impossible. Or, while in my own personal opinion, you've seen a degree of refilling of the right side of the heart, ventricular stretch, and that is enough to cause a restarting of the heart. I suspect that there was an element of venous flow back into the right side. Okay. So is there data out there that might suggest that these techniques, either in TANRP or ANRP, are safe? In other words, that when they're applied, you do not see flow back into the cerebral circulation. And I'm pleased to say that thanks to the work and research of many colleagues around the world, we are beginning to see the development of that evidence. And I would highlight this excellent paper from colleagues in Spain, where they used intra-arterial pressure monitoring in the circle of Willis. So it doesn't get much better than that, I think, as a gold standard for how you might determine whether there is a head of pressure. And as we said, the key thing here is there flow? That doesn't answer the question about is there perfusion, and doesn't answer the question about whether there is subsequently function. We'll get onto that in a moment, but it might tell you whether there was flow, because if there's no pressure, there cannot be any flow. And reassuringly, in 8 cases of ANRP and 2 cases of TANRP, they did not see any restoration of the perfusing pressure in the circle of Willis. I will just note, the pressure in the circle of Willis is not zero. And that's important to note, and back to all of our physiology. You may have been taught this in year 1, although I'll admit that I forgot it. So, but that when you turn the pump off in a circulation, then the pressure falls to a resting pressure, which is essentially is the best, if you like, physiological marker of preload, which is dependent on the degree of vascular tone. So the pressure that you will see in that system is not zero, but it is insufficient to cause flow and thus perfusion. And then also from colleagues in Spain, a use of a different technology, this time radionucleotide perfusion imaging, in 15 cases of ANRP and 5 of TANRP, using that what we currently think is best practice in TANRP, the so-called Monara technique, and that reassuringly didn't show any cerebral perfusion. However, not all the evidence is pointing in quite the same direction, and this recent paper, I don't necessarily recommend it. I couldn't fully understand exactly what was done here. However, it does suggest that in an animal model, even though there's been occlusion of those major branches of the aorta, there was still, quotes, delayed, discrete, and transient supraaortic extracranial blood flow documented in half of those cases, presumably through collateral supply. And then here, interestingly, that included delayed opacification of the carotid artery. So again, I will just highlight that anatomy is not my strong point, and I'm not a surgeon, but I can't quite see where the previously described anatomical variation would have allowed that to happen, and it's not adequately described in that paper. So I think we have some more work to do here. Okay, so we talked about conceptual safety, about whether NRP prevents either the diagnosis or the continuation of the declaration of death, and confirmed that we think in the UK and Canada and increasingly globally around the world it does not. We've talked about theoretical safety, how that might be achieved in TANRP and ANRP, and also increasing amounts of evidence that show that those techniques are effective. But I want to spend a little bit of time just talking about practice safety, what that really means when you put this into your system. So just to give you a little bit of background about the UK, so we've got a national system of donor identification, referral, approach, consent, matching, retrieval. We've got 10 abdominal retrieval teams which are deployed nationally, of which 8 are on call at any one time, 6 cardiothoracic teams. 7 of those 10 have the ability to do abdominal NRP at the moment, although is a growing capability and experience. To note, ANRP is massively resource intensive for your donation and transplant system. It takes a load of very experienced staff. It takes expensive kit, which is not always available and needs to be moved around the country. It takes a lot of time. It is complex. There's some logistics behind that, and it takes theatre real estate in your donor hospitals. So those are real practical reasons why, even if you accept the conceptual and technical safety of NRP, why its practice implementation might be difficult. How are we getting on in the UK? Well, NRP attendances are going up significantly. So 212 in the last financial year. This data does include the 32 cases of TANRP that we did in the early days, but we have done 0 of those since 2020, and we'll talk a little bit more about those in a moment. And that's an increasing component of our DCD experience. So currently around 26% of DCD donors in the UK have NRP applied, and you will of course already know that DCD is a large component of the UK's donation and transplant system. Does it make a difference? Well, yes. So the data would suggest that probably it does, and I'm not going to steal all of Matt's thunder. He's going to talk a little bit more about the outcomes in a moment, but you can see here that certainly when it comes to percentages of transplants offered, on the left there, it looks like NRP makes a significant difference in the liver, and that indeed continues on to the number that are retrieved and subsequently transplanted. But this is the thing that's probably most interesting from my perspective as a donation physician, as an intensivist, as someone who is looking to try and maximize the possibility of donation for every family and patient that might want it, because it looks like there's some increasing data that would suggest that NRP begins to negate the impact of prolonged functional warm ischemia, and clearly that means that we see less stand down, less prolonged time to asystole, and a greater proportion of DCD donors be able to donate specifically the liver. And it's the ability of NRP to really value each and every donation that is most exciting to me, and I think this data is encouraging from that perspective. And indeed, we are seeing DCD liver donation rise in the UK. However, is it all quite as good as it seems? Because the proportion of patients in our DCD population who go on to donate the liver has not risen significantly, and not risen as much as you might have hoped and expected with the implementation of an NRP program. So why might that be? This is now just my best guess. I don't have any data to support the following possibilities, but just a little thought experiment. Let's say in your first year you do hardly NRP. It's maybe 5% of your overall DCD program. And as your program develops, say at year 4, you manage to do 35%. By year 8, you're doing 85%. What's the effect when you're thinking about the transplant team's acceptance and utilization of organs? Well, in year 1, those teams are only offered standard DCD. So you don't see much of an effect of NRP. But in year 4, now you're seeing 35% of your livers maybe come from an NRP program, and you think they're better. What's the effect of that in your willingness to accept a standard DCD liver? We don't know. My suggestion is you are less likely to accept the standard DCD liver, which is a problem because it's still 2/3 of your program. So utilization begins to fall in your standard DCD population because of the quality that is only now available in 30% of your NRP program, because it's so difficult to deliver logistically. By the time you get to it being 85, 95% of your program, you can't see the difference anymore. You're over the hump. I think that explains why we haven't seen an increase in DCD liver utilization in the UK. But that is maybe beginning to change. So this is unpublished data, but might suggest from a reanalysis of our data that for every 1,000 DCD livers that are offered, NRP almost doubles the number of transplants, and that importantly, because those grafts also survive longer in NRP, those patients do not need to be retransplanted, and that effectively those additional livers that come on stream only happen maybe 2 and 3 years after, when you've seen graft loss from the first DCD organs. So there's a secondary benefit that occurs in your system, but it takes time to achieve. Okay, we'll press on because I'm running out of time. Just to say that we've been funded in the UK now for a rollout and extension of our abdominal NRP program to cover the entirety of DCD. However, I'll just mention the logistical challenges. So what about TA-NRP? Well, TA-NRP is all about the heart. And we know that already in the UK, 27% of our heart transplants already come from DCD using direct procurement and the use of the ex situ perfusion. And this has had a transformational effect on heart transplant in the UK. And pleasingly, those outcomes look really good. So then the question then becomes, well, if your outcomes from direct procurement and the use of the OCS in heart transplant are so good, why do you need TA-NRP? And we haven't answered that question yet. But there's also that practical experience, because after we paused our TA-NRP program when we saw flow back from those collateral vessels, the collateral vessels via the major vessels back into the thoracic cavity, and that effectively confirms that collateral flow is a real problem. And so we paused the TANRP program until we had the data that suggested that that collateral flow could be controlled, diverted into the chest and was safe. And we're beginning to see that data, as I've already shown. Talk a few minutes in the last few minutes and around quite a short time about future directions. How might we improve the science here about cerebral blood flow? How do we develop safe systems and some practical real world ethics? So we've just heard already about improving the science, and my thanks are really to the Spanish who've driven this work, and we're trying to support that in the UK too. And we have a clinical protocol currently running. We've done 2 cases in abdominal NRP, looking at CT angiography during abdominal NRP to exclude perfusion. We're also looking at cerebral oxygenation in that study, and we'll hope to expand that potentially subsequently to TANRP when we've proven it works. What about functional monitoring? So we've talked about exclusion of flow, and then could you exclude perfusion? We talked about perfusion studies as well. And what about a monitor? Well, clearly, whatever monitor we choose that might look to exclude neurological function would need to be validated in low flow states, and that could be a bit of a problem. We'd need to be able to make sure that it could be interpreted by the clinicians who are on the ground in real time. And that's an issue. And a multimodal approach seems initially to be the obvious choice, except that there are the possibility, as we know, when we use multiple monitors, that it just compounds the error rate instead of actually reducing the safety. And I will just highlight what we found in our own research. This is the DPART study that I was a pleasure to be involved in, led by Sunny. And in those 631 patients after withdrawal of life-sustaining therapy, 4% had a return of cardiac activity with ECG and waveforms, but it wasn't all detected clinically. So the fact that you can detect these things means, yes, but it needs to be detected by the team on the ground for it to be an effective safety monitor. What's the answer to this? Well, I would hope as well to be able to use platform studies as this approach. I haven't got time to talk about that at the moment, but just to say, although we may have missed the boat for equipoise in ANRP and liver outcomes, that's not true for the use of normothermic regional perfusion in totality right across all our organ systems. And the number of questions we could answer using that sort of methodology. They can be difficult to implement, particularly in these sort of complex systems. And so an idea we're currently trying to develop in the UK at the moment is use of what might call a Tetris trial, where you design multiple interventions to occur at the same time in your DCD protocol to try and maximize efficiency and effectiveness of the research. And we could talk more about this later on the panel, perhaps. How do you develop safe systems? Trust in an NRP is global. In other words, it is not and Sunny talked eloquently about the value of trust in donation and transplantation systems, but it is not enough for us to have a safe system in the UK. It's not enough for us to have a safe system in Spain or in Canada. We need a safe system globally, because arguably, I think catastrophe in one jurisdiction will rapidly wash into all the others. And activity, both in terms of donation numbers and transplant outcomes, are not the only metric that matters. And so this paper that was recently published looking at American experience in NRP is a concern. So 89% of ODOs in America had experience with NRP, but their mean case volume was only 7. So I just want to think back to the number of cases that you might have done where you've done something 7 times. First time you put a central line in, first time you intubated a patient, first time you ventilated someone. Think you're expert after 7? Not sure. 80% had used teams from outside their own area. So I want you to think about putting that central line in someone else's ICU. And that 40% of ODOs had no NRP policy to cover that. That's a concern. Where's the focus on trust in the system? Because we know that team performance needs expertise, commitment, and talent. So this is the Sky cycling team who won many Tour de France's. But we know that expertise, commitment, and talent are required, but they're not sufficient for expert. What else do you need? You need data, marginal gains, you need protocols, you need training, you need to practice and repeat that multiple times for expertise. And then you not need to go too far. So those who know the story of Team Sky will know they run multiple yellow jerseys and Tour de France's, and then all of that was somewhat undermined by an aggressive use of salbutamol for asthma in the team. And it's not really about whether they had asthma or not, whether salbutamol actually really was the reason why they continued to win cycle races. It doesn't matter because it's tainted the victories after that point. And it's the tainting of our victories that is a potential problem here. But there's also the risk of highly complex and dangerous interventions occurring in a time-pressured manner. So this is the F1 pit lane, Josh Verstappen's car in the 1994 Grand Prix, where a very highly volatile liquid that had to be applied very carefully and quickly, there was probably a gap in an O-ring, and this was the result, an enormous fire which occurred. Now, they had been delivering fuel into F1 cars without a problem for hundreds and hundreds of times, but it happened once, and that was the result, and they were very lucky that everybody survived that particular incident. Of note, Formula One cars are now no longer refueled in the pit lane, not because it can't be done, but because it can't be done safely, reliably, and at scale every single time without the risk of that flow causing an enormous fireball. So instead, they just run round the circuit heavier. In other words, just because you can do something that might nominally be better in a complex system doesn't mean you should if you can't apply it safely across the entire system. It also matters what your response to those incidents were, and we know that there are a number of human factors that really are vitally important into how safe systems are developed. And so it's a concern when we are occasionally gaslit that our concerns about this are not real. For example, here from a recent paper, such the resumption of integrated neurological function as a result of NRP might result in activities like agonal breathing or occult consciousness. To date, there's no evidence of this where it's appropriately isolated. Is that something we could rely on? Well, our local NRP data suggests that the mean duration of functional warm ischemic time is really of the order of about 32 minutes. So I would argue that that's entirely possible, that were you to restore perfusion, you may well see function, and our experience in out-of-hospital cardiac arrest would tend to back this up. So I thought it might be interesting just to plug in the last few minutes, just to plug how long have I got out of time? 2 minutes. To plug some numbers in. On technical thoughts, we'll skip through that because I think it's important we get to this. How do we make sure that there are safe systems? Well, we do what we've done in other areas. So in DCD, we have proven through the research and our application the safety of the 5-minute standoff time, for example, but we show that as well through the experience in our numbers that we have not had auto-resuscitation in our now extensive experience of DCD based on the science. And we do the same thing in the diagnosis of neurological death. So even where we have been issues related to diagnostic accuracy, for example, in the UK with decompressive craniotomy, we've been able to integrate that new learning and understanding in a safe way through training experience into our clinical practice through the code of death. And so colleagues' expansion of this, for example, in Spain, without any reported adverse events is very reassuring. We'll just highlight that complex systems are difficult in terms of governance. There is a natural learning curve, both in individual clinical expert surgical teams, but also in the system as a whole, about how to apply, how to train, how to educate, how to utilize those organs, and then subsequently how to make sure that the safety and the reporting you have in place is sufficient over time, and that those complex systems need time to grow. The real benefit of perfusion might be that it unlocks some of that complexity, and the difficult decision about organ utilization is one that I would highlight, and this may be in time the biggest impact of NRP, that it really allows us to understand what the different impacts of all those different factors might be, and share some of that decision making, not just inside our MDT, but critically with patients as well. We might need some new metrics that helps to describe that. This is Dr. Doolittle's push me, pull you. But I think it's often recognized, for example, that transplant needs a donation to occur. What is not so often appreciated by all of us is that donation needs transplant. In other words, if there is not a transplanting patient and transplanting team who are willing to accept an organ, donation will not occur. The greater the willingness of transplant teams to accept an organ, because they can apply technologies like NRP, the greater the pull and the larger the amount of donation will occur. That is not described in our current metrics in any way. And we need to understand that relationship really clearly when we apply these sorts of technologies. So the lack of some of these things in the system south of the border had led my colleague Dale Gardner to describe in this paper in JAMA Open that really the US remains the Wild West of NRP, and that is a problem for all of us. Okay. We've got some practical experience of this in the UK. This is NHS Blood and Transplant dealing with the contaminated blood scandal. It's taken 30 years. NHS BT is overwhelmingly blood. And so we are very keen not to see a repetition of these sort of national scandals, which cost billions of pounds, lose an awful lot of trust and took 30 years to sort out. Might highlight that the Human Tissue Act in the UK only exists because of an organ retention scandal in paediatrics in Alder Hey, again 35 years ago. And I have some experience of this in my own hospital, which is currently under a public inquiry because of problems in maternity care. If you've ever been the focus of any of these sorts of issues, you will be very keen not to replicate it. And the harm there is not really to the donor, which we think is likely minimal for the reasons I've explained, potentially to the family because of communication, but might be offset by prior assent, to the donation system as a whole, but really to recipient transplant and transplant programs because they will lose this very valuable technology. We'll skip through that because I don't have time. We talked about that yesterday. And just to summarize, to say we've talked about 3 mechanisms of safety in NRP. Conceptual, which I think is broadly accepted. Theoretical, which has got some encouraging evidence developing, but we need a little bit more. Practical, but we need to think carefully about the implementation science. 3 opportunities for our future. Improve the science of perfusion, but also organ impact. Develop those safe systems, and really a practical, ethical response to prevent, plan, and engage where these things to go wrong. I'm sorry I've overrun.
Thank you, Dan. I'm sure everyone has lots of questions, but we're just going to ask that everyone holds off on questions until we have our panel at the end. So up next, we have Matt Weiss, and he's here from Quebec City. He's a pediatric intensivist working at the University Hospital of Quebec, as well as an assistant clinical professor at Laval University. Thanks, Matt.
All right. Appreciate that. And so going to be covering some of the same stuff that Dan just talked about. I'll try to motor through those slides as quickly as possible. Here we're going to be talking about the beneficence of NRP, specifically in heart and liver donations, same disclosures. Special disclosure, donation specialist. I'm not a transplanter. Special thanks to Pro, who verified my liver slides. Here he is. You can ask him some questions after the end of my talk. Any remaining errors are mine alone. So setting the table, as Dan mentioned, same thing in Canada. DCD has vastly increased in frequency from about 1% in 2006 to roughly 30% in most provinces today of the type of donation pathway that we're going to follow. The population is aging and more comorbid. So NRP technology that might allow us to either assess or repair or reperfuse organs becomes more important as the donation population becomes sicker. The same slide that Sam showed yesterday, but I would point out that already in 2025, there have been almost as many publications as all of 2018, just to show the rapid increase in publications related to perfusion and donation. It is very hot right now. So as Marat will detail, and as Dan already mentioned, there are risks. It can get into the public eye, but this guy's going to talk about that. I'm here to talk about the potential. So there are really 2 pathways that NRP can make a difference. It can either increase the number of donors because you are willing to accept donors that otherwise you wouldn't have accepted otherwise, or you can improve the outcomes of the organ once it has been recovered and transplanted. Those are your real two pathways. So we'll see if any of those apply. For the scope of the rest of the talk, I'm only going to be talking about controlled DCD here. I'm not going to be talking about uncontrolled DCD, which doesn't really apply in a Canadian context, even though there are always mutterings of programs trying to start up. We will be talking about mostly review articles, and those by definition will have multiple jurisdictions, multiple techniques. For instance, some jurisdictions allow ante-mortem cannulation, a lot do not. We're not going to get into the details of that. We don't have the time to really dig into the individual studies, but we are going to be looking at published literature reviews. Table is set, we're ready to dig in. So, most important question, does NRP work? Does it work? And I guess the most important answer would be sort of. It depends on where you focus. The biggest takeaway is that it is going to be organ specific, as we'll talk. And as Dan mentioned in much more detail, the data is full of mixed comparisons. And you can still pull some conclusions. I mean, these studies are both fruit, you could say. Even if you're not comparing apples to apples, you are comparing things that are hopefully at least similar enough that we can draw some conclusions. So this is a 2021 paper from our European colleagues. I chose it because as a first paper because it looked at all NRP applied to all organs. And from that review, which is the 2021 or the first reference there, for the kidneys, there was limited to no benefit for NRP. That's a chart from their review showing that either for primary non-function or delayed graft function, there was no significant difference. And that was confirmed again in a recently published 2025 review by Klein and Newland. Once again, no difference in primary function, 1 year graft function, or utilization. So it doesn't seem at this time that NRP makes a big difference for kidneys, and in the interest of time, we'll move on. Lungs. About the same story for lungs. This is UNOS data from 19 to 22, which showed no difference in 6-month survival. Outcomes with and without NRP were similar. They did actually look, because technically thoracoabdominal NRP with lung recovery can be technically quite difficult, risk of hemorrhaging, delayed reintubation. They wanted to make sure it wasn't worse to use NRP for lungs, and so they at least were reassured on that level. And so really, but we knew that about the lungs, that likely limiting the ischemic time would not make much of a difference. We knew that, among other reasons, from our colleagues in Toronto who had done lung recovery from MAID donors who died at home, where the arrest time was more than an hour. Not the functional warm ischemic time, the arrest time was more than an hour. So kidneys, lungs, they can tolerate ischemic injuries better. It's unlikely that NRP is going to make nearly as big a difference as for other organs. So search for benefit continues. And, as Dan mentioned, we're likely going to find it in the liver. So historic DCD liver outcomes were rough. If you look from 1997 to 2006, they had rates of up to 60% ischemic cholangiopathy. That was data coming out of Johns Hopkins, once again, that they were willing to publish. So a prestigious institution publishing a 60% complication rate. About the same time period, this is a separate paper that came out that looked at the cost and just how much, and in a large part because of the high complication rate, the cost of DCD livers compared to brain dead donors was much, much higher. So all of this data led to warm ischemic time limitations of less than 30 minutes, and all of us on the donation side know how nervous the liver transplanters get when things start to go long. Now, those are the historic data, and you could say that was a dark time, a long time ago. Nickelback ruled the airwaves, and the Americans had elected an unqualified moron to be their president. Never going to make that mistake again. So we needed better liver outcomes. And one of the ways, there were a lot of improvements in surgical technique that I'm sure Prasanto could talk about, but one of the things that has vastly improved liver outcomes in DCD has been NRP. This is a paper from an Australian group in 2024, and this is going to be the most exciting part of the talk, where we talk about study selection. But it was all controlled DCD, no pediatrics, only looked at the case series with at least 5 livers, and they included 11 papers. And specifically that last point, there were no limits on post-recovery perfusion. We haven't really been talking about the variety of different pumps you can put the livers on after you've recovered them, but they can be normal or hypothermic, and different technologies can be applied. This is a slide directly from their paper. I'm sorry if it's hard to read with their color scheme, but essentially the purple box in the top right you can see that when you looked at comparison of NRP versus non-NRP livers recovered through the DCD pathway, they had decreased rates of any outcome they measured. And that second purple box, they found no difference between DCD livers and donation after brain death livers. So it seemed to really make a difference. And if you look just a bit more into their details, so they confirmed a substantial reduction in ischemic cholangiopathy. They were also reported a significant reduction in primary graft dysfunction and recipient mortality. These were findings that had not been seen in the review from the ESOT group in 2021. Did not examine cost, and they did not have enough comparisons for post-recovery perfusion strategies, and their data was all European and UK. This data out of the US was published too late for the OSCE review, but it was an additional 242 livers, largely similar report, although they did not find a mortality benefit for recipients, and interestingly, they found no ischemic cholangiopathy in the NRP group. So implications. Multiple systems now, European systems, they won't take livers that don't have NRP. That's specifically true in France. There's been continued global expansion of NRP, abdominal NRP, for the livers where it's available. And current data suggests benefit regardless of what you do with the livers after. Although, as Dan said, and I'll show in another slide, it's complicated. Liver schmiver, what about our hearts? So I'm going to show the same image that we've already seen at least 2 or 3 times. Higher risk, higher reward, much more collaterals, and it's harder to exclude the cerebral circulation. People will often compare NRP to direct procurement and perfusion, where the heart is taken out rapidly after confirmation of death and put on some type of perfusion device, often the Transmedics OCS system we've seen a lot about. The surgeons will tell you the ex situ perfusion lacks dynamic assessment. Specifically, afterload assessment is difficult to impossible when the heart is on these ex situ pumps. Looking at data, when you try to compare what has happened with NRP versus DPP, this is a recent study from US data looking at 318 DCD hearts from 19 to 21. They found no 1-year mortality benefit for NRP. And they didn't report any other outcomes. I will say this is somewhat typical of the NRP literature. Their conclusion was thus, well, you should do it because the outcomes are better for the abdominal organs. So there does seem to sometimes be some general enthusiasm among programs that have done this. Some scorching hot new data. This has not been, this is a pre-publication but accepted for publication that looked at international data, did include US data as well. They again found no difference in 1-year survival, although there was a trend at 0.08 p-value of towards NRP advantage. But there is more ECMO in direct procurement perfusion versus NRP, almost 2.5 times more ECMO in the DPP group. So there does seem to be some advantage, and it certainly is possible that if you did enough of these, if you're doing 2.5 times more ECMO, eventually you're going to have more ECMO complications as well. Conclusions from that group was that NRP seemed promising, but further study needed. They had no quality of life indicators or economic analysis. Curiously, they did state that Europe and the US are looking at issues of cerebral perfusion. MIP, I guess you haven't contacted them. There is a special case for DCD hearts. The pediatricians in the room will recognize single ventricle physiology, one of many complicated congenital cardiomyopathies that we see frequently in the pediatric group. Palliation or attempted correction of those are difficult to impossible. We currently in Canada and most of North America do not consider transplantation because there are just too few hearts available. Infants rarely progress to brain death, and withdrawal of life-sustaining measures is by far the most common mode of death in the NICU. So if we were able to do DCD hearts in that population, there is a real chance of a kind of paradigmatic change in how we treat complex congenital cardiomyopathies. That's been done in a group from Duke in Chicago with a 6.2 kilo recipient and 6.4 kilo donor. Obviously not as small as our neonates that we often see, but still significant, where the heart was recovered using TA-NRP and then transported with cold storage. There currently are not commercial boxes small enough for infant hearts. So quick other benefits for the potential for NRP. As Dan said, it can change these procedures into a much more controlled setting. And in France, they even institute the NRP in the ICU. So you're not monopolizing the OR time, and you can really change it from a DCD almost into a DBD. And, you know, the benefit to the donor families who often want to give the best gift. And so if we are convinced that there is a chance that these organs will function better, most of the time, that's what the families want. Word of caution, you haven't heard me mention the word RCT, or randomized controlled trial. The logistics of that are almost impossible. Just conceptually, if you're just looking at potential cardiac DCD donors, well, you can say, no problem, we'll compare NRP to DPP. Okay, sure, but then if it's DPP, well, what are you doing, normothermic regional? Or normothermic ex situ or hypothermic ex situ. And if you're looking at NRP, okay, if you're doing thoracoabdominal, are you doing ex situ perfusion after? Are you not doing it? If you are doing it, what type are you doing? Could you be doing abdominal NRP with cardiac direct procurement, with or without ex situ? So you can see the design of these studies through a traditional RCT. As Dan mentioned, these need powerful platform technology, or powerful platform methodology, that is just not available currently, and the data that we're looking at is not high quality RCT data. Very partial thanks to ChatGPT for helping me on that. Also, equipoise is becoming more rare. You know, that is another thing that is mentioned. We probably missed it for livers. If you were going to tell the French to do a RCT with or without NRP, they just wouldn't participate because they are entirely convinced of the benefit. And not unreasonably based on the data that we have. But it would be really difficult in some of these settings to get an RCT going. Also, word of caution, much of this data was generated during the pandemic. Hard to know how that may or may not have confounded some of these issues. And almost no data on conversion or utilization rates, which is, if you recall, that's one of the key ways this could increase, that provide benefit to the system. So merci, just a bit of log rolling. I do hope you consider, for anybody that can travel, consider going to the ISODP meeting, which is for December in Kyoto. A lot of good NRP topics, and the only international conference focused directly on donation issues. Also CDTRP, as Sunny mentioned yesterday, a lot of great stuff. I'll go to their website, frequent webinars, and a peek behind the curtain before we sign over.
Thanks, Matt. Very well done on sticking to the time allotted. Up next, we have Marat Slesarev. I practiced yesterday. He's an adult intensivist from London Health Sciences, an assistant professor and clinical scientist at the Department of Medicine for Western University, and he's a researcher with the Canadian Critical Care Trials Group. And he will be talking to us today about honoring the dead donor rule. Thanks, Matt.
Thank you. It's really hard to go after Dan and especially Matt. When I got the title of my talk, I knew Matt was going to talk about pro-NRP stuff, and I was glad to see that my talk was titled pro-ish, not con, because it'd be really hard to argue that I'm against this. So I do have a few disclosures. I do have a bunch of funding for research related to donation. That's not just with NRP, but other areas. And I do work for Trillium Gift of Life and Canadian Blood Services. So I guess for us to implement NRP in Canada, we have to face the critics south of the border, because all the things that Dan alluded to, that our systems are interconnected, and a scandal in one place can really have a ripple effect in jurisdictions like ours. And so when we were looking at identifying what kind of questions we wanted answered, these are the three questions that come up over and over again. And, you know, there are obviously metaphysical questions out there, but we're not going to touch them today. And the three questions are as follows. Does occlusion of vessels in NRP induce brain death? That was one of the things that American College of Physicians statement suggested, that the tying of the blood vessels when you are getting ready to put the patient on NRP actually induces brain death, because we don't know how much time passes between cessation of circulation and cessation of brain function. The second one, does NRP violate the dead donor rule? And the third one is, does NRP risk trust in donation? So I'm going to take on each of those questions one at a time. So the first one is, does occlusion of vessels in NRP induce brain death? And I think we have some data to suggest no. Brain activity and brain blood flow stop before circulatory arrest. We are running a large prospective multi-center observational study in Canada, where we essentially applying EEG leads on patients who are planning to undergo withdrawal of life-sustaining measures in the ICU. And we also then put transcranial Doppler on their heads. This is illustrated in the figure below. This is Tanya. I can reassure you she's well and alive. This is one of our research coordinators. She's demonstrating this. But that's how the setup looks in the room. And we've so far have enrolled 75 participants out of 90. And you can see the statistics of the various breakdown of monitoring technologies there. We do plan to expand our sample size because enrollment is ongoing, and there are others in this room, including Julie, who have contributed greatly to getting those numbers for us. But we do have some preliminary data as when we were starting to set this study up. The top right graph there demonstrates cessation of EEG activity just before the time of circulatory arrest, which is the 0 time point there. And you can see that, and that's across, I think, 8 subjects. And the same is true for brain blood flow. It does stop a little bit before cessation of brain activity. And we're now starting to take a peek at what the thresholds, physiological thresholds for blood flow and pulse pressure are to result in these events. So you can see from our natural history study of neurophysiology in the dying patient, it seems like the brain blood flow stops first, followed by brain activity, followed by cessation of systemic circulation. And what's reassuring, we haven't seen any resumption of brain activity or brain blood flow in the small cohort that we have so far, but obviously the larger data will come later. And because NRP is instituted at 5 minutes after circulatory arrest, then the statement that occlusion of blood vessels induces brain death is just simply untrue. So the second question was, does NRP violate the dead donor rule? And for those in the audience who may not be familiar with this concept, the dead donor rule states that organ recovery must occur after somebody has been determined to have died, and it cannot be the cause of death for a donor. And in 2023, SAM led a guideline effort to determine what death is, and redefined death as permanent loss of brain function that occurs in DCC case after permanent cessation of brain circulation, which results as a result of permanent cessation of systemic circulation. And then Nick Murphy, you keep hearing the name, he is a legend in this field, helped us to think this through. And so if death is defined as permanent loss of brain function that occurs as a result of permanent cessation of brain circulation, that as long as we apply surgical safeguards that maintain that permanent cessation of brain blood flow, then DCD plus NRP would not violate the dead donor rule. And of course, the question here is, how do we know if these safeguards are indeed effective in maintaining that permanence? So this brings me to the second point. We have heard some data from Spain, but before those studies were published, we embarked on our own study in Ontario called Conclude Study, and this is a 2-center prospective observational trial that took us a long time to get through ethics, as you can imagine, and get everybody on board, because we had 2 liver programs, one in Toronto, one in London. We needed to bring them together and really iron out the surgical protocol, the neuromonitoring protocol, and most importantly, involve donor families in helping us to develop consent materials. How do we approach families to consent for this kind of a study? This is perhaps the most complex study that I have ever done. and I'm a clinician scientist, and we do randomized controlled trials and all that stuff, but this is by far the most complex. And the complexity is in the number of teams involved. Trying to mobilize those teams to come together was a great learning experience. But you can see we started enrolling in April of last year, and so far we have consented 15 patients, of which 2 did not die in time to allow donation after circulatory death, similar to a case MIP shared yesterday. And we performed 13 cases with 2 of them not suitable for transplantation, and resulting in 11 donors, 10 livers, 15 kidneys, and 4 lungs. And I can tell you that last NRP we did, that's not included in this one. We actually worked together with a team from Boston to do simultaneous DCD, ANRP plus direct procurement and machine perfusion of the heart, so DCD heart, in the same case. And that was sort of technically challenging because of all the bleeding that's involved. And so surgically, the surgeons did an amazing job because they had to all come together and make this happen. It's an amazing teamwork effort. But you can see this is what the OR is quite busy. So practically, we need a large operating theater. The first time we did it, there was, I think, 10 or 12 perfusionists in the room, and you can multiply it across different teams because everybody wanted to learn what was happening here. And you can see that the top left figure there shows the patient's head under the drapes, and that's where our EEG, continuous EEG and TCD monitoring. And we also had to bring TCD and EEG techs into the OR, but more importantly, neurointensivists, neurologists have never been in this setting, had to come in to interpret these signals. And we have a donation physician, there's Dr. Basmaji there, my colleague, who is there to communicate and orchestrate this whole scenario. So the data is emerging, we're continuing to enroll, and we're planning to add a couple more centers in Toronto. Sunnybrook and St. Mike's, and Edmonton's also coming on board, and hopefully so we'll continue enrolling in this study. And at some point, hopefully pivot to TNRP. There is interest in that, but we haven't crossed that threshold just yet. There is emergent data, obviously, from, I'm not going to belabor this, you already heard that the Spaniards have done a very interesting study where they cannulated pre-mortem DCD donors and put the cannulas inside the circle of Willis and measured pressure there, compared to abdominal pressure and thoracic pressures during these procedures. We can't do that, not yet, at least in Ontario, because we don't permit non-therapeutic DCD donor interventions, but this is obviously supportive of safety of ANRP. And the last question, I think, in this domain is, why should we care about protecting the brain in the first place? Well, there's data to suggest if you resume blood flow, you can violate the dead donor rule in Canada, which, remember, is based on permanent cessation of brain circulation. This is an RCT that was done in pigs, where they randomized 16 pigs to thoracoabdominal NRP with or without clamping. You can see the black line is with the clamp at the top graph there, and after baseline measurements and 5 minutes of asystole, 5 minutes after systole, NRP started. And if you have a clamp on, there is no blood flow and there is no resumption of cortical or brainstem electrical activity, saying the brain function and brain blood flow remain unaltered. But if the clamp is removed, there is a resumption of brain blood flow, and expectedly those animals have return of cortical and brainstem function, which would violate death determination in Canada and violate the dead donor rule. Well, you say, well, this is animal data. How does it apply to humans? And, you know, in brain dead donors, of course, all the entire brain have died. We have patients, the majority of our DCD patients are those with some degree of brain injury. But we also have DCD donation after medical assistance in dying. And I would argue that those patients are most vulnerable to the risk of resumption of brain activity, brain blood flow, despite the fact that they get large dosages of anesthetics. And the reason for that is that the half-life and the volume of distribution of those drugs when they go in an NRP circuit is currently unknown, right? And so you don't know if they're effectively protecting the brain after they've been administered for MAID purposes. And we now also have data to suggest that even patients with injured brains have residual brain activity and function up until the time of circulatory arrest. So even the ones in the middle will have some residual electroencephalographic functions. So we have to be careful. So finally, the last question we wanted to answer as we proceed through this careful implementation of NRP in Canada is, does it risk trust in donation? And so we did a study supported by the CDTRP program in Ontario that was led by Charles Weyer, an ethicist, and Mary Ott. She's a qualitative researcher and educator, where we interviewed donor families and healthcare providers about their perceptions of ethics of NRP and trust in the NRP process. And what emerged was not what we expected. We were so focused on the violation of the dead donor rule and the events surrounding NRP practice. And the family said, sure, we are concerned about the risk of resumption of brain activity and brain function and perhaps sentience. So do show us data that doesn't happen. It will reassure us. But more importantly, they see NRP as just yet another event in their loved one's journey through the medical system that begins from the time when they arrive in the ICU. And they argue to us that the trust in NRP, the seeds for that trust, are planted upstream of NRP, upstream of consent for donation, discussion of withdrawal of life support measures, but in the ethics of care that we provide for our patients. And they helped us draw this diagram that completely flipped the way we think about this. And so this work is now expanding to a national study. We're funded by the Canadian Institute of Health Research. Added a couple of researchers and Matt helping us from ODO perspective, Sean Keating. There's others in this room who are part of that large study. And it has 3 parallel work streams. We want to expand the qualitative studies beyond Ontario, obviously. And we will actually, this was a theoretical concept, what you think about trust, but we will actually interview healthcare providers who participated in the Conclude study. How did they feel about actually being part of the study? We will interview families who have consented to Conclude study as part of this work. We will do ethical and policy analysis for NRP implementations, including developing consent materials for families. Do you need consent for NRP? And if you do, what it should look like. Some jurisdictions like Philadelphia, Gift of Life, have a statement in their consent form for donation that you may undergo normothermic regional perfusion, but that statement is very short and small, and some would argue, does it really qualify as the informed consent? And so how much information does one need to provide to a family to make sure that they're providing informed consent? And the most important part of this is that we integrated knowledge translation with 5 provincial ODOs from the East Coast to BC here. And I think that's the real power of this work, is that we're doing it together with the practical side of things. So in summary, we posed the following 3 questions. Does occlusion of vessels in NRP induce brain death? And I would argue no, because brain blood flow. My brain has become brand, but brain blood flow and activity stop before circuit arrest, and NRP starts at least 5 minutes after circuit arrest. Does NRP violate the dead donor rule? No, at least in Canada, because we have defined death as cessation of brain function, and as long as we can maintain permanence of brain circuit to arrest and brain function, we're okay from that perspective. It's a bit more problematic south of the border. And emerging neuromonitoring evidence confirms this, so I think we're on our way to confirming no, it does not violate the dead donor rule. And does NRP risk trust in donation? No, if we ensure that we have that neuromonitoring data to reassure our stakeholders, and we continue to engage the community, not just the public, but also the healthcare provider community in this discourse. I think through wider national consultation, I think we'll be on good way to maintaining trust in NRP and donation as general. And on that note, I thank all the people who are involved in this. I'm just a speaker for this amazing group of professionals. Thank you.
Thank you, Murat. Up next, we have Stephanie Cartier-Plot. And she is one of our very own here at Vancouver General Hospital. She is a hepatobiliary surgeon and liver transplant specialist.
Perfect. Hi, I'm Stéphanie Chartier-Plante. I've been asked to talk about normothermic regional perfusion from a transplant surgery standpoint, but you will find that a lot of my points are similar to what have already been talked about. I have no definitional disclosure relevant to this topic. My objective for this very short talk is to try to understand what are the complication profiles associated with DCD organ donation and why, as a transplant surgeon, I think NRP is a good strategy. We'll try to understand what are the benefits very quickly and how it compares to other other perfusion alternative for DCD organ utilization. As everyone knows, the growth of organ donation in Canada has been characterized by a growth in organ from donor after cardiac death or DCD donor, and it represents about a third of all organ donation. However, even if there is a lot of organ donors, that doesn't mean that there is a lot of organs that are utilized. In Canada, about only 10% of the liver come from donor after cardiac death. In other jurisdictions, such as Netherlands or UK, where they have perfusion programs that include NRP or other alternative, the organ utilization from donor after cardiac death is slightly higher. When we think about why this is the case, we have to look at what are the fundamental differences between donor after cardiac death and a brain dead donor. And that differences...
Japanese Pavilion, ground floor, cardiac cath lab. Code blue, Japanese Pavilion, ground floor, cardiac cath lab. Code blue, Japanese Pavilion, ground floor, cardiac cath lab.
Maybe a bit too early. So the differences between brain dead donor and donor after cardiac death resides in that period of warm ischemia time that starts after withdrawal of care, when the organs are less and less perfused. There's a drop in blood pressure, drop in saturation, and that kind of agonal period constitutes the donor warm ischemia time, and that period is what causes injury to the organs and what brings the problem associated with those organs. To try to palliate that and to try to make up for that agonal phase, then what the surgeon do is that when we take organs from donor after cardiac death, rather than taking our time with dissection using cauteries, then we try to very quickly enter the abdominal cavity, and then we cannulate the aorta and then bleed out the IVC to try to perfuse the organ with cold solution and put ice on the organ to stop the damage that occurs during the warm ischemia time and stop the ATP depletion. So we try to basically aim to cannulate within 2 or 3 minutes of a skin cut to try to minimize the warm ischemia time from the donor. Doing so, there is evidently a risk of organ injuries just because some things are done in haste. And then after that, we really want to we really want to be quick to also remove the organs, and we don't have much time to look at organ viability and no opportunity for that. When you think about organ donation and why some of those organs are not used for donation in the DCD population, a lot of those organs are actually declined before the donor even proceed with withdrawal. Because of that danger with complication, most of the program have a cutoff for age using either 50, 60, or 70 years old, depending on their perfusion strategy. We also look at donor history. We look at biochemical liver function and then logistical capability. So if someone is already doing a liver and they don't think they can do another one very quickly, and this liver will be in the cold or in the box for a long time, then that might be a reason to decline those organs, unfortunately. If those organs are accepted, and then we see if they will pass on time for us to be able to use them. And when cold storage is used, most programs use about 30 minutes from functional donor warm ischemia time. And that definition of what functional donor warm ischemia time is, and where the cutoff starts, depends from program to program. Once if those donors pass on time, and then we can look at those organs, then we look at what the liver looks like. Is it perfused well? Is there steatosis? Is there fibrosis? And we might be able to do a biopsy. The availability of that depends from site to site, and that may lead to further discard. If programs have availability for machine perfusion after the organ retrieval, then that would allow to test the viability of those organs, and that might actually increase the rate of organ acceptance. When it's not available, we have to go with what's best and what we know about the organ. To try to palliate that, the UK has come up with a UK DCD risk score, and they kind of try to stratify using data from the donor, but also data from the recipient, including the recipient MELD score, and if there are retransplantation or complex surgery, and they qualify that combination of donor and recipient into a low risk score, a high risk group, a very futile group. And depending on that, those groups has different cutoff and different outcome in terms of primary non-function, ischemic angiopathy and biliary complication, and hepatic artery thrombosis. When there's a good match between donor and recipient, this score is low, and those matching can happen if the donor passes in time, and the risk of graft loss and complication is lower. On the other hand, if the matching is not good, then in that time, the risk of primary non-function, ischemic angiopathy, and hepatic artery thrombosis in that population was higher, and then they recommend to proceed with some kind of perfusion, either for NRP or perfusion after donation, if we want to use those organs. Historically, the outcome, those are all single center outcome for donation after cardiac death before NRP. You can see that there is, some have showed very big difference between patient and graft survival between donor after cardiac death or DCD donor and donor after brain death. As surgical technique have improved, those outcome are closer, but that cuts to the come of a lot of organ decline and rejection to be able to achieve outcomes similar to brain dead donors. What's the problem with DCD donor? Everyone has heard about, well, DCD donor are bad. Well, this is what it looks like clinically as a bad donor, a donor that has ischemic, that has ischemic angiopathy. The liver will work initially. This is the first one is post-op day 5 after liver transplant, when you see that all the bile duct is nice and plump. And then as time progressed, they did cholangiogram on the same recipient. They kept a little biliary tube and were able to shoot those cholangiogram. And by post-op day 36, you can see that the bile ducts are all diminutive. There are stricturings and beading on the bile duct. Those recipients will unfortunately need some further intervention. Either if they have a single stricture, they might need an ERCP or a drain. If there are multiple strictures like this, the liver will likely fail and they will need retransplantation. So those increased costs associated with liver transplant increase morbidity and also increase mortality. Another problem with DCD donors is the post-reperfusion syndrome. So this has been described as a change in blood pressure and hemodynamic stability following reperfusion of the liver. It can be mild when you just observe a change in blood pressure to very severe when the heart stops after bradycardia and chest compression is required during the surgery. DCD donor is one of the risk factors for reperfusion syndrome. So how can we optimize donation after cardiac death if we want to maximize organ utilization, but also maximize outcome for our recipient, because that's what donation is about. It's about outcome for the recipient. Well, before donation, we're already optimizing retrieval process, and we go with strict donor acceptance criteria leading to that drop-off of other organs. During retrieval, we can use NRP, and after retrieval, there is different type of pump perfusion, either hypothermic pump perfusion technique or normothermic perfusion. In terms of NRP, we've seen those data this morning already. This is the UK utilization. As they implemented their NRP program, they were able to recover more organ per donor and also increase the rate of those organs being transplanted with the improving transplant outcome, meaning a decreased chance of graft failure and for kidney decreased chance of daily graft function. In Sweden, they started to do DCD only in 2020. And they did that with a national NRP program. Doing so, they were able to have a 1-year post-transplant survivals above 90%, and no ischemic angiopathy were found after using NRP. They compared those donors to brain dead donor and found very similar results. This table shows what are the criteria for consideration of NRP. Earlier with DCD, we saw that the warm ischemia time is really kept below 30 minutes, either from extubation to perfusion or from a cutoff of blood pressure or saturation. Here, when NRP is considered, programs are willing to push the envelope, meaning that their donor age limit will increase. Some don't have any donor age limit. Some use 65 or 75-year-olds. The functional one ischemia time criteria change as well. Some program utilize a combination of saturation and blood pressure, while some other program utilize only blood pressure. The functional ischemia time can also be lengthened up to 120 minutes or no limit depending on the paper. So as you see, the paper are very heterogeneous in their presentation. And there also an upper limit for pre-donation liver function. And then we look at the variation of the liver function during NRP and the trend of the lactate. Usually a short increase in ALT and the trend down in the lactate combined with a good appearance of the liver would lead to an acceptance of this liver. With implementation of an abdominal NRP program in the US, they've been able to start with criteria for donor acceptance that are very similar to what we use in BC, meaning donor age less than 60 years old, functional warm ischemia time starting from a saturation or a blood pressure of 80 for a maximum of 30 minutes. As they gain experience with NRP, they move to a very much broadened acceptance criteria for donor. They use a total warm ischemia time of 90 minutes, which is what their hospital policies allows. And they went for a functional warm ischemia time of 30 minutes after systolic blood pressure drop below 50, which allows for most of the donor who proceed to die to be at least looked after and see if they will be a good liver and assessed during NRP. Those are the cohort study evaluating abdominal NRP and DCD, controlled DCD liver for transplantation. The Spanish has the largest experience in NRP published to date. And you can see that the rate of biliary complication and ischemic angiopathy are very low. And the graft survivals are all above 90%. This is the US study published in JAMA that we've seen today. When we look at NRP versus a DCD donor procured with standard cold storage, the length of stay with the NRP donor was shorter, and they have less early allograft dysfunction. Also, the rate of biliary anastomotic stricture and other biliary complication was lower in the NRP group. We have also seen this meta-analysis when they compare DCD liver procured with NRP and DCD liver procured with cold storage, showing an improvement in all rate of complication. And when they compare DCD liver to brain-dead liver, there is no difference in any measure of outcomes. How to push the envelope. I think the case of the Italian is very interesting as they have a mandatory no-touch period of 20 minutes. So how do you palliate that very long period when the organs are not perfused? Here they presented their experience with NRP followed by cold perfusion, dual oxygen-filled perfusion, which is DHOPE. And they did NRP and then a minimum of 2 hours of DHOPE following that. And they showed that their outcomes are actually similar to other DCD in other countries. They use a cohort from England to compare, as they are not allowed to do DCD with standard cold storage, and showed that their outcomes were similar to the DCD procured with cold storage. So with using those perfusion technology, we can actually push the envelope and use more liver to try to transplant people faster. In conclusion, NRP allowed for functional assessment. The functional is quite crude right now using the lactate and the ALT as well as the visual assessment, but it's a better assessment than what we have when we do a DCD with rapid technique. It also allows for a controlled surgical technique for organ recovery, basically changing a rapid technique to a donor similar to a brain-dead donor, which is a much more calmer environment in the OR. Also increase in organ utilization when we can actually look at the liver and see if it's going to work or not. This increases our confidence in using those organs. It reduced post-transplant complication and then reduced the cost associated with those post-transplant complication, even if the act of NRP itself might be more costly than the DCD used done with standard rapid technique. NRP can also be used in conjunction with other procurement machine perfusion, and that would allow us to push the envelope even further. Thank you.
Thank you, Stephanie. Up next, we have George Isaac, who is an intensivist and a cardiac anesthesiologist here at the Vancouver General Hospital. He's also the medical lead in organ donation and chairs the Organ Donation Committee at Vancouver General.
Awesome, thank you.
All right. Well, thanks to our speakers from before, I'm going to be able to hopefully quickly move through my slide deck so we can get to the most interesting part, which I think could be the panel discussion. The only disclosure that I have is I also work with BC Transplant as a donation physician. It's relevant to this talk. And really what I want to do is just quickly talk about a research study here at VGH and with BC Transplant to look at the safe implementation of NRP here locally. And really the purpose is just to share with you our experience in terms of putting together such a research study. In terms of NRP, you've already heard the benefits and the risks, and I won't go into those in any more detail given what we've talked about today, nor will I spend any time on what I think is a fantastic paper that really highlights the roadmap of how we need to move forward with NRP in Canada. That paper really outlines those important points that I think we need to be cognizant of. And really, for me, the big important message here was the importance of making sure not to reanimate the cerebral circulation, which is obvious, and how little proof and study data there is. And I'm glad to hear that there's increasing evidence in this field with the work that Murat and his colleagues are doing in Ontario to try and increase the knowledge base around the science in this arena. In terms of our pilot study here at VGH, in terms of NRP utilization, the real driver behind this was we thought we were actually quite uniquely positioned to study this. And what I mean is, in Canada, we're a Canadian site. We have, as we talked about, the legal backing to be able to do NRP in our country without violating a lot of the laws that other countries may not be able to perform. We locally have the multimodal monitoring experience that we thought we could contribute to looking after these patients as we've had clinical and research application of invasive and non-invasive monitors in other cohort patients such as post-cardiac arrest study patients that MIP described earlier. And we've got quite an extensive end-of-life research experience, and all those things together really allowed us to really think about applying NRP to our patient population here at VGH and here in BC. Obviously, driven by the primarily liver transplant program for the obvious reasons of potential benefit by hopefully extending ischemic times for liver with better and more functional graft outcomes. Obviously, in the future, the hope about being able to apply thoracoabdominal NRP to potential for heart transplants, if deemed safety, and there's local appetite to do so. And we really thought we could help to provide and fill that void of scientific information, and provide hopefully safety data globally for NRP practice that's much in need. So in a nutshell, basically what we do is we consent participants in our NRP study with neuromonitoring applied in the ICU in consented local DCD donors. The process of DCD differs, but the major differences between our usual and our cohort of study patients is we transfer to the OR for withdrawal of life-sustaining therapy. In the OR, those patients are still cared for by the ICU teams and ICU physicians, but we share that common OR space for the withdrawal life-sustaining therapy by the ICU, followed by the retrieval team entering the OR. The same rapid cannulation of the vessels we talked about, sternotomy to isolate the descending aorta, all of the safety profiles in place to vent the proximal aorta, as well as the institution of organ support with perfusion on cardiopulmonary bypass, the monitoring of organ function, cold flushing, and then subsequent storage. So specifically, the VGH DCD cases in whom NRP would be applied really relies on the neuromonitoring layer in terms of the study process. And what we're talking about is really two levels of monitoring, or two types of monitoring: invasive parenchymal neuromonitoring and non-invasive, non-parenchymal neuromonitoring. So in terms of the invasive monitoring, we are talking about doing bilateral invasive monitors using quadrilumen bolts that I'll show you that measure bilateral cerebral blood flow, one probe on each side of each hemisphere of the brain, bilateral brain tissue oxygenation, microdialysis, being able to look at the metabolic environment that the brain sees, intracranial pressure monitoring, and EEG depth electrode placements to hopefully mitigate potential artifacts that we might see with surface monitoring. Added to that invasive monitoring is the non-invasive complement that includes scalp EEG, AI-generated transcranial Doppler, brainstem auditory evoked potentials, somatosensory evoked potentials, and NIRS if we have the forehead real estate. This is what the neuromonitoring platform looks like. This is a single quad-lumen bolt with PbO2 monitor, ICP microdialysis, and cerebral blood flow monitoring. I love this picture because it highlights the high-tech in the foreground and the low-tech in the background of our CD player, tape deck, providing music at the bedside. This is what the device looks like up close, and the various monitors emanating from the top of the quad-lumen bolt. And you can see the ICP microdialysis, PbO2, and cerebral blood flow in the middle as how they enter the brain tissue. This is just a diagram to remind myself that we have surface EEG in addition to the depth electrodes. We have brainstem auditory evoked potentials as well as SSEP as well as AI-generated transcranial Doppler. And I can't do those sounds that MIP did yesterday, zit, 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 but that's essentially the same machine. This is what it looks like at the bedside. This is, I think, one of our post-arrest cardiac patients from years gone by, but it shows the quad-lumen bolt, a single one with the application of TCD. This is just a picture that I think you've seen before in terms of some of the real-time data that we get in terms of cerebral blood flow, hemodynamics, PbO2, and being able to integrate all those in a single monitoring platform. This is the whole suite of neurocritical care monitoring that is capable at our bedsides in the intensive care unit, and we'll show you pictures of how these are applied both in the ICU as well as in the ORs. So really, it is the pilot is really not about NRP, it really is the safety layer of neuromonitoring to ensure that there is really no cerebral circulation as evidenced by our invasive and non-invasive monitors, primarily those invasive monitors being cerebral blood flow and PbO2. And that's the flow component, and no evidence of function as evidenced by the EEG, brainstem, and SSEP monitoring, overseen by ICU EEG techs as well as neurologists. And really, we needed to come up with a game plan for evidence of flow or function would require immediate stopping of NRP. And I think Dan highlighted that as you monitor all kinds of things, you need to have a game plan in terms of how you deal with things. And the more things you monitor, the greater the risk of things showing you potential results that you may not expect. And all of these monitors would have to be applied prior to withdrawal life-sustaining therapy. This is a nice diagram that really shows the changes in cerebral blood flow that you might expect and the both EEG changes and cellular responses, and we really did look at that infarction threshold and really picked low levels of cerebral blood flow that we would potentially be willing to accept because they're well below what we feel is the infarction threshold. This is the NRP stopping rules that we had to come up with, and many thanks to a lot of our colleagues in the ICU here locally and our colleagues across the country that we bounced these parameters off to ensure we're not missing anything. And basically this table highlights how we would move forward or how would we adjust our NRP on the basis of the feedback of information that we're measuring real time. And on the left side, you see clinical criteria, and that's really to say, are there any signs of brainstem activity clinically? And that would clearly be if that's a yes, then it's an automatic decision that there is potential for reanimation. Regardless of what the neuromonitoring shows, that would be a problem in immediate stoppage of NRP. After that, if we had no clinical criteria met, we had all of our functional and perfusion monitors, depth electrode, EEG, brainstem auditory evoked potentials, cerebral blood flow, and PbO2. If those all show no flow, then there's no evidence of reanimation. We'd continue with NRP. And then all the combination and permutations that you'd see of the various functional monitors, perfusion monitors, that would allow us to be confident in our decision to stop NRP. From the function and perfusion, we really wanted to see that consistency of the results among multiple monitors, not just one. So that was a bit unique in our design. And cerebral blood flow cutoff, I told you, was 10, and PbO2 cutoffs would be probably under 5. So this is me standing here in front of you describing our research protocol, and I think you talked initially about what's your experience of 7 and how you feel about being confident. This is our experience of 1, maybe 2. So obviously take that in consideration, but I just wanted the opportunity to share with you what our thoughts are. It's extremely early. We're learning lots about neuromonitoring for NRP. We clearly hope to walk before we run, and that means really looking at abdominal NRP before thoracoabdominal. The hope is to provide objective human data to support the practice of NRP, and likely we will learn a lot from the physiology of the dying process, as you heard with anybody that's involved in this type of research. And then I couldn't help but to not include that pretzel analogy that we feel like sometimes we're having to morph our bodies in and contorting to make donation and transplantation happen. And I think that this is another form of extreme pretzeling, hopefully that's only short-lived for the long-term benefit that we will be able to see the benefits in the future. I see NRP very much like the early stage of DCD. It's got a lot of the ick factor. It's highly uncomfortable. And if we can get over this initial hump and hurdle and gain some confidence and understand a little bit more of the science, then maybe that'll be a lot more guiding in terms of our confidence moving forward. I'll very quickly share with you our journey in terms of the discussion. We had lots of discussion with key stakeholders, hallway conversations, phone conversations, coffee discussions, and that was probably a year and a half ago. We had REB approval early in 2024. We started a serial roadshow of presentations about NRP and our neuromonitoring study with various departments within the hospital through BC Transplant, with our OR cohort, the ICU cohorts, and several simulations that we kind of started in the late summer and fall. This is a shot from our OR mock back in August 2024, just trying to see, can we fit all the monitoring in a large OR? This is one of our larger ORs on the second floor, and that curtain is really a separation between the combined donation area that we were going to be withdrawing life-sustaining therapy by the ICU and the need for a surgical sterile setup within the ICU. And you'll see, because of the monitoring, we had no ability to move our patient. And that'll become obvious pretty quickly. A few other shots of that process. Later in November, we took it to simulation in the Sim Center, really to flesh out a lot of the details around how do we do NRP smoothly, skillfully, quickly, and further simulation really sorted out a lot of those details. This is February 2025, our first huddle around our first NRP donor. That's a huddle in the intensive care unit. All of our patients that would come through this and have, with our Evaluate study and other monitors, all have CTAs to look at balanced perfusion, have MRIs as part of their clinical workup. And then we establish a lot of the baseline data in the intensive care unit. So you can see the hemodynamic monitoring on the left, brain blood flow for both the right and left hemispheres, laptops to generate and cohort all of this data that flows from ICP monitors and bilateral brain tissue oxygen monitors. On the left, you'll see continuous jug bulb mixed venous sats, PA catheters, and all of the hemodynamics that come with invasive cardiac output monitoring. On the left is the microdialysis unit that allow us to look at the metabolic activity of the brain at various critical time points. ICP monitoring, PbO2 monitoring that I showed you. This is a picture of a patient in the intensive care unit with two quad lumen transcranial bolts that really allow us to provide the access for all of the monitoring that I showcased. This is I think one of the first patients we brought to the OR, and shortly after bringing the patient into the OR, you can see the numerous people involved in getting that patient connected to a whole host of monitors. And that is a very busy OR, it's a large OR, and you can see how much of the space is occupied in the background with the neuromonitors. This is our neurologist, EEG techs, intraoperative neurophysiology experts to help us with the real-time monitoring. And another shot of the monitors. This is, again, in the foreground of the anesthetic machine is all of the hemodynamic monitors, brain tissue measurements, and so forth. What you don't see is, oh, there it is. On the floor, you can see MIP toggling two laptop computers and, again, trying to cohort all of the information that we're collecting real time and make decisions about that. You can see on the foreground the microdialysis and all the blood work. This is the head of the bed, and that's the hemodynamic monitors in the very foreground, and you can see the transcranial Doppler, all of the neuromonitoring. It's extremely extensive and complicated, and that's the worst kind of spaghetti of wires that you'd ever see behind your computer. So there is no way that we could move the patient from the ICU, do withdrawal, and collect this type of data. So that's why the move to the OR for withdrawal of life-sustaining therapy. our TCD machine that you can see on the left side, and again, the rest of the suite of monitors. And again, another shot of the spaghetti of wires from SCCP, neuromonitors, and all the rest. This is just prior to bringing the family into the room. We've got a curtain that really does try to block a lot of the equipment at the head of the bed, and try and give some semblance of privacy for the families. And we've got another curtain at the far end of the room to separate the sterile field. Depicted there, again, another shot up close, a real tangle of wires. This is an action shot of our surgical team in action on the left, having just cannulated and put the patient on organ support, and our perfusionist on the right-hand side manning the pump. This is what we all hope to see, which is well-perfused intra-abdominal organs. You can see the cannulas coming from the far right, and well-perfused liver and intra-abdominal organs regionally, with no perfusion at the top end of the bed, which is the big concern. So this is a sample shot of PbO2s, as well as transcranial Dopplers, somatosensory evoked potentials, both left and right, brainstem auditory evoked potentials bilaterally. This is a summary sort of slide that shows that our scalp EEG recordings were unchanged, as did our depth electrodes, show no real activity throughout the deaf and NRP institution on the right side of the screen. And in closing, hoping to stay on time, our pilot team is massive. This is a huge undertaking by countless people. You saw on the many pictures the number of people involved, whether it was in the summertime doing sims, a weekend call out. Can't thank enough all of the players that are involved. I hope I haven't missed anybody, but it's a huge group collaborative effort, and very humbled to be able to stand here in front of you, and excited that that so many groups of people were supportive in this mission to allow us to undertake this study and provide this opportunity for British Columbians. Thank you.
Thank you, George. That was excellent. I'm just really grateful for all the speakers today. I think we've really covered every angle and kind of ethical perspective on NRP, and we're really going to get into the meat of things with the panel discussion. And so I know we're over schedule, so we're going to delay the break. So we'll do the panel discussion now and go into break in a little bit. On our panel, we also have Julie Crum from the University of Calgary, who is presented yesterday, and Prasantosh Chandri, who is also here from McGill, and he works with organ transplantation in Quebec. And so we've got a lot of experts, and I'm sure there's lots of burning questions in the audience. MIP has the first one. Oh, let me get some mics to you guys.
Yeah, thank you all. That was wild. I've got a question, two questions, one for Julie and one for Prasanto. First for Julie, the question is, you come at this at a very unique angle, being a neurologist, intensivist, epilepsy physician, stroke physician. Like, what from your perspective, what is the optimal monitoring technique that strikes, like what George presented is not generalizable. But what is the optimal technique that strikes that balance of informative neuromonitoring, but can be scalable? And then, Prasanto, for you, do you, as a liver transplant surgeon, do you view NRP as just NRP, or is it impairing, is it part of the process to then also enable like machine perfusion? Like, are they separate, or are they kind of a combined marriage?
Starting off with the easy questions. So one, I will say what George and Murat are doing is amazing. And certainly, as MIP highlights, is not going to be necessarily scalable moving forward for every single case. But I do think it's important to be utilizing all of these different monitors to ensure that we are scientifically proving that we are not going to be breaching the dead donor rule. One thing that really struck me that I was actually quite impressed that you guys actually started to think about this already was, well, what happens if one of these things like your PBTO2 monitor shows something? What do you do with that? Especially when we have a marvelous, an amazing, well-done guideline in Canada that doesn't say anything about PBTO2. It doesn't say anything about NIRS. It actually says don't use EEG. So I do think it's really important as we move forward with these studies that are needed, that one, we choose modalities, as hard as it may be in a research setting, that have been approved in Canada to confirm brain death, but also I think it is useful to use some of these other modalities as an extra safety, just as long as we're prepared to deal with things that may pop up that create some more pretzels. In terms of making it scalable, I think EEG, so depth electrode, is not necessarily ever going to be something that's feasible in every patient, but surface EEG certainly is possible. Or the abbreviated EEGs like BIS monitors would be something that I think would be phenomenal to check, or SedLine. And then even if you're using a full complement of EEG electrodes, you could still use, for example, quantitative EEG that makes it far more easy for non-experts to be interpreting the EEG at the bedside, which is what we use in Calgary for our screening for seizures with our nurses.
So the question of NRP and machine perfusion. I think it's one of the burning questions in liver transplantation right now. And the question is, are the technologies mutually exclusive or complementary? And I think that for a vibrant and growing liver transplant programs, you need to have both available. You need to have the machines available for the marginal livers, be they NRP or DBD. And we're talking about looking at eventually defatting protocols, extended viability assessment, and for logistics issues of rendering hopefully liver transplant a daytime elective procedure as opposed to a middle of the night emergent procedure, which is a lot of the U.S. experience, and a lot of the growth of machine perfusion in the United States has been predicated on that. The question then is, which NRP DCD livers would you want to subsequently put on a machine? And I think, again, that we're going to gain experience. You're probably going to see, as Dan described, a shift from we will all want to use DCD NRP livers. So even our standard criteria, DCD under 50, we're all going to start saying that we want to put that donor on NRP. I think that's the natural evolution, because regardless of of everything we've done so far, we still have higher complication rates with DCD livers, even the most standard and best ones. And so we want to do something to improve those. But we're also going to push it. We're going to push it to older donors, more fattier livers, higher BMIs, all sorts of things that we don't currently accept in DCD. And the question then will be whether in those donors we want to, in addition, apply machine perfusion strategies. And I think the answer is probably going to be yes. So I think the growth of liver transplantation in Canada and to improve the outcomes for patients and access to transplantation for folks on the wait list, you're going to need to see both technologies deployed in parallel. I don't know if that answers.
Thank you very much for those talks. And this is a question for Murat. So one of the things that you highlighted was when the pulse pressure or the mean arterial pressure was giving out for potential like cerebral circulation. And then you talked about a study comparing like the clamp in animals, either just like whether or not there could be reperfusion back to the brain. Could we potentially do a study where we don't clamp the animal and just do graded ECMO to see what the critical closing pressures are to the brain, and whether or not we could even return electrical activity or function to the brain? Because, you know, if we can't actually return function, are we just, again, twisting ourselves in a pretzel where it's like, is it even possible to get to that point? And can we help inform the thresholds that way in animal models?
Great question. Can we do the study? Yes. I mean, study can be done like that. I think the challenge lies in the fact that when we think about brain injury in DCD patients, it's a very heterogeneous group of patients. It could be diffuse anoxic brain injury post-cardiac arrest as one group, and they may have more uniform injury there, whereby you have a certain degree of intracranial pressure. And so, whereas in traumatic brain injury, you may have more focal effects or localized intercerebral hemorrhage, you may have more local effects that may impair blood flow more to that region of the brain than to others. And so I think the challenge will be in designing a model that replicates all combinations and permutations. Now, you can look at the average intracranial pressure and then sort of go through the, at least study the relationship between various levels of ICP and what the critical closing pressure is at various thresholds. I think it will be an interesting set of data, but again, and we will generate some of that data from from your work here in BC, I think, and like in any studies, we'll get a point estimate and a variance, a confidence interval around that point estimate, but you still will have some variability, right? So the more patients we do enroll in human studies, the more precise our point estimate will be for the mean arterial pressure and pulse pressure thresholds that are quote unquote safe for preventing brain reperfusion during these during NRP.
Can I ask a question?
Absolutely.
So I'm going to ask Dan this question, and it's more about the scaling of this. So right now what we're seeing is that across Canada, various jurisdictions are looking at very, very small applications of NRP, almost strictly in a research perspective. I spent some time with Gabby Niscu in Edinburgh and was impressed by how NHSBT had structured this. There's a training manual that we can all download. There are the minimum requirements for an NRP team, and there's a lot of emphasis on the structure and the minimum requirements that you need. So I think, what advice would you give us in Canada about how we can scale NRP? And I'm going to assume that all of your research is going to show us that this is possible to do in complying with dead donor rules and what have you. What advice can you give us about how we go about on a national rollout of this?
It's a great question. It's really important. It speaks to the fact that the science that you're doing in Canada is just phenomenal. Looking at the certainty that will give us in the safety of that technique is vital. And to make sure we can apply it practically by people who are not experts in that. And that is where the safety of those training and education approaches are really key. So the advice would be, you need to build that through your whole of your donation and transplant community. So we have, NRP training, not just in the practical application, but in the ethics and in the decision making inside our national deceased donation course, which is given to all of our ICU advanced trainees. There's a master class, as you've seen, for training retrieval surgeons into how to apply that safely. And then on top of that, you need a governance structure that you trust to highlight when there are issues, when that training and education and the inevitable complexity, such that when there are cases that raise concern, we can address those as as a community together. And we've already seen that when you do that in other settings, so you might say DCD, or for example in the diagnosis of of death by neurological criteria, you can see that builds faith, trust, in the system, not so much in the public, because all of that is not seen, but in ourselves, in a community, that we are open and transparent enough to deal with these issues, which will occur if you repeat them often enough. There will be some issues, and you will need to overcome those, make sure that they are not systematic, and for example, as an allegory in the diagnosis of neurological death, we had 2 potential cases, one of which taught us new knowledge about how to apply the diagnosis safely in the setting of decompressive craniotomy, and one which, is essentially that our previous understanding about the impact of high C-spine injury, for example, was not readily appreciated by the team. Those are completely different potential safety, if you like, lapses. But it's important the system as a whole is able to take account of those. So that would be the advice, and that's what we think may be missing elsewhere.
Any other questions from the audience? Yeah.
Yeah, thanks for a really informative panel. I learned a lot of nuances in terms of the procedure, the scaling, the risks, and the approach to the liver. I was part of a pro-con debate last year at the Canadian Society of Transplantation on whether or not to do NRP. And I have to tell you, it was a very hostile audience in a transplant conference. So I'm going to put on my hostile transplant hat and ask you all, why is this taking so long? Why can't we get this going? There are people dying with liver failure who are not getting grafts or getting inferior grafts with controlled DCD currently. Why are we taking so long and being so careful?
I'm going to pass that.
Not the mic's a hot potato.
I mean, I think that while it is a lot of potential to provide more and better quality hepatic grafts, I think the risk of failure is also dramatic here. And it's the kind of thing where you could do, you could do 50, 100, 150 cases. They all go well. But then if you have that one case where the clamp fails, the brain is reperfused, and the patient starts gasping in the OR table, and it is a moral issue in the sense that we have breached our trust, and then it is also practically, it would be a potential disaster for the public trust that we have spent decades in the system developing in Canada. If that information were to leave the OR and be transmitted to journalists, be transmitted to others, and that it's a high risk, high reward. It would be a low frequency event with extreme consequences if it were to happen. And to make sure that we could do our best to avoid that low frequency event is, I think, why we are being so cautious.
And I might just add that I've been in that seat, in those conferences, taking those attacks, and I think that they are reasonable. Okay, transplant recipients are potentially dying because we are not applying these technologies. Okay, so we do need to acknowledge that, but at the same time, I then the following day go to a different conference in critical care and try and highlight the potential values. It's accepting the risks there, and if you like, we have to bring that entire community with us. And so it's not enough just for us to be driven by advocacy in one particular area if we don't bring the entire community with us. And we've seen that before, in DCD, and indeed there are many, arguably, the biggest win for liver recipients as a whole would be the extension of standard DCD, which is without any of these complaints and without the resource issues, to a much larger population globally. Yeah, and that includes the differential application of some of those opportunities inside our own countries, which we know are real, both for geographical reasons and for resource limitations. So that would be the sort of pushback for why we think we should go safely. You might just add that yes, there is, and we've seen that eloquently explained about the defined benefit, particularly in liver cohorts, but there are lots of unanswered questions about the absolute benefit across multi-organ donors and across the system as a whole, which we sort of highlighted, which have not been answered. And there is an opportunity cost for the 35 people in the OR, for all of those other, not just in donation and transplant, but all the other things that they need to be doing. If we're seeing these things as complex system interventions, those are the questions we need to answer, not just, does this benefit one particular liver recipient? Well, sure, but we all work in critical care. We know that complex interventions are applied across entire populations, and it's the effect on the population that matters.
May I add
to that. So, Sam, thanks for asking that question. I will now engage in a therapy session with this group. I've been involved with NRP for many years now, and so, I've showed you the data when we started with our first case in last April, but building up to that was a long and arduous road. And so I've heard the same sentiments shared to me, sometimes multiple times a day or a week, on multiple Zoom calls. And when I started off in this journey, one of the things that I think my understanding of donation and transplantation is here we are on the donation side of things. We're taking care of the trust in the system. And then there's this wall that separates us from transplanters, and they're doing their things, but they want organs from my patients, and my job is to protect the trust at all costs. And it's almost an adversarial position where we found ourselves at when we first started this. The more I engaged with the group, I started to learn about the perspective of transplant surgeons, because as you interact with them, you understand the challenge that they face. Yes, we can talk about system implications, but they have real patients in front of them with their real lives that are at risk, and what is being perceived perhaps as an unresponsive system that is unable to pivot quick enough to enable innovation that's going to save lives tomorrow for my patient. And that's a very challenging situation to find yourself in. Then we went into the operating room, and that was a whole new learning experience for me. It was truly an emotional roller coaster. And what was interesting, if you know, we give 1,000 units per kilo of heparin, conventional DCD in Ontario. And that's what we did for the first case. And there was so much bleeding that the following case, we went down to 500, just like that. And I was like, well, so there is equipoise about how much heparin you use here. Perhaps we can entertain an RCT in the future and the benefits of heparin. And they're like, yeah, and this is interesting. We didn't expect it. Then, as we proceeded through doing more and more NRP cases, we had our first case where lungs were being recovered using direct procurement method with a lung transplant team there. And as that team was doing their dissection, we encountered a lot of bleeding in the chest. And they're like, whoa, there's a lot of collaterals here in the thorax, right? Which is the conversation that would never entered our conversation. The conversation never happened when we were talking about theoretical risks, right? They're like, we climb the aorta, everything's going to be fine. And so but then at the same time, as I'm peeking over the curtain, I'm seeing remember the first case when the bowels started to pink up and peristalse. And then the kidneys started to make urine. And so for me, it was a moment of learning that, oh my God, these organs are literally coming alive. And why would you ever accept a liver from a conventional DCD donor or any organ for that matter, if you can have a very good organ there. So the meta learning of this whole process was that I'm not so confident that wall that separates transplantation and donation necessarily needs to persist in its current form. And I think we need to work together more often, because an NRP is forcing us to play in the sandbox. And we're learning about our work, and I think it's making us a better community. The other meta learning point for me is that donation transplantation will remain an innovation-rich environment. And our biggest, I think, learning point from this experience is how do we develop a system that's going to be responsive to addressing and bringing the next innovation that comes down the pipeline into our community in a thoughtful, safe, and trust-preserving manner without dragging our feet and being too slow. And I think this work will build that ecosystem that will allow us to innovate in the future and become leaders in this in Canada.
Go ahead.
Hi, this question is for Dan. I was just curious, you've rolled this out so that you're taking more and more livers from NRP patients. Right now, we're only looking at doing it here in Vancouver. How do we extend that out to more hospitals, because we do donors all over the province, when there's a shortage of perfusionists and hospitals that don't have perfusion machines to have it go to a point where all livers from DCC donors are NRP? I'm just trying to figure out how you scaled that up and how we're going to possibly do that.
So that's an excellent question. And of course, your challenges in Canada will be different from ours in the UK because of the geography, but also maybe because of the transport times. And so the answer there is going to be different. And I can absolutely see why you might use different ex situ devices in addition to that. In the UK, our approach there has been to, if you like, centralize the expertise, the training, and into national retrieval teams. And then to send the retrieval teams with all the kit they need to the donor hospital. So we provide NRP in every hospital that does donation, which is, nearly 200 in the UK, with, as you saw, 10 national retrieval teams. Now, the logistics of that are not to be underestimated, and we have a national hub that do that, and that does mean putting teams on aeroplanes to fly to Belfast while we fly their kit to Southampton, and then we drive the remaining team after they've had a night in hotel to Newcastle on their return trip, dropping it off in Nottingham. It's not we do say it's the most complex intervention that the NHS provides in any 24-hour period. Might just say that we maybe go through that complexity to get to a place that is much simpler, and that's the vision. So if we get to a point in which these ex situ devices and or NRP can begin to unlock donation and transplantation, we can actually make that simpler. We can bring transplant into the daytime. We can bring matching over a 48-hour period. We can begin to, make some of the burden on donation specialists, families, donor hospitals, transplant recipients, transplanting theatre teams a little less, because recruitment, retention, burnout in all of those parts of the system are a real problem, not least in our transplanting teams. And in the UK, we've got a new project to try and streamline all of that, just recognizing that activity is not the only thing that matters. We do more and more, and the outcomes are great, sure, but it's got to be sustainable. Otherwise, it'll break.
We have time for one more question. Oh, it's a tie between, should we have a dance-off? I don't think we have time for that, but maybe we'll take your question here, and then you can pick the brain of the panelist in the break.
Just a quick question. Do we ever see this going into pediatrics of any kind, or with an age restriction in pediatrics?
Yeah, I think certainly there is increased risk for collateral circulation in pediatrics. That's something that we do know. There is abdominal NRP has been applied in Europe extensively for extensively. Pediatrics is always going to be small volume, but the pediatric cases of, say, hepatic recovery and transplantation is done routinely on abdominal NRP. And as I showed during my talk, there has been thoracoabdominal NRP done in the States already for cardiac recovery. So I do think it'll come. I think our nature is going to be even more conservative as pediatricians and pediatric ICU specialists. I think we will likely wait for, as conclusive as possible data coming from the adult side, and then branch out into pediatrics.
I'm just going to add, there was a lot of interest in pediatric liver transplant with NRP in Ontario. So yesterday was an email from SickKids. They want to go ahead. But in London, we actually plan to expand NRP to adolescents of a large size. We have neurocritical care expertise there as well in Rishik Hassan, who's a pediatric neurointensivist with expertise in neuromonitoring. So using the same technology in larger children as the first step towards extending it to pediatrics.
Okay, great. I want to thank the panelists and everyone who spoke today for all your great talks, but also just recognizing that so many people in this room and online at home have contributed to the work that's gone into everything that's happening across Canada. Dan, thank you so much for your experience in the UK, but I think there's still so much that we're interested in, need to learn, need to develop, need to collaborate on so that we can have a more unified approach to ensure that the outcomes are successful so that we can continue to build that trust and ensure that this therapy can be applied, increase the donations for our patients, but also I hope that next year we can be talking about some of the outcomes of the studies that are currently underway and really be solidifying how we can provide NRP across Canada. So thank you, everyone. So next we do have a break. We'll come back together in the room at 11 o'clock, but please do visit the exhibitioners because they will be giving out tickets again for door prizes at the end of the day.
I mean, you can leave it if you want. Yeah.
Can you double check James's talk?
they need constant maintenance. I've always had a knack for fixing and repairing broken things. I've always looked at objects and seen how to improve and repair them, never considering that one day I'd be the one that needed repairing. I took for granted that my life was status quo, and it was humbling to see.
Test, test, test.
Using a monorail
Just going to do it a bunch of times. Okay, everybody, welcome back. I hope everyone got some caffeine to keep us going into this next session. So the next session until lunch is really going to be focused on transplantation. So we've kind of done the death and dying journey. We've talked about kind of post-mortem organ salvage, and now we're going to really focus in on the advancements that are kind of up and coming in transplantation. So first up, we have James Lan. He's the director of the HLA laboratory in Vancouver and a transplant nephrologist here at Vancouver General.
Okay. Hi, everyone. Thank you for the organizing committee to invite me for the talk today. I just want to say from the outset that I'm presenting on behalf of the Genome Canada Transplant Consortium, a large group of investigators working on the project I'll describe today. Here's my disclosure slide. So I know not everybody here wakes up thinking about kidney transplantation, so I just want to provide some background for context, because that's what we think about in our team when we wake up. Kidney disease affects 1 in 10 Canadians, and there's over 50,000 Canadians now with end-stage kidney disease. We think about cancer mortality all the time, but the reality is that for patients on dialysis, the mortality is over 50% over 5 years. And it costs the healthcare system a lot of dollars, over $2 billion annually. I think kidney transplant is unique that it's one of the few therapies that gives mortality and quality of life benefits. And we want to tell the government this all the time, that every transplant that we do for kidney transplants will save the system $250,000 over 5 years compared to hemodialysis. And I think the last statistic here on this slide is really special when it comes to BC. It's one of the few places that I know of where more patients with end-stage kidney disease are treated with a kidney transplant compared to staying on dialysis. But what's the problem that we have to tackle is rejection. 25% of the kidneys will fail in 10 years, and rejection is the leading cause of graft loss. So as we transplant more patients, it makes sense that we understand what's causing graft loss and how can we counteract this. And what we do know is that the majority of rejection are due to antibody-mediated rejection. And this problem is so difficult to treat. All the therapies we have to date have not been effective. That about 7 years ago, we were able to get a large grant to form something that's really revolutionary, to take leaders in clinical transplant, laboratory sciences, laboratories, legal experts to come together to form this, what we call a Genome Canada Transplant Consortium. And the goal of the project is to come up with something that's completely novel that can address the unmet challenge of antibody-mediated rejection. So to do this, we went back to the old days, the first kidney transplant, which was done between identical twins. Because back then there was no immunosuppressant, and yet the transplant worked. And that is because the immune system detected the foreign kidney donor as the same as self, so there was no rejection. And over the years, we found that the immune targets of rejection really are not the entire protein molecules of the HLA, but these very discrete amino acids that you see on the right, on the surface of the molecules that incite the immune response. So the first hypothesis that we have is, can we use this type of analysis, what we call molecular mismatch analysis, to identify patients who are at risk of rejection? And to do this, Jenny Tran and others on the team analyzed the biopsy data of over 1,000 patients in BC who underwent a kidney transplant between 2018 to 2021. This manuscript is just under review. And what we found was that this is indeed true. As you see in the green dotted line and the blue line, patients who have a low burden of amino acid mismatches on the surface residue of these molecules, immune molecules, HLA, they had a very low risk of rejection. And the ones that had a lot of mismatches, then they would have a much higher risk for acute rejection. The next question that we had was, well, as clinicians, if we know this information, can we use it to guide the choice of immunosuppressive therapy? Is this something that we can use to change practice? And the answer is that, yes, we can. What you see on the left-hand side, the first observation was that patients who have low degree of mismatch it didn't seem to really matter what type of intensity of immunosuppression they received. Even when they were low intensity, they had an extremely low risk of rejection compared to patients that had a high burden of immunosuppressant. But the story is not the same for patients with high burden of mismatches, as you see on the right. There's a greater risk, depends on the intensity of immunosuppressant that patients get, that modulates the risk of rejection. And so if we take patients who are having high eplin mismatch, high molecular mismatch, and we give them the stronger immunosuppressant, the number needed to treat to prevent one rejection is only 10. So having that information on the right helps clinicians choose the type of immunosuppressant that they deliver to patients. So all this stuff is kind of retrospective analysis. The next question that we had was, well, is precision medicine just research, or can we actually do something about this? And if we want to do something about it, what would be the workflow that we would do? Well, the first step is you have a donor and you have a patient. What we would then have to do is to sequence the patient and donor using a sequencer like you see there, and to derive what we call a high resolution typing. Then we take that typing and convert the sequence into 3D conformation protein and analyze the differences between the two in terms of the number of mismatches. And then we give that information back to the clinician so they can use it to alter their and tailor and customize their immunosuppressive therapy. The issue that you see is that sequencer, although it's state of the art for many centers, it takes many days to get the results back. And as we all know in organ transplantation, we don't have a lot of time. We're talking a few hours. And the revolution came when there's a new technology that came called the nanopore sequencer. This is a very portable sequencer. I have one here, it's smaller than the iPhone, but you can really just open it up, put a patient sample in, connect it to your laptop of choice, and start to get real-time sequencing. That really reduces the time to analyze the sequencing data on the patients and also the donors. So when a deceased donor comes up, then we can put it into this technology and get real-time typing back within a few hours and to do the analysis. Our lab is just around the corner, but it doesn't fit all of you. So I thought that we would bring the lab to you. First, I want to describe that this validation of the new technology has been conducted by key members of our lab. The first one is Dr. Karen Sherwood, who's a co-director that brought the technology in. And our amazing team of technologists, including Brendan, who's our lead technologist, Amy is our senior technologist, and Franz, who's a director in training. And what we did is we analyzed this technology over many samples from blood-derived and also cheek-derived DNA and show concordance at 100%. How fast is technology? We actually had Franz to time the sequencing of actual donors that came up. And as you can see, Franz was able to get it down to less than 4 hours from beginning to the end. So let's see what this looks like in real time. So you can use it for one patient sample at a time, or you can line up all 5 sequencers all together and actually have real-time sequencing perpetually all 5 days of the week. So that was our first aim. And what we realized, and this is great for personalized immunosuppressant, but what we found out was that if you leave it up to chance, very few patients are going to be well matched. And what that means is that for those patients, their safety zone is very small. Either they're going to be under immunosuppressed or over immunosuppressed. And we have this constant struggle between the two sides as physicians. To change that, we figured we would have to go back to the allocation in the very beginning and really try to deliberately take every organ and see if we can match it to a patient on the waiting list that's a well-matched patient. And that is the next grant that we have, which is ongoing, is to prospectively match donors into patients so that everybody that we hope can derive a well-matched organ. And so these are the different institutions supporting this work. One of the concerns that we have that was brought up by patient partners is, well, can you actually do this? Can every donor be allocated to a well-matched candidate? And Jenny and the team here again did this analysis a few years ago using Canadian data that showed it doesn't matter what a waiting list pool size is. It can be very large, as in Ontario, or very small, as in some of the neighboring provinces, that most of the patients can still find a well-matched organ. The second question was, if you actually are prioritizing a kidney into a well-matched patient, are we going to introduce ethnic disparity in that process? And so that is a real concern that's been voiced many times. And so to do that analysis, Ross Doyle that you see in the first picture, he did an analysis using BC real-time data and found that ethnicity really did not determine whether patients could find a well-matched organ or not. So at least that would put some ease into this type of a strategy. The last piece I'll talk about is we talk about giving personalized immunosuppressant, matching people better, but after the transplant, can we monitor patients better as well too? My mentor, Paul Keong, is very fond of saying that it's like treating patients for high blood pressure, but they don't have a blood pressure cuff. And we have the same problem in immune diseases, is that there is no way non-invasively to track patients very well. So the last technology I'll discuss is called a cell-free DNA test. This is a picture of my wife. She hates this photo because she was pregnant at the time. She feels bloated. But it brings up what happened 10 years ago when we had our first child. At the time, my personal connection is that the non-invasive prenatal testing technology was not available. But I wanted to know the sex of our child. So I took blood from Danny, and I just put it in our lab so we can find out the sex of the child. And that is relevant because we know the fetal DNA gets released into the maternal blood and it can be picked up. That's how the technology works. And I did that for both our kids. Then we realized that you can use that technology for organ transplant as well, because it's almost like a fetal transplant with an organ, because the donor DNA gets carried inside the organ that's being translated into the patient. If there's injury to the organ, it gets released into the patient's blood and can be detected, as you see in the bottom, and that will precede the rise of the donor DNA will rise before the organ injury. The problem with that test is that it costs $4,000 for one test. It's completely cost prohibitive. So we were very fortunate to receive the funding from Genome Alberta and Genome BC to set up the test locally in BC and Alberta. The way to do this is that we're partnering with vendors to bring the technology into our lab so we can do it ourselves, reduce the cost and the turnaround time. So we are now just started on this project, and the hope is by the end of the year, we could have it clinically available for some patients. So in conclusion, real-time application of genomic technology can more precisely guide the selection of medications. We can use it also to minimize rejection through allocation policy change. And also, this entire approach, this is not the end. It's paving the way for us to go to the next frontier, which is to minimize medications and achieve tolerance. So I want to thank everyone for listening, and also the amazing team that supported all the work and all the institutions and funding agencies as well. Thank you.
Thank you so much. Do we have any questions from the audience? George?
Thanks, James, for a great talk. I'm going to still proceed with this question. I know it's a little bit off topic, but we struggle with some of the turnaround times for testing for some donors, and we lose potential donors because families just don't want to wait. You hear about the virtual cross-matching that takes place in other countries around the world. I think Spain is one of those, and again, forgive me if I'm speaking out of turn and not having a lot of the details, but they're able to go from decision to donate to donation quite quickly. yet we're not doing that in Canada routinely. What are your thoughts for even that population that we just don't have the time?
That's a great question, George. So what you're referring to is the need to do a final cross-match result prior to transplantation. And you are right that there's a debate going on. Do we need to do a physical test before surgeons implant the organ, or can we just go by virtual, whereby we forego that physical test and just go by the analysis of antibody against the donor typing? I can only speak for our lab in BC, is that the physical cross-match has not delayed an actual organ time to transplant. And the reason I say that is because most of the cross-matches for local donors will be completed well in advance of the organ retrieval. So it's not like the surgeons are waiting for the cross-match to get finished before they implant the organ. That is a consideration for import organs. We're waiting for the organ and the blood to arrive so we can proceed with the cross-match. For those type of scenario, we have moved now towards, in many cases, virtual cross-match to transplant as well. And I can do another hour lecture on the benefits of virtual versus physical cross-match, but the bottom line is that it can be done safely with virtual for the appropriate patient. And so when those import cases, they come up, we do discuss with the clinical team. If they do not want to wait, and it's a long call time, then we would go to the transplant based on virtual only. And that's worked well for the most part. Yeah.
Other questions?
Oh,
I'm going to use the mic. Excellent work and changes for especially the difficult to match and second time transplant candidates. With the changes that you guys are making to be able to, in 4 hours, look at what patients are actually, that are already transplanted, like what their risk burden is of rejection, do you see a change coming to be able to curtail medications in real time for patients? And those that are at a high risk of rejection, would those go into serial testing to try and bring down a medication to the low? I know the goal is the lowest level that you need, but like, how do you kind of see that playing out in reality as patients start to embark on this journey?
I think that's a great question. Yes, I do foresee changes to our clinical management based on the technologies that we have as we re-stratify patients better. The issue is when you have a high mismatch patient, then there's not a whole lot you can do at this point in time. There's still high mismatch. So what that means is that they have to get more immunosuppressant, and there's no other way around it at this point in time. For the low mismatch patients, then we know who they are now, and we can minimize immunosuppressant and monitor them in a different way. So I think that's very helpful. But I think at the end of the day, we do have to make some attempt to address how do we prevent patients getting a high mismatch organ in the first place. Because once they get it, at this point in time, we don't have a lot of wiggle room in our immunosuppressive management. Yeah.
Any other questions?
Thank you.
Okay, up next, we're going to continue on to kind of the same vein of, supporting patients after transplantation. Robbie Wright is a clinical pharmacy specialist and a PhD candidate who's going to be talking to us about, his experimental work on anti-rejection meds.
Good morning. Hi, everyone. Thank you to the organizing committee for allowing me to come and speak today. Like many of the other speakers, most of this work is not actually my own. I'm just here on behalf of my colleagues. So I have no real commercial or financial conflicts of interest. I'm a student. I'm struggling to get by day to day. But I do just want to let everyone know I'm a backup speaker. So my supervisor was actually who was supposed to be here today, but she was invited to the NIH this week, and you can't turn down those opportunities right now. So I'm here instead. So I hope by the end of today's session, everyone will be able to recognize, if you already don't recognize, the limitations of conventional immunosuppressive therapy. So thinking prednisone, tacrolimus, mycophenolate, that type of thing. And then I want to introduce you to the concept of chimeric antigen receptor regulatory T cell therapy, or CAR-Treg therapy. And I want to share with you our Made in BC CAR-Treg therapy that we're hoping one day we'll be able to give to transplant patients. So we've already talked about kidney and liver transplantation, so I'm going to talk to you a little bit about lung. So short-term survival post-lung transplantation has improved dramatically over the past 3 decades or so. So you can see in the 90s when lung transplantation first emerged as a real option for folks, 1-year survival was about 75%. And now consistently across the world, 1-year survival is expected to be greater than 90%. And unfortunately for me, this is not due to immunosuppression or the medications that we give patients. It's basically all due to the perioperative care that patients receive, as well as donors. And so really what we found is that while the short-term outcomes for patients have improved dramatically, we really haven't seen any changes to the long-term survival in lung transplant patients for about the last 20 years. So the last year of data we have from the International Society of Heart and Lung Transplantation is 2017. And as you can see, there's essentially been no improvement in long-term allograft survival. And this might not surprise many of you because we're still using medications that were developed in the 60s and 70s. And so I'm glad I changed the picture from that guy doing the tightrope, because that was this picture before. So in the context of lung transplantation anyways, post-transplant morbidity is primarily a result of immunosuppression-related complications, either rejection due to inadequate immunosuppression or medication toxicity like infection, cancer, diabetes, and kidney disease. And so what myself, some others might think is that turning off the immune system is probably the wrong approach. We tend to think of the immune system as just this single entity that is bad in the context of transplantation, and all of the medications we give folks really is bad for every type of immune cell. But we know that the immune system is actually designed to be tolerant towards foreign antigens, whether it be to food, to external stimuli, or the billions of bacteria that live in our bodies. Our immune system is naturally able to not attack those antigens. And this is primarily driven by a type of T cell called regulatory T cells, or Tregs. And we know that dysfunction in Tregs is associated with autoimmune disease like type 1 diabetes, lupus, and that is also associated with infectious complications like long COVID. So Tregs maybe were called suppressor T cells in your high school biology textbook. I don't think I knew about them until like 5 years ago. But basically they're a type of T cell that works to restrain inflammation throughout the body, both towards ourselves and towards non-harmful pathogens. And so they work in 3 primary ways. First, they inhibit antigen-presenting cells so that they're not able to either deliver the antigen, so in our case, the donor tissue, and they're not able to deliver co-stimulatory signals to cytotoxic T cells, which are the red ones. Tregs also inhibit cytotoxic T cells by starving them and competing with them for nutrients and activation signals. And finally, Tregs are actually able to convert other naive T cells into the good regulatory T cells. So they really kind of take a multimodal strategy to promote tolerance. Now, unfortunately, in the context of transplantation, the Tregs are really struggling, and that's because immunosuppressive drugs were developed before we knew that Tregs existed. And so our current arsenal of medications works very broadly and unfortunately affects all T cells by either starving them of their growth and activation signals like tacrolimus and cyclosporin, blocking DNA replication like mycophenolate, or like our big guns, just killing them off like ATG and alemtuzumab. And so we propose that we need to rethink our transplant immunotherapy strategies, and instead of turning off the immune system, maybe we just need to change the dial, turn up the volume on some types of cells and turn down the volume on others. And so this is where chimeric antigen receptor technology comes into play. So like many things in the transplant world, it's just borrowed from oncology. So CAR T-cell therapy is already used to treat certain types of blood cancers. And basically what CAR T-cell therapy is this kind of bespoke or designer T-cell where an artificial receptor that could be targeted against a type of cancer or a donor organ is inserted into the cell so that it acts against the tissue that you want it to. And so a few years ago, my supervisor and a grad student developed this HLA-A2 CAR Treg, which is a Treg that's designed to recognize a specific type of human antigen that's commonly mismatched in organ transplant recipients. And using a mouse model of graft versus host disease, they were able to show that if you basically gave mice a bone marrow transplant with these human immune cells, the A2 CAR Tregs could prevent the mouse from getting GVHD. Next, they tried it in a model of skin transplantation, which sounds like not very impressive, but skin transplant is actually a very robust model to study solid organ transplantation. And Antoine and Caroline were able to show that when you administered either saline or a CAR Treg targeted against a random antigen, the skin grafts became necrotic and fell off within about 5 to 10 days. But when you administered, so this is the irrelevant CAR. When you administered an A2 CAR, so one that recognizes the skin that you've grafted onto the mouse, it was able to protect the skin and keep it healthy for up to 3 weeks, basically. And just recently, so this was published last month with colleagues at the University of Chicago, we were able to show that A2 CAR Tregs can protect a mouse model of heart transplantation when they're combined with suboptimal immunosuppression. So you can see at the top, the gray circles, those are mice receiving maximal doses of immunosuppression. And if you gave them a reduced dose of less than half, combined with A2 CAR Tregs, we saw that about half of cardiac allografts were able to survive out beyond 60 days post-transplant. So now moving into the more exciting in-human trials. So the A2 CAR Treg that was designed here in BC is now being studied in a European multi-center clinical trial looking at A2 CAR Treg therapy in kidney transplant recipients. And so basically what they're doing is kidney transplant recipients are getting their standard induction, and then about 2 or 3 months post-transplant, they start weaning immunosuppression and infuse a single dose of A2 CAR Tregs with the goal of maintaining patients on low-dose tacrolimus monotherapy. And so results for this are not yet published, but we're really excited to see what they show. And lastly, it's really hard to generate Treg therapies because there's so few of them circulating in our blood. And transplant recipients or potential transplant recipients are often already unwell. And so it can be even harder to harvest enough T cells to give back to them. And so Dr. Levings and others recognize that the thymus, which is this organ in our chest, is a really rich source of Tregs. And when neonates get cardiac surgery, it's really bulky and in the way. And so it's actually routinely just discarded. And so they figured this was a really nice way to recycle a tissue that isn't otherwise being used. And so a baby who received a heart transplant in Spain a couple years ago actually was given thymic Tregs from themselves. And they were able to demonstrate that it is a feasible way to make this Treg product and that it was safe for the patient as well. So in conclusion, the future of immunomodulation after transplant might not be immunosuppression free, but I certainly think immunosuppression dose reduction is in the near future. And we're hoping that we can recycle this tissue that we've previously been wasting to develop off-the-shelf Tregs that are ready to go in the blood bank, just sitting in the freezer for when a patient needs them. But there are some additional challenges our lab is working on, like designing CAR Tregs that will be helpful for other patients with different HLA mismatches, and engineering CAR Tregs that could survive being in the setting of another immunosuppressive medication so they don't get killed off unintentionally. And so this is the whole lab who works on all that. So just shout out to them for all the hard work they do. Thank you.
Thanks, Robbie. That's really incredible work and exciting kind of future outcomes from this. Does anybody in the room have any questions?
Rob, I had a question about the infused CAR Tregs. What's the durability of those CAR Tregs? And do you foresee reinfusions will be required for these patients?
Sure, so that's a great question. So the durability of the CAR Tregs is actually very efficient. As long as their antigen is expressed, the Tregs will persist basically indefinitely. As long as we've seen that we've kept our mice alive, and we know from CAR T cell therapy in humans who have certain types of lymphoma, their CAR T cells are detectable like up to 10 years after infusion. Even after the cancer has theoretically been eliminated, there's probably some reservoir somewhere that's keeping the cells alive.
Any other questions? I just have a follow-up to that. You know, in terms of testing and maintenance that comes with, I think, all transplant recipients, what do you see and how do you see this kind of fitting into the regimen of that? Like, how often will people have to come in to get their levels checked, or is that something you could do at outpatient labs? Do you see this kind of provincially rolling out really nice, or is it something really specified that has to be done at a lab locally?
So right now, CAR T cell therapy in Canada is mostly, we ship the cells to the States, manufacture them at a company, and then they send them back to us. But different centers across Canada are building their own facilities that are able to manufacture these cells. And so I think probably manufacturing will remain kind of centralized in these quaternary centers, but certainly I think infusion could happen elsewhere. Thank you.
Thank you. Very exciting. Okay, up next, we're going to switch over to the heart. We have Nima Mogadam, who is a CICU physician here at VGH and an advanced heart failure and transplant cardiologist at St. Paul's. And he's going to be talking about mechanical bridging for the heart patients. I'm sorry.
Great. Thank you, everyone. Thank you for the event organizer for inviting me. So I'll just shift focus a little bit and, kind of focus a little bit about what we do before heart transplant. In a lot of cases, heart transplant, patients that come in are very sick, so we have to think about ways that we can bridge them to transplant safely, and most of the time it's with mechanical circulatory support. So this talk will kind of go over that. I have no relevant disclosures to this talk. So with everything, I just want to talk about a little bit of a history of mechanical circulatory support. The first successful implantation of a temporary MCS was performed many years ago in 1966 by the famous Dr. DeBakey. And the recipient was a 37-year-old female who had post-cardiotomy shock following an aortic valve replacement. And what he did is that, as you can see on the picture on your left-hand side, he used this external left ventricular assist circuit to provide mechanical circulatory support for this patient for 10 days post-surgery. And then in 1982 is where actually the first durable ventricular assist divided total artificial heart was implanted in human. This was a Jarvik 7. And as you can see, this was quite a huge device that was replaced the entire heart. They resected the ventricle, steered it to the atrium and the great vessels, and the patient, was connected to this huge console that weighed around 500 pounds outside of the body. And that's a picture of the patient. And the first patient actually survived up to 112 days with this device. and they subsequently did more of these devices, and the longest survivors was 620 days. And when we talk about mechanical circulatory support, we generally categorize them into two major kind of branches. The first is temporary support devices, which are used kind of for a finite period of time, usually days to weeks, until the patient gets to recovery or most of the time to definitive therapy, such as transplant. And the second is a durable support, where patients are actually can go home with these devices and they live on these devices for months to years until we get them to definitive therapy or transplant. So when should we think about bridging patients with mechanical circulatory supports? Again, in an acute setting, in our kind of ICUs, when a patient comes in with cardiogenic shock, we most of the time need a temporary support to stabilize and optimize them until we can have time to evaluate these patients for transplant or a durable VAD. And if they're kind of transplant candidate, then bridge them until they wait for an organ. But a lot of times, patients are not, transplant candidate up front. Either they have pulmonary hypertension that, kind of precludes them to getting a heart transplant up front, or they have other medical conditions such as obesity, uncontrolled diabetes, recent cancer, that you cannot safely transplant them. And then that's where LVAD or durable left ventricular assist devices come to bridge this patient to transplant until they become a candidate or until an organ becomes available. And in some cases, if someone comes in fulminant myocarditis, there's maybe a hope for recovery. So that's, you use LVAD as a bridge to recovery in these patients. So let's start with kind of reviewing the durable VADs and its evolution throughout the years. The first generation devices, on your kind of left-hand side were these large extracorporeal devices, kind of, pneumatic pulsatile devices with large console that was attached outside of the patient. And then subsequently, the second generation devices came in that provided more continuous flow devices. They were smaller, they had an axial flow, designed less moving parts, which kind of revolutionized the field of mechanical circulatory support. And now we kind of went to the third generation devices, which what we use are these smaller, totally device goes into the chest. It's all inside the chest. It's more centrifugal, smaller, and has bearing less kind of contact. So it's more suitable for long-term support. And the major breakthrough in the durable LVAD trials came in the early 2000s with the rematch trial. In this study, they kind of used a pulsatile flow LVAD device called HeartMate XVE, or from the Thoratec, and they compared it to optimal medical therapy. And the results showed significant survival benefit, improved at both 1 year and 2 years, with a number needed to treat of 4 patients. So these are advanced heart failure patients who eventually, most of them passed away. With these devices, 50% of them were able to live up to 1 year. But if you kind of look at the numbers again, 50% survival, so 50% did not make it with these devices beyond 1 year. And part of the problem was that there's a lot of adverse kind of events with these devices. There was a lot of pump thrombosis, there was lots of stroke, lots of bleeding and hemolysis. So that's why the continuous flow, the axial flow, continuous flow devices came along in the late 2000s. And the difference was that they used a rotor that worked as a propeller to generate non-pulsatile blood flow and were much smaller, more durable. Again, the device would sit in the patient's chest entirely and had fewer moving parts compared to the old pulsatile pumps. And in the HeartMate 2 trial that was kind of published in 2009, these continuous flow devices, when they compared it to pulsatile flow, the older generation one, is that it increased survival by 46%. And there was significant reduction in neurological events, stroke, and in hemolysis and bleeding with these devices. But there was still 40 to 50% incidence of hemolysis and bleeding with these devices, and particularly GI bleeding. So this led to the development of the next generation of magnetically levitated centrifugal pumps. And HeartMate 3 is the one that is on the market now, which we used previously was hardware, which it's out of commission now. But by using these magnetic levitation to suspend the rotor, these pumps does eliminate the mechanical contact with the blood. It reduces the wear, it reduces the hemolysis, it kind of provides a wider flow pathway, and it can generate up to 5 to 6 liters per minute of cardiac blood flow for the patient. And it has an intrinsic pulsatility device where the speed goes up and down, and this helps to kind of reduce the stasis of the blood and the incidence of pump thrombosis. And really, this has revolutionized our kind of management of patients with advanced heart failure until we can get them to transplant, or in many cases, not in British Columbia yet, as a destination therapy for our advanced heart failure patients. And this is data from the 2023 STS annual report, where they looked at 27,000 patients who had continuous flow LVADs, and they compared the newer generation of HeartMate 3 LVADs to the older generations. And what you can see is that the survival has been amazing. The 1-year survival with these devices are 86%, and 64% of patients are alive at 5 years. And if the patients, even in the younger patients, the survival is better, 92% are alive at 1 year. And even for patients who get it for destination therapy, these are patients more than 70. The 1-year survival is 78%, and more than half are alive at 5 years. And what has really the benefit of these devices is that low incidence of adverse events. Risk of stroke has gone down significantly. The risk of bleeding has gone down significantly. To be honest, risk of pump thrombosis, again, in the first few years of my practice and my training, I've never seen a pump thrombosis with HeartMate 3 device. Probably the most common complication that we see is usually driveline infections from that cord that comes out of the patients. And when we look at the survival of heart transplant following a durable LVAD support, 1-year survival is about 90% when a patient gets transplant after a HeartMate 3 LVAD. And this is nearly identical to patients who undergo transplant without a prior LVAD support. And this holds true regardless of the patient's age. As you can see in that middle graph, regardless if the patient is less than 60 and more than 60, the survival from transplant post an LVAD is pretty good. And there's this notion is that if you're on LVAD longer periods of time, then your survival is going to go, it's going to be worse if you get a transplant. And again, this was studied again, and they looked at patients who got LVAD 5 to 6, got transplant 5 to 6 years after being on LVAD therapy. And again, your 1-year mortality post heart transplant was not that different. Dr. Lan, I didn't include this, but when Dr. Line talked about immunology, kind of that one of the questions that always comes up is that if you put an LVAD in someone, there's another surgery, they're going to be sensitized. It's harder to get them an organ later, and that hasn't been shown to be true too. Although these patients are more sensitized at the time of transplant, the rates of rejection is lower, and actually when you remove that device, their PRA also goes down. But what we've seen in the recent years is that we've seen a shift away from using a durable LVADs as a bridge to transplant. And much of this shift that we've seen in North America is driven by the revision of the U.S. heart transplant allocation system, the UNIS system, which prioritizes transplanting patients who are on temporary mechanical circulatory support. Again, we do it a little bit different here in Canada and British Columbia, but I think one of the major other factors for this significant shift from durable to temporary MCS is that there has been significant advances in technology of temporary MCS that can support these patients for a good amount of time with less amount of complications. And there are many forms of different arrays of percutaneous temporary MCS options that supports predominantly the LV, like the old school intra-aortic balloon pump, Impellas, some that support the RV alone, like the Protect Duo RVAD, and some that supports BiV, such as ECMO. And in reality, the evidence for supporting one use of device compared to the other is lacking, but there might be some physiological reason when you choose one device over the other. Either, it depends on the amount of support you need, or how long you need the support, and the risk of vascular complications. And one of the most kind of oldest and still, I would say, the most commonly used temporary MCS device in our patients with advanced heart failure as a bridge is intra-aortic balloon pump, and it kind of provides hemodynamic support around 0.5 liters per minute of cardiac output. It helps both reduce preload and afterload. But despite its widespread use, the randomized trial have consistently shown that IBP, or intra-aortic balloon pump, does not improve outcomes or successful bridge to LVAD or heart transplant in advanced heart failure patient. Either they come in with a kind of an acute MI cardiogenic shock or with a heart failure cardiogenic shock population. So despite, again, lack of evidence, we still use it because it's very cheap.
The Impella system is placed percutaneously through the femoral artery using a monorail.
Oh, I don't know how I can, okay. Can I mute that, or let's see if I can mute that. Okay, let's mute. Okay, sorry, I forgot to remove the audio of that picture. But one of the temporary MCS kind of devices that has received most of the attention over the past, I would say, kind of a couple of years is percutaneous ventricular assist devices known as Impellas. And it comes in several models, but the most commonly used model, as you can see in this video, is the Impella CP, where the device is inserted by the femoral artery, crosses the aortic valve into the LV, and the inflow sits inside the LV, and the outflow sits in the aorta, and it provides continuous flow of cardiac output up to 3.5 liters per minute, and the patients are attached to this console that you see on the right-hand side. And it really kind of changed the game and, for management of patients with advanced heart failure. And really what kind of changed the platform here for use of Impella CP as our go-to device for mechanical circulatory supports in critically ill patients with cardiogenic shock was this recent publication of the Danger Shock trial last year, which looked at the Impella CP microaxial flow pump compared to standard medical therapy in 300 patients with acute MI cardiogenic shock. And they showed a 36% reduction in mortality up to 6 months. But I would say that Impella CP is rarely a device that I use for bridging patients to transplant, because the duration of support on Impella CP is usually short. If you kind of keep it in for too long, then you're going to run into problems with hemolysis, kidney injury, limb ischemia. The majority of the time, these are put in the cath lab when the patients are very sick. It's less favorable to bridge someone when they have a bed bound. There's kind of low chance of rehab with these devices. So it's great for acute setting, but rarely used to bridge patients to durable VADs or transplant. But what is a good device to kind of bridge these patients to LVAD or transplant? And this is the Impella 5.5, which I would say the most commonly used device in the world, in the US and Europe now, which offers much more flow than the Impella CP, up to 5.5 to 6 liters of flow. And, it can be put in. What's unique about it, through the axillary artery with a surgical cut down with a 21 French sheath, and the inflow goes into the LV cavity, the outflow is in the aorta, and it has a very low risk of hemolysis, low risk of thrombosis, and the good thing is that the patients are mobile. So again, if you're waiting a few weeks or a month for a donor organ to become available, these devices are really good so the patient can be mobile. And this is a patient during my fellowship, when I did it down in United States. Our CICU was full of patients who are waiting for a transplant on these devices, and they can walk around and be really mobile. And really, it's a game changer for bridging patients to transplant the Impella 5.5. This is data from the cardiogenic shock working group, and it looked at patients who underwent Impella 5.5 for cardiogenic shock, and we see 75% survival to discharge with these patients with these devices. And most of these patients went on to get a heart replacement therapy that is a durable LVAD or transplant. And when you compare it to other forms of devices, the rates of limb ischemia and bleeding are much low. So I would say, again, for patients with kind of advanced heart failure in hospital who are critically ill, as we try to bridge them to transplant LVAD, Impella 5.5 is now standard of care. We don't use it much in British Columbia. We have a couple in St. Paul's Hospital we've done, but every device costs $40,000 to $50,000. So it's going to be a huge burden on our healthcare system, but hopefully we can get more access to this. And lastly, another temporary MCS device that we use a lot in British Columbia here for transplant or durable VAD is a CentriMag, which is basically an extracorporeal centrifugal pump that provides full cardiac support. The device is surgically implanted with inflow and outflow cannulas connected to a central circulation, and the pump sits outside the body. And it can deliver a great amount of flow, up to 10 liters in patients. You can use it up to a couple of weeks, up to a month, as you're awaiting a suitable organ for your advanced heart failure patients to come. And there's low risk of hemolysis and thrombosis with these. And I'm just going to finish about outcomes to bridge to transplant with temporary MCS. I would say the outcomes are excellent with percutaneous and temporary MCS for transplant. And when I say percutaneous, MCS, I'm mostly talking about these Impella devices. I'm not talking about ECMO. Transplant outcomes for patients coming off ECMO tend to be poor, and we all know that. But with these temporary MCS, really the game has changed as we bridge these patients to transplant. If you look at these recent data from ISHLT, you see that with temporary MCS, 1 month, 6 months, and 1 year survival post-heart transplant is similar compared to those patients who actually didn't have an MCS bridge or those patients who had durable LVAD. And rates of adverse outcomes like needing dialysis post-transplant are actually similar. So these devices really are safe to use and have expanded our ability to care for these patients until they get to transplant. So with that, I want to thank everyone. To get any questions.
Thank you, Niva. Do we have any questions in the audience? Yeah.
Thanks for a great talk and some fascinating data. In the UK, we saw a reduction in the use of LVADs as we introduced the cardiac transplantation after DCD program. And that's both a sort of blessing and a curse. Obviously, we were good to be rid of those and probably much better for the patients, but it does pressurize the transplantation list because obviously those patients are less stable on it. Do you think these devices maybe begin to reverse those sorts of decisions?
Yeah, I think that's absolutely correct. Again, unfortunately, we don't do DCT heart transplant here. Hopefully, we'll get to there soon. But again, I always say these devices are great. But if you can get someone to transplant, it's ideal. It's kind of one surgery, and you can avoid these devices. But again, part of the thing is the temporary MCS are getting much better. So a lot of time, if you can get these patients a couple of weeks on these devices until you get a suitable organ, that's favorable. And I think when your donor pool increases with DCD, that's probably less likely you want to reach out for durable VADs. In reality, again, in Canada, at BC that hasn't happened, but majority of the devices that are put in, the durable LVADs that are put in the world are for destination therapy. I would say 70% of devices that are LVAD or LVADs that are put in for destination therapy. It's very uncommon you put in for bridge to transplant. Usually you do it for bridge to candidacy. Someone is obese, you want them to lose weight. For bridge to transplant has actually fallen because now patients get transplant. There's increased donors and better temporary devices. Yeah.
Wonderful. Thank you. Okay, up next we have Dr. Dal Chahal. He is a gastroenterologist and transplant hepatologist here at BGH, and he's going to be bringing it back to the liver again.
I think you have notes as well, right? Oh yeah, yes. You can do the presentation. Yeah. I'll just turn the presenter notes on here. So you can see them now. Yeah, okay, perfect. Okay, thank you, everybody. Very humbling to speak after everybody else who has spoken here. I'm a transplant hepatologist here, but I hope that some of the concepts presented here can show us how we can maybe bridge donation and transplantation research. So just a brief outline. I'm going to talk about hepatic ischemia reperfusion injury, just a brief overview. I'm going to talk about IRI in transplant and specifically DCD and how it might drive some DCD complications in liver transplantation. I'm going to talk about warm ischemic time and some of the definitions that are used and how they differ throughout the world. And this concept of quantifying warm ischemia better, and then highlighting some of the work that's being done here in conjunction with other groups, specifically the ICU group with Dr. Sikon, and how that might be expanded upon. So ischemia reperfusion injury, whether it's in transplantation or any other disease entity, is essentially tissue damage caused when blood flow to a tissue is restored after a period of ischemia or hypoxia. I really like how this particular review paper conceptualizes this. The ischemia is described as sort of a loading shot, so a period where a pro-inflammatory or a pro-damage sort of milieu is constructed. And then the reperfusion, the restoration of blood flow introduces neutrophils and other things and drives that, right? And again, from a molecular standpoint, it kind of proceeds through this pathway in the liver, right? So in the liver, you will get some liver cell damage during ischemia. Presumably, this primes the liver for damage and this accumulation of pro-inflammatory elements, what is described as a sterile inflammation. And reperfusion will reintroduce neutrophils, other mechanisms, other elements driving cell necrosis, and further inflammation via release of cytokines, damage-associated molecular patterns, and reactive oxygen species. And from a pharmacologic standpoint, it's interesting because there's several drivers of this pathway that actually have readily available pharmacotherapeutics present, but we don't use those, or they haven't been tested, actually. In the context of liver transplantation, ischemia reperfusion injury is thought really to be the driver of complications. And I know there was a whole session on NRP, and NRP is really, one of the goals of NRP is to reduce this injury and reduce the complications associated that are driven by this injury, right? So you can have early mild complications, such as just an elevation in your liver enzymes, what we can classically describe as early allograft dysfunction, jaundice, coagulopathy, surgical complications, right? Bile leaks, etc. And then just primary non-function of the graft. It just doesn't work at all. It needs a retransplant. And then the main complication that we see as hepatologists in the long term is ischemic cholangiopathy, which essentially drives the need for retransplantation. Complication rates can occur in both NDD or commonly called DBD donors, brain death donors, but they are higher in donation after circulatory death, or what we call in Canada DCC. This is a study from the UK, I believe, of about 4,000 patients from January 1st, 2008 to 2015, demonstrating reduced survival after liver transplant if you get a DCD graft as opposed to a DBD graft. This has narrowed significantly, but we think this reduced survival back then was driven by these issues. In British Columbia, we do have some older data from 2011 to 2015 of 300 transplants, 50 of which were DCD. The survival rate, the graft survival rate, was actually essentially equivalent between the two. The DCD had higher complications, right? Higher bile leak, higher ischemic cholangiopathy. And if a patient were to develop ischemic cholangiopathy, which is, I guess I should just describe, it's a malformation of the bile ducts, right, driven by an ischemic injury at the time of transplant in the long term, that was a significant risk factor for retransplantation. And we are working on updating this data, given that surgical techniques and everything else have changed over time. We think that DCD grafts are more prone to ischemia reperfusion injury and complications because of this additional component of warm ischemic time. Warm ischemic time happens at various times during DCD donation. It can happen during withdrawal of life-sustaining measures in the donor. It can also happen at time of surgical reimplantation. This is a figure that sort of describes this aspect. We're really focused right now, at least on some of the work that we're doing, on donor warm ischemic time. And if you want to define it, that's the time where total donor warm ischemia time is when withdrawal is initiated, and it goes until cold perfusion, and it can be actually separated into several different phases. This is a figure from the ILTS DCD sort of consensus conference, where it shows varying definitions of donor warm ischemia time. So you can see at the top, there's the total donor warm ischemia time. This can be separated into agonal and asystolic. Agonal is from withdrawal of treatment to circulatory arrest, and asystolic is from circulatory arrest to start of cold perfusion. Now, commonly in most surgical centers, the start of warm ischemia time for procurement is defined as when you hit a certain threshold of oxygenation or blood pressure. And these are called hypoxic functional donor warm ischemia time or hypotensive functional. Now, there is some disagreement between those two, which I will talk about later, but different surgical centers will use different starting times for warm ischemia. If we think about this conceptual framework in the context of liver transplantation, DCD liver transplantation, I like to think of that donor warm ischemia time as the loading phase and the recipient implantation as the firing phase, right? So the longer that ischemic burden in donor warm ischemia, the more damage presumably you will get, accounting for various donor and recipient factors as well. Again, warm ischemia measurement is varied. It depends on center protocol. Most centers will use a certain systolic blood pressure or oxygenation measurement as the start time for warm ischemia. In general, these studies are based on retrospective cohort studies, expert consensus, rather than, let's say, physiologic studies of liver function and liver oxygenation. In liver transplantation, again, specific limits will depend on center, but about 30 minutes of donor warm ischemia time is the cutoff for whether a graft can be used or not. And this will change with NRP and things like that as things evolve. So that has to be taken into context. And a wide variety of methods have been used. So in that consensus document, they basically gathered all the different modalities of warm ischemia measurement. There's centers that do it by systolic blood pressure, by diastolic blood pressure, by MAP, by SpO2. Some actually factor in the trajectory of the hemodynamics. And then there's some more research-oriented efforts looking at quantifying the area under a curve of systolic blood pressure oxygenation in an attempt to really quantify the total ischemic damage that a particular graft has experienced during the withdrawal of life-sustaining measures. The outcomes are also very varied, right? So depending on which study you look at, which center you look at, there seems to be not that much agreement between using certain thresholds and tracking recipient outcomes in terms of graft failure, graft loss, ischemic cholangiopathy, et cetera. And this is really an area that, can be debated whether it needs more study in the context of NRP, but it is there's a lot of disagreement here in the literature. Another aspect of warm ischemia is, despite our use of time limits, we know that individual donor hemodynamic and oxygenation trajectories differ extensively, and there's presumably little correlation between those trajectories of oxygenation and hemodynamics, even within the same patient, right? And as such, the time from when a certain threshold is reached to the point where, asystole occurs or what have you, we don't know if that's really the only predictor of the total ischemic insult a particular organ has experienced by the time that procurement is about to occur. There's this interesting study from 2016 that it sort of split patients, donors, into 3 hemodynamic trajectories. So they measure the hemodynamic trajectory and the oxygenation trajectory during withdrawal of life-sustaining measures. And they found sort of 3 clusters: those that stay steady for a while, then decline, those that decline slowly and gradually, and those that decline quite quickly to the point of declaring that a patient has passed away and the procurement can begin. They found that the organs coming from the cluster 2, the slow, gradual decline, predicted worse clinical outcomes in recipients. Why that is, we don't know, but there's some suggestion in the discussion that perhaps these particular grafts experienced more ischemia. So I think probably Mip and Jordan talked yesterday a lot about the Evaluate cohort and all the work that they've been doing with that. And one of the sort of additional data points that they've been able to gather with that is evaluating the hemodynamic trajectory of these patients as they undergo withdrawal of life-sustaining measures. So like very detailed physiologic measurements. And these are data from that cohort, right? And these are the actual physiologic trajectories of those patients over the course of withdrawal. And we've shaded in the limit. So I think this is a map of 50 approximately. That's the physiologic threshold we've defined for this particular data as the threshold limit. And so you can kind of see how much time is spent under that threshold limit and what the variability is. And there's some interesting data here, right? So in the top left, the actual time from when they hit that threshold down to when asystole occurred at the end is actually very rapid, right? Even though the timer for warm ischemia, I don't know if it was for sure, I'd have to go back and look at the data, may have been actually started sometime before that. And then in some contexts, if that timing, if it was started and then the timing was greater than 30 minutes, but they actually went above that threshold again, that graft would not have been procured perhaps because they timed out. This is data sort of correlating the individual trajectories in each patient from that cohort, depending on if you look at SpO2 or MAP as the start time. And the boxes are where they correlate well, which is all the SpO2 measurements, but the MAP and the SpO2 measurements don't really correlate that well. So that area that I've highlighted on the prior, if you measure it with an oxygenation threshold versus a blood pressure threshold, even in the same patient, that area probably will not be the same. So that's kind of interesting for donation and procurement purposes. And then one of the other things we've done is, or we started to do, because as a hepatologist, we have access to all the post-transplant data. So we have about 3 or 4 patients from that cohort that actually, from that physiologic cohort where we have the physiologic data, that actually donated their liver and has been transplanted. And now we can actually link all that physiologic data with various measures of organ function after transplant in the recipient. So we can now track their ALT, AST, their liver function, and then in the longer term periods of rejection, ischemic cholangiopathy, et cetera. I have not commented on NRP. NRP will certainly change everything here. Other perfusion modalities will as well. But at least from a scientific standpoint, it could even be an additional endpoint where we track the physiologic data, then a graft goes to NRP, and the graft's function can be measured during that process as well. I'd like to acknowledge Dr. Seacon, Jordan, Rebecca, Sophie, Laura, the liver transplant team, liver transplant program, VCHRI, Michael Smith for funding. This work is just starting, so I hope it sort of provokes further discussion. Thank you.
Thank you very much. Okay, any questions in the room? Sam, yeah.
Yeah, thanks a lot for that talk and helping us understand ischemic cholangiopathy. Given the majority of deceased donors have hypoxic ischemic injury post-resuscitated cardiac arrest, meaning they've already received a whole body hypoxic ischemic hit. If you stratify the outcomes based on the cause of brain injury, does it make a difference? Because there's some literature that suggests if you already have a hypoxic ischemic hit, in fact, it protects you, versus this would be a second hypoxic ischemic hit to the biliary tree and make the outcomes worse. Any insight?
From the literature, I cannot recall immediately what that, if there is outcome data. I'm sure there probably is, but I can't recall off the top. I know for our data, we do obviously track etiology of asystole in the context of DCD, so that is data we could evaluate further, but I can't recall right away off that.
Thank you. Okay, with that, we've wrapped up kind of our mid-morning, we're running late session. So thank you everyone for your patience. We have ordered a lot of lunch, so eat a lot of food. And then come back and join us, because in the afternoon, we're gonna shift our focus back to the patients and impacts on donors, patients, and patient families. Oh, also check out the exhibition hall as well, and get your tickets for our draw in the afternoon.
Do you mind if I introduce you?
Yeah, sure.
Is that okay? I'm not going to, I'm just going to freestyle it. Is that okay?
Totally fine.
Okay. All right.
I'm glad. Hopefully everybody got some lunch in. I had to head out for a little bit because the hangover is real. But I got an Advil, I got some water, and yeah, I'm ready to do it again, round 2. Okay, so it's my distinct pleasure to introduce Dr. Sarah Belga, who's a colleague, a clinician, a scientist. She's an infectious disease specialist with transplant training. So a transplant infectious disease physician here at Vancouver General Hospital. I don't know how you do your job because you essentially cover the whole province. And your work, I know, especially for recipients, is incredibly valuable and appreciated. She's going to talk to us about, now in this session, we're going to go into the recipient stories, but the recipient perspectives, and we're going to kick it off with this talk that really gets at one of the big fears of recipients. We heard about rejection, and now we're going to hear about those potential infectious complications.
Thank you very much, MIP, for the kind introduction, and also to the organizing committee for the invitation to present today. So without further ado, I'll get started on donor-derived infections. So first, I'd like to acknowledge that we are gathered today on the traditional territories of the Musqueam, the Squamish, and the Tsleil-Waututh peoples. These are my disclosures, but none are related to the content of this talk. So the objectives for today is to go over donor-derived infections with a specific focus on organ transplantation risks, timeline of these infections, and we'll mostly talk about unexpected pathogens since we have limited time. Okay, so I'll start off with a real-life case, slightly modified for confidentiality reasons. But the question I'd like to ask the audience is, should I accept this donor? So this was a 50-year-old man that initially presented with confusion, a GCS of 14 that rapidly evolved into a coma. He was later found to have a spontaneous intracranial hemorrhage in the dominant hemisphere attributed to hemorrhagic stroke. But the MRI showed some interesting findings that included enhancement of the leptomeninges, which raised the possibility of CNS vasculitis. And when I got called, this donor or potential donor had a fever 48 hours prior and had been started on IV acyclovir. So we'll come back to this case, but just something to think about of the challenges of evaluating for donor-derived infections. So a little bit of the Canadian perspective. So this is data from the Canadian Institute for Health Information from January to December 2023. And you can see that in that year, there was nearly 3,500 transplants, but there was an equal number of people still waiting on the list by the end of the year, and there were 216 patients that died waiting for an organ. So we all know that donors are scarce, but also it's important to understand that we're unable to test for all possible transmissible diseases. But reassuringly, unexpected disease transmission occurs in less than 1% of all solid organ transplants. And one of the main challenges for any ID physician is really the epidemiology of infectious pathogens is evolving and will always be evolving. And we learn a lot from COVID. We are continuing to learn about a number of other pathogens, including avian influenza. We've been seeing increasing numbers of MDR bacteria, particularly carbapenemase-producing organisms, and then emerging pathogens like Zika a few years ago, and ongoing outbreaks in endemic regions of yellow fever, and a novel virus that was recently described in Latin America called Oropouche virus. There hasn't been yet any reports of donor-derived transmission, but something that we'll be watching for. So I can't talk about donor-derived infections without talking about the timeline of donor-derived of all infections in solid organ transplant. It's a very busy slide, but I just wanted to illustrate that most donor-derived infections, and particularly those unexpected ones that I'll be talking about, tend to present early, so within the first month, but can also occur later, including beyond 6 months. So when we think of donor-derived infections, we must think of expected versus unexpected. Because expected infections is what we see on a daily basis. For example, you have a CMV donor positive recipient negative transplant, you know that CMV will result in a donor-derived infection, EBV, hepatitis C, among many other examples. The issue is really when unexpected infections occur. And this is a very long list of infections. So starting off with virus, from respiratory viruses like adenovirus, influenza, to less common virus like rabies and West Nile, a number of different fungi, with, of course, lung transplant recipients being at higher risk because of the organ being in contact with the outside, from Aspergillus to mucor to endemic fungi like histoplasma. And then a number of different bacteria, from multi-drug resistant bacteria to bacteria that are very difficult to treat or require multiple antimicrobials like Mycobacterium tuberculosis, nocardia, bacteria that don't grow on regular cultures. We have seen, for example, increasing numbers of syphilis, et cetera. So just to give you an idea of all the possibilities. And then ending with parasites, from malaria to toxoplasma to things like Balamuthia or Naegleria, which can cause amoebic encephalitis. So in terms of the epidemiology, I really like this slide. It is data from the US between 2008 and 2017, as reported by the Disease Transmission Advisory Committee, or DTAC. And this is the committee that examines potential disease transmission cases reported to the OPTN there. And you can see that the number of reports has increased, as have the numbers of transplant increased over the years. However, it is reassuring that the proven or probable donor transmission events that you can see here in black have remained relatively stable. So some more data from the US, and this is just kind of looking at all donor transmission events. And we must think that donor transmission events are not just infections, so malignancy is also a big part of this. And out of 1980, 577 were malignancy events, but the actual proven and probable numbers are much lower. When we look at infections, viruses and bacteria are by far the most common. And again, some of the same viruses I've mentioned, from very common to uncommon, like Eastern equine encephalitis, HHV8, West Nile, among others. And then in terms of bacteria, kind of along the same lines of what I had previously mentioned. And fungi are the third most common category. And this is followed by parasites and mycobacteria that includes non-tuberculous mycobacteria and TB as well. But again, when we look at proven probable, the numbers are much lower. And because in Transplant ID, we always have to remain humble, we have to be aware that unexpected things can happen. And I want to talk about this outbreak, which happened in our neighboring province in Alberta, but included also patients in BC, which was an outbreak of donor-derived Bartonella infection. And this involved 6 recipients from 11 seropositive donors with Bartonella henselae or Quintana. The majority were kidney transplant recipients, and the attack rate from seropositive donors was 12.5%. The most common presentation was skin nodules or papules that occurred at a median of 5.5 months post-transplant. So you can see the challenges of these infections might present later. A lot of times is because the initial presentation was quite vague, and this is a bacteria that doesn't grow on regular cultures. Now, switching gears a little bit, which is what in Transplant ID we're always very worried about, which is the donor with neurologic findings. And I wanted to show you this case that was published in JAMA more than 10 years ago, but an important one, is a 40-year-old man that presented with nausea, vomiting, and paresthesias, had recently returned from a fishing trip. In the emergency department, had fever, leukocytosis, and hyponatremia, and later on developed seizures, and unfortunately was declared brain dead 17 days after the onset of symptoms. This was presumed to have occurred from Chiguatera poisoning, which is a fish toxin, and organs were donated. They went ahead and did an autopsy, and the final conclusion was severe gastroenteritis, which I think this should raise a lot of questions. That a 4-year-old man, shouldn't really die from severe gastroenteritis. But anyway, I wouldn't be telling the story if what happened after wasn't, unfortunate but significant and important to be aware of. So the left kidney recipient, and I hope you can see the slide, I know you may not be able to see it very well, but presented around 20 days after transplant with some vague symptoms, right abdominal pain, hip pain, some diaphoresis, but then kind of developed fevers, was admitted to hospital, and then went on to develop bilateral lower extremity weakness, altered mental status with hemodynamic instability and hypersalivation, and ended up dying a few days, or ended up dying later of rabies encephalitis. And when they went back to the initial donor, it was confirmed to be rabies. However, even though this is obviously a very unfortunate case, the other 3 recipients were actually doing really well and had no symptoms whatsoever. And because this was identified in that recipient, all other 3 recipients were given post-exposure prophylaxis and survived. So this is why it's very important to recognize and report these concerns. Now, rabies is not the only one. I just wanted to show you some outbreaks that have been reported in the literature, and this is just a very small part. There's many more. But we talked about rabies. There's a second outbreak here reported, which is a different one. Unfortunately, this outbreak included 4 recipients and all died. There's also other viruses like lymphocytic or meningitis virus, and this included 8 recipients from 2 donors that presented with symptoms such as fever, respiratory failure, and the peri-incisional rash, which I thought was a very interesting one. But unfortunately, 7 out of 8 die within 72 days. And then they also report a new arenavirus that hadn't been identified, that involved 3 recipients from 1 donor that unfortunately also died of encephalitis within 6 weeks. And something that you might be more familiar with, which is West Nile virus. This was another cluster. This is, I believe this was from US, where 4 recipients had transmission. 1 had just a febrile illness, 3 had encephalitis, and unfortunately 2 out of 4 died. But one of the important things to mention is that most donors were reported to have died of intracranial hemorrhage or stroke. So even though these are concerns, not always, it's obvious when we're evaluating donors. So now going back to that question, should I accept this donor? So of note, when I got called, the donor or the patient didn't have a lumbar puncture, and we didn't really have a lot of time to pursue further investigations. It was felt that the decision had to be made immediately. And because I had major concerns with the uncertainty of the neurologic presentation and that CNS infection or encephalitis were moderately high in the differential, I decided not to accept a donor. But this kind of tells you how sometimes difficult it is to assess these donors. Now, when should we consider donor-derived infections? So like now on the recipient side of things. So whenever there's an unexplained illness post-transplant, we should always think about that, including mental status changes, particularly encephalitis, when there's persistent fevers that remain unexplained, or hepatitis that persists despite extensive workup. Although these tend to occur early post-transplant, and so we should definitely think about that within that time frame, we also have learned that other infections can present much later. Of course, anytime there's an infection or abnormality specific to the graft, because that's usually where these infections start. And of course, when there's more than 1 recipient from the same donor with similar clinical syndromes. Now, just to wrap things up, in terms of the summary of what I would like you to take home, is that organ donation is life is not without risks. We know that risk can be mitigated, but it cannot be abrogated. Fortunately, however, is that most donor-derived infections in solid organ transplant are expected, such as CMV, and only less than 1% are unexpected. And we must balance the risk of severe untreatable donor-derived infection against the mortality on the wait list. However, a lot of caution would be advised if you have a donor with unexplained febrile or neurologic illness or unknown cause of death. Of course, the epidemiology of infectious diseases will always be changing, and we know that geography and time matter. But importantly, when suspected, these donor-derived infections should be reported, and in BC should be to BC Transplant in order to trigger the appropriate investigations. That's all I had for today, and I'll be happy to answer any questions. Thank you.
Questions from the audience? I've got one. Since Sarah, since well, I don't want to get into politics, but since the politicization of vaccines and vaccine rates dropping off, and we're seeing the reemergence of microbes that may have been under control, not so much under control, like things like measles. What sort of risks do these present to your recipient patients now? Like, do they still have their immunity like lifelong from when they were kids, or are these sort of concerns and considerations that you're like top of mind now?
Yeah, great question. I'm not sure I can answer very quickly, but yeah, so measles is definitely a concern, and measles can be transmitted through organ donation. We know that measles infection leads to viremia, so any form of the virus in blood can be transmitted. So of course, this is why when we have someone with a febrile illness or sometimes even without a rash, it's important to evaluate that donor for that possibility. And if that donor has measles, without a doubt, wouldn't really accept that. But whether the recipient would be protected by just being immunized, I would not assume that, because we're about to just get rid of their immune system for a little bit. So I think if measles is a consideration in someone we're evaluating for organ donor, and we also must account for possibility of these donors receiving the vaccine because it's a live vaccine. And so viremia could occur as well. It's been reported up to 2 weeks, but the recommendation is to wait 4 weeks because of that potential. So it's a lot of things to take into account. This is why we have to evaluate the whole picture, and if there's uncertainty or concerns for measles, certainly would not proceed. But this applies to other potential vaccine preventable illnesses.
Great. Well, thank you so much, Sarah. Thank you. All right, so the next speaker is Dr. Suze Berkhout. So a little bit of history here. Susie and I went to, Susie and I went to medical school together. She's an MD, PhD, and we actually starred in a play together. It was good, actually. Yeah. But she's got a really unique perspective and a method to share the stories of recipients that I think you'll find very impactful. So, Suze.
Thanks so much, Mip. It really is wonderful to be back in Vancouver. So I'm a psychiatrist now practicing in Toronto, and I work out of UHN, where I have a program of research that uses arts-based methods to understand the invisible, the contested, and the unspoken experiences that happen in a lot of different complicated physical and mental health issues. And so transplant's one of those areas. And as Mip was saying, I did complete my MD PhD here at UBC. And so it's a pleasure to be back. And I thought I would express my gratitude to Mip for inviting me by sharing just a little, just a little bit. See if you can find him on this page. So thank you, Mip. It's a pleasure to be back in Vancouver. So I do want to also express my appreciation for this meeting as being hosted on the traditional and unceded the territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations. And the research I'm talking about has been carried out in Toronto or Tekronto, the traditional territories of the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, the Chippewa, and the Wendat people. And I work in collaboration with galleries, including Tangled Art and Disability. And I'll borrow from them just to say that part of working toward the complex concept of decolonization means being accountable to the systematic relationships that we all have with one another, whether those relationships are in medicine, in the arts, or beyond. I have some disclosures. This project, as you'll see, is I'm going to give you a snippet of the work that we've been doing, but it's been funded through the New Frontiers Research Fund, through SSHRC, the CDTRP, who you've heard a lot about the last couple days, the University of Toronto's Critical Digital Humanities Institute, and then I'm supported as well through the Department of Psychiatry. So I'm going to start off today with what I think is an uncontroversial but maybe still important sentiment, that transplantation is a transformational experience. But like a lot of transformations, there are these periods of uncertainty. There are longer lasting impacts on people's sense of themselves, how they relate to their loved ones and how their loved ones relate to them, and their expectations for the future. And it can be really easy to get caught up in the physical health issues, the blood tests, the scans, everything that's happening to someone's body, what they're expected to do, who they're expected to be in order to be a transplant patient. And it's easy to forget that this transformational experience impacts our emotional lives, our relationships, and our communities. And so some of the work that I do clinically and in research tries to explore those experiences. And so there are I should go back one sec. What you also see here in the background of this slide is a piece of textile artwork by lung transplant recipient and artist Dominic Quigliozzi. And I've been fortunate to work with Dominic over the past year and a bit in the role that I have leading arts-based research. And this piece, and you'll see a little bit more of it later, is part of a series called Transformations. The work combines textiles that we sent Dominic from our hospital, so linens, fabrics, patient gowns, along with felted moving blankets and Dominic's what he called his failed paintings. So those paintings that never made it into a show, never got sold, they were sort of in the back of a closet. And as beautiful as the piece is, and you sort of see from a distance this very hopeful metaphor of the butterfly, when you move in close, what you see are the sutures, you see the connections, the markings, you see the fabric of the gown, the hospital gown, layered with the failed paintings. And what you get are the sense of complexity, the gesture of loss and of failure. You get the complexity of what is home, where is home, and the messiness of being a person with chronic sickness. And so this piece of work also sort of helps us sort of situate some of the things I'm going to talk about today. And as I said, the theme of my talk is unspeakability, and that's sort of a motif in the research that I do. And the other image you see here, which probably looks a little bit like a liver, is part of a painting that came as a prompt. And it was an image in an art workshop where the group we were working with was exploring emotional complexity in relation to the complications that can happen after transplant. So serious adverse events and complications. And the prompt that we gave people was, this is what I can say, this is what I can't say. And so within the art making, we were sort of exploring this theme of what you can say and what you can't say. And the question that we have is, what is it that makes some transplant experiences so unspeakable? And what the quote that you see, which is from a colleague who's a mental health nurse in transplant, and shout out to Nurses Week, our colleague said, a lot of patients will have a lot of feelings about everything they went through on the waiting list, everything they went through kind of getting diagnosed, where all those emotions and all that feeling get put on hold until they're well enough to actually feel it. And then they kind of crash through all those emotions post-transplant instead. And I think some of the things that we also heard yesterday were about the ways that there are some parallels too with the donation experience, and especially for donor families. And so I just wanted to hold a moment to sort of say these unspeakable experiences span the entire aspect of transplantation, but not just from waitlisting to post-transplant survivorship, which is what we've been studying, but also on the donation side. And there's something that importantly brings these things together. So I'm not going to get into it now. There's a lot of setup. How does arts research respond to this question and this challenge? I'm not going to explain too much about what arts research is, but you'll probably figure it out as we go. But what we want to be able to do is, like, how do we think about things and how do we think with things outside of the scores and the biomarkers and the indices, which tell some stories. They tell important stories, and I work very closely with scientists, physiologists, other folks who are telling important things through that data. But what do we miss, and how can the arts help us with that? So we'll give you a little bit of a background. And then you'll also see there's some postcards that you see in some of the slides. I brought a few of them. They're down at the front. So at the next break, please feel free to take some. But arts research, and the way that we would do it, is critical qualitative research. And it really gives us a different kind of knowledge. So critical qualitative research tries to understand processes, events, and relationships in the context of a social and cultural situation. So we're asking people to make sense of their experiences while also paying attention to the relationships between knowledge and power. So power shapes how people experience things, it shapes how they speak about these things. And so that's sort of also where arts research comes in. Because when you're doing qualitative research and arts research especially, you are doing an inductive kind of analysis that's generating very exploratory kinds of knowledge. It's much less likely to be instrumental or outcome-centered, and in the arts especially, it's incredibly emergent. There's no a priori hypothesis, there's no hypothesis testing. That's not the right model of knowledge for what it is that we're producing. And in a lot of ways, the aims are quite different. We might hear about symptoms. We might hear about ways that people engage in different kinds of day-to-day practices to try to reduce their symptoms. You might hear a lot of the creative ways that people try to live well post-transplant. But what we're really sort of focusing on also is meaning making, what that living well means, and the kind of existential experiences and in some cases existential recovery that's part of transplantation. And so I want to share with you a little bit of one kind of small sliver of this through where we've been doing work in digital storytelling. So digital storytelling is one mode that we've been working with to work with. We have a professional filmmaker who's a liver transplant recipient, as well as a couple of other professional filmmakers. And they were the mentors to groups of liver transplant recipients who were invited to work with our research team to share some part of their experience or tell a story about some part of their experience of their liver transplant. And we were looking at people who had had transplants a number of years out, so there's there's not as much data about long-term survivorship, especially in liver transplantation. And so we weren't sort of interested in the kind of like, we were interested in the further than the 1 year mark. And we wanted to, we did have an interest from a research standpoint in how people experience time, how they experience their bodies, how that changed over time with their transplant. And so we had different kinds of writing prompts. And this was all in the format of an online workshop where people could explore significant aspects of their experience. And they could also explore who they wanted to tell a story to. Who is the audience that we didn't set any parameters about this. So they were working with 3 filmmakers as mentors. The research team was also kind of part of all of this. We were watching and observing and documenting how they told the stories, what stories they told, what got edited out of the stories, how the audience was chosen. And this was a way to create a space for these very complex, layered, nonlinear narratives. And filmmaking is especially powerful as an artistic medium to be able to understand things like time, because unlike a static image or a static piece of even like mixed media, like the textile art that you saw, film moves in time as well. And you can do different things with the way that you work on the tempo, how you do different sort of points of view, how you shoot, how you edit, to be able to understand time. So as researchers, we're exploring this visual medium and as well as the layers of sound and what's happening. And so as a form, it really embraces multiplicity, simultaneity, and we're studying that. And then people came into the workshops with their own reasons. So Marianne, you'll see her film. She said to us, I think that unless you've been knocked back that far and had to climb back up that hill, pushing the rock, you can't know the journey. You can empathize with it, but you can't know it. And that was one of her goals for creating her film, was to try to bring people in to what her journey was. And so we'll start to see some of the films now.
My personal model year is 1959, our home 1979, and my hobby car is 1972. They need constant maintenance. I've always had a knack for fixing and repairing broken things. I've always looked at objects and seen how to improve and repair them, never considering that one day I'd be the one that needed repairing. I took for granted that my life was status quo, and it was humbling to see my frailty, my mortality. It was amazing to discover how much I relied on people around me to survive. When I was diagnosed with liver disease some years ago, I wasn't sure of what to do to calm my mental state. I tried to deal with my failing health by continuing to work and rebuild and repair my car and home as my health would allow. Ironically, I received a call for donor parts for my wounded car at about the same time as I received a phone call from Toronto General about a possible donor. Someone, some family, had gifted me with what I so desperately needed, a second chance. Their unselfish sacrifice had given me hope, life. My work was not finished. I had things to do. I was needed.
Don't give up, we don't need much of anything. Don't give up, 'cause somewhere there's a place where we belong.
People were not giving up on me. How could I give up on myself? So many things came together magically in this one event for me to be renewed, rebuilt, reborn, May 14th, 2019.
Don't give up, please don't give up.
That was a film created by Mike Mora, a liver transplant recipient, who also later contributed as a peer mentor to the next rounds of digital storytelling work that we've done. And you hear in the film some of the ways that Mike is referencing some of the very common motifs of transplantation: a second chance, hope, being reborn. You can feel, I think, his gratitude. And at the same time, you also hear about the intense anxiety and the difficulty that came with waitlisting. You see visually the moving in and out of parts, replacing the engine parts of the car, which both showcases him as a person with passion and with hobbies, someone who's not just a MELD sodium score. And it also subtly plays at this idea of transplantation being just about swapping out parts, because he's showcasing this mechanical work, but he's also talking about this very tremendous transformation. And so there's a real juxtaposition there. The arc of the story is also about who I was then, who I am now, some of the struggle of liminality and the struggle of transformation, and while also offering something of himself in this much more holistic way. And then you also hear him speaking to interdependency and fragility, as well as a kind of tenaciousness of living, rather than say health as being just about restored autonomy. So there's a lot going on in this very short film. And as researchers, as what we've also learned through doing the work of digital storytelling is that people are often trading one set of complex conditions and issues for a different set of complex conditions and issues, some of which we heard about earlier today, talking about immune suppression. And all of this stuff exists alongside like hope, alongside fear, alongside despair. They're all together. And the complex medication regimens, physical side effects, the enormousness, the weight of responsibility of caring for a new organ that has come as this kind of tremendous gift. There's psychosocial and identity transformations that are all about how people reconfigure their lives in the aftermath of transplantation. So one of the things I also wanted to show you, you see these are anonymous visual field notes. So these are images that people have made when we've done things like public events where we've screened the films, and we left out art supplies, and anyone in the room who was there could draw, doodle, make notes, and they could give those to our project, which we have included, as well as our more traditional ethnographic field notes. And so what you see on the screen also captures something that you hear back in the films. These were anonymous notes, but you also see a lot of different kinds of things. So the colors, the formal qualities of the images, they reflect something of the complexity that was happening in the films as well. isolation, fear, that you sort of see that more prominently on the image on the left-hand side of the screen. But you also get this sort of vibrancy that sits alongside the loss. So the kind of the density of the colors and the brightness of the colors on that right-hand side of the screen. But then you also have these sort of motifs that reflect death. And so there's also this sort of fragility as well as the tenacity of life. That's sort of part of the stories that people were telling.
Did you know you would not return as you left today, leaving much behind? Loved ones' dreams of you walking through the door haunt nights of wonder, waiting, pining, not to be. But the painful swallow of time heals memories on many hearts and minds, knowing that what you left behind rises, gifted, shared, awaking, for a chance, so more to live.
That was a film by Marianne Klein, and it's a piece of narrative as well as visual poetry that she created in order to try to express something about the way that, as she would say, your soul changes in relation to transplantation. A letter to her donor, her story is intertwined with this very speculative embrace of her donor's story. And the visuals as well as the narration sort of fill the absence of the individual donor's life with this imagined futurity of the recipient. And when she starts off, did you know you would not return as you left? Is she talking to her donor or is she talking to herself? The intermingling of the two is incredibly prominent there. And so it toys with this conventional separation that we have structurally in the donation and transplantation world. The visuals also draw out those metaphors of transformation while holding sort of absence and presence as being very simultaneously unfolding together. I'm coming to the end of my time, but I did want to show a few more pieces of Dominic's work. And our team also engaged in a practice of creating pop-up galleries. So we were transforming spaces that were not typically these sort of self-reflexive dialogical spaces into something that was different and experimental. So some of the images you see are from the wall of the patient and family lounge at UHN on the transplant floor, and we were able to take that lounge and for a week change the lounge into an art gallery where we had Dominic's pieces featured as well as a number of other artworks that were made within the project. And then there's a tiny little picture that you can see where one of the butterflies is on a wooden board, and that is from a CDTRP conference where we were able to also kind of bring in the artwork to the scientific meeting and create a different kind of space and a different kind of set of discussions that were in conversation with the science that was being talked about at that meeting. And so this idea of being able to bring together all of these different emergent and experimental spaces, it sort of parallels the way in which transplantation is an innovative, emergent, and experimental scientific space. And so what I want to sort of propose to everyone is that artistic creation is also something that can help us understand different kinds of knowledge about transplantation that can sit alongside and help to inform and better inform ways of living well and what it means to be in the transplant space. So our project has many people. It's a collaboration across time, space, discipline, and practice. And there are many, many people to thank. So I'm here on behalf of our very large group. And I'd be happy to take questions and also have you reach out to hear more. Thank you.
Susie, that was really powerful. I really also wanted to thank you for showing the picture in the beginning of the presentation. Questions from the audience?
Thanks, Suze, again. We've been talking a little bit over the last couple days. It's been mentioned a number of times how the idea of silos in donation and transplant is a problem that lots of people have identified. And I'm just curious what your thoughts are and for the opportunity of what donor families and transplant recipients might co-create in this space. Because I know in my work, I certainly hear from recipients and donor families that completing the narrative of donation and transplant is something that is missing in a lot of cases and very meaningful.
Thanks, that's a really great question. Yes, and when we started out the work, I would say we were kind of attentive to certain sorts of silos. So the project was designed knowing that there were these silos on the recipient sort of side because we knew that my colleagues in consult liaison psychiatry, there was someone who did heart stuff, there was someone who does lung stuff, and the heart program shall not talk to the lung program except when they have to talk to each other occasionally. And the kidneys are their own thing. And they all have different tempos and they all have different people, except sometimes they don't. And so we were really interested in thinking, okay, let's not just do a study of heart transplantation. Let's not just do a study of kidney transplantation. Let's look at all of it. Let's also look at all of it from waitlisting to sort of long-term survivorship. And so that was sort of the way we came into thinking about it. And I think it was being in the project that actually then also became evident, very clear, that all of the sort of ways in which not just there's sort of the past in terms of people's own pasts and their health trajectories and how sickness and disability have landed them to become a transplant recipient, but then also how their futures were intertwined with other people's pasts, people, especially in deceased donation who had died, but also in living donation. There is sort of all of this kind of enfolding of past and future, and it blew apart the sort of things that we even thought we were thinking about, which I say at the time we thought we were very smart thinking about temporality and stuff in this way. And we really learned from participants about the ways that we hadn't even thought about the complexities. And so from a research standpoint, what I would say is the beauty of something like the New Frontiers program in the exploration stream is that it's high risk, high reward. And there weren't a lot of parameters on what we were doing. I mean, we had a proposal, we had a lot of things, but it was about creating this space to sort of follow what was happening. And that was the thing that was most exciting as a researcher, was to be able to sort of take what is going on in this place and then start to think about how do we follow this in some other way. And that was sort of what led then to engaging a different set of artists, for instance, in the next call for an artist in residence who was at a different stage of things and who was working in different kinds of ways. And so from those silos, to break them down, I think require us to be able to create these experimental spaces where different kinds of disciplines, different kinds of viewpoints can come together, and where we can follow that sort of thing. And that really, I think, does require a different way of thinking about research and a different way of thinking about how we do science too.
Thank you, Susan.
Thanks.
So building off what Susie was getting into in silos, we've heard those words a lot, and we have, talk about silos within our transplant and donation, but we're going to try to do something here with patient partners, where we're going to try to break down those silos too. And so if Jen and Mary, if you'd come up and have a seat at the panel, we're going to try to break down those silos by integrating donor family perspectives with recipients. And there's two recipients here today who are going to join us. Nick Cannon, you can come on up, as well as Christy Coldwell. They're briefly going to introduce their stories of transplantation, and then we're going to have a panel discussion about integrating those two perspectives that sort of form the gift of life. So I'll start with Nick.
Up here, Mitt?
Yeah.
Awesome. Hello, everybody. Thank you for having me. Nick Cannon, cystic fibrosis patient and double lung transplant recipient. It was actually exactly 6 years ago this month that I was on the second floor in ICU on ECMO and fighting for my life. I was, what I've been told, hours away from death. The wonderful team here, some of whom are actually in this room today, fought very, very hard, pushed the envelope for me, and as a result of that, I am here today. So there were, I'm sure, many who would have had the opinion that I probably should not have survived. I may not have been worth taking the risks that were taken. However, here I am today to prove that, less about proving certain people wrong, more about proving that people like me are worth the fight. And I'll get into what life looks like now. However, these photos will show you just how rough things were. On the left is when I was first placed on ECMO. In the middle is when they were trying to get me up and moving in the ICU. I remember this day perfectly. I had no control over my face, so my eyeballs felt like they were going to explode out of my head. And my mouth, this is one of the rare moments, it was actually closed. I was drooling. It felt like I was stripped of all dignity because unfortunately up here I was 100% alert. And sitting down for the first time, I remember swaying back and forth. I was completely deconditioned. And on the right is what my entire body looked like. It was basically bones. So pre-transplant, as I was aware of that, 2019 is when I got really sick. The 2 years leading up to it, I was gradually getting sicker and sicker until I hit a point of end-stage lung failure. I was placed on ECMO as a bridge to transplant while intubated, which I believe was at the time considered highly risky. And I had hemoptysis, near fatal hemoptysis leading up. I believe I had cardiac arrest, I was told not long ago, multiple strokes. It was everything you could throw at me is what happened. So as a result, I'm pretty memorable here, I think. And for good reasons, fortunately. So that was sort of the lead up to transplant. And just so I don't mess anything up here, just that one? Yeah. Awesome. So life now is fantastic. I have a wife, I have two kids, a 7-year-old and a 6-year-old. And again, thanks to this hospital, thanks to many of you in this room, I get to do what you're looking at up here, which is attend first days of school, attend birthdays, and just be a regular citizen of society. I'm fully at work. I've actually been at work full-time for 4 years. My transplant was 6 years ago. I actually, now versus the entire world caring for me, I get to care for individuals, which feels really good for me because I am one who has a lot of pride. And again, dignity for me is, I don't like people caring for me. So I know the day will come again, but for now I'm embracing these moments of giving back to those I love and care about. And, there's a couple things I'll reference. I'm trying to compress 6 years, actually 8 years, including pre-transplant illness, into 5 minutes. But there's a few things beyond, the traumas and everything we go through personally as patients. Some of the folks pictured here, as well as my parents, my siblings, anybody who had to be on the receiving side of that, I'd say fared worse than I did. I'd take going through what I went through again versus having to be on the observing and caring side of that. So for what that's worth to the group in here, the individuals, especially people like spouses and parents, do really feel the impacts of that for many months and years afterwards. And, grateful for them. It also plays a huge role in our recoveries. They're there when a lot of you can't be there because you're limited to minutes and multiple patients a day. So shout out to all of them as well. And if you do cross their paths in your care, definitely, do consider that. There's a lot of things behind the scenes we see at home that I think a lot of you wouldn't, and a lot of the PTSD that comes out of that. So all that to say, life is great now. What I would consider minor inconveniences compared to being laid out in the ICU and unable to walk are things like today I had a clinic day and you're working, you're busy, and I get the convenience to say, this is kind of annoying that I have to drive into the hospital and deal with a clinic day. So overall, life's good. I actually, in the 6 years, I just experienced my first hospital admission 2 weeks ago for what these wonderful kids on the screen probably brought home to me. And, and I was placed on IV fluids just because I was dehydrated. So there are a lot of considerations in a post-transplant world. We're not invincible. Sometimes I think I am, but I'm not. So I am reminded that I need to take a step back and focus on health and focus on just ensuring that I'm holding down what I need to in terms of my daily care and routine. But again, all that aside, I'm very grateful to be here today, and I'm grateful for everybody who plays a role directly or indirectly in advancing medicine, advancing research, and allowing people like me to not only survive, survivorship is okay, it's not great, but actually thrive. And the fact that I can walk in here on my own, the fact that I can speak, the fact that I can work and give back both in terms of just everyday citizen duties like working, but also in volunteering and giving back to the foundations that I work with, that means the world to me. So thank you all.
Awesome. Thanks, Sean. Hi, everyone. Amazing, Nick. Thank you for getting us started. I'm going to build a little bit on that. I do want to just say that I'm really honored to be part of this panel discussion alongside these remarkable individuals. And I know we're going to be talking a little bit more as things go. But for me, I have spent more than 2 decades of my life in our organ donation and transplant system. I have seen the good, the bad, and the ugly. I know firsthand the miracle that is organ donation, but I also know the tragic toll that post-transplant life can have on recipients as well as their families. So I was born with a congenital heart defect. It went undiagnosed until I was 7, but following my diagnosis, I was thrown into our healthcare system, undergoing various open heart surgeries, procedures, and pacemakers, before finally being told at 17 that I needed a new heart. And this meant that my mom and I, we had to pack up and leave the small town we lived in the interior for the very large and unfamiliar city of Toronto, as that's where I was listed for my heart at the hospital for sick children. Being listed for an organ transplant is really like entering a lottery for your life. I didn't know if I was going to receive my heart in time, or if I was going to die before I really got a chance to live. But I was incredibly fortunate in that I only waited 3.5 months for my new heart. But that period post-transplant, which really went up to at least about the 2-year mark, was really the hardest time in my entire life. I had never been so sick. I had bouts of rejection, infection. I suffered cardiac arrest a few days post-transplant, at which time the team had informed my mom that they weren't sure of the trauma that my heart and my donor had endured, and my prognosis was very guarded. But my story was not done being written, and I prevailed. And for the first time in my entire life, I knew what it was like to have a normal heartbeat. No more arrhythmias, no more tachycardias, just a normal heart beating in my chest. And that also meant I was able to go to sleep at night, and I didn't have to worry that I wasn't going to wake up in the morning. This August marks a significant milestone for me. It will be 25 years of life with my heart, the same heart, and that is huge. And in those 25 years of life, I have been able to do things that I dared dreamed would be possible when I was waiting, hoping, and praying for my miracle. I was able to graduate from university, I fell in love, got married, I currently foster little senior rescue dogs, and I continue to work on my to-do list, my bucket list, if you will, that I wrote when I was 17. And in that time, I have also seen how far we've come in transplant medicine, but I know all too well how far we still have yet to go. Transplant truly is a miraculous gift that not everyone gets to experience, but it can also be an incredibly difficult life. I have lost more friends than I care to count. Their bodies could not withstand the rigors of post-transplant life. And every day I take handfuls of toxic medication that, while keeping me alive, it is slowly killing me. And as recipients, I think we are so filled with gratitude, but we also have scars that cannot be seen. And that is very difficult. And even all these years later, a day doesn't pass that I don't think of my donor and their family. And I am in awe of the fact that my donor and I have walked through life together for nearly 25 years. I have had my donor's heart beating in my chest longer than I ever had the heart that I was born with. And that is something that even to this day, I still struggle to process. But it really is all that I have survived and all that I've experienced that's motivated me to become more engaged in this world, particularly the world of research. I'm fortunate to work at the Organ Donation and Transplant Research Foundation as senior advisor, and also to serve as a patient partner in various capacities. And I find this is absolutely critical to really bridge the divide between our more scientific world and that of the lived and living experiences of our patients, families, and our donors. Because the truth of the matter is, we are so incredibly thankful and really indebted to our clinicians, our physicians, and the scientists. But the matter remains, you have not walked in our shoes. You do not know what it is like to hold your breath for something as simple as a blood test, knowing it could change your life, or how difficult it is to battle crippling side effects of your medication just to get out of bed or off the couch, or how heavy the burden of the PTSD can be at times just to function a so-called normal life. And it really is sessions like the one that we have today, that we're having right now, that are so important because they really ground what we've heard the last 2 days in what matters the most. And that is our patients, our families, and our donors. But it's more than just me, and it's more than really any of us in this room. It's about the individuals who didn't get their organ, those individuals whose grafts failed prematurely, but most importantly, it's about the people and the patients of tomorrow, both our recipients and our donors, because they are counting on what it is that we're doing today, what we're learning, what we're discovering. And it's so important to appreciate and to respect the interconnectedness of the donation and the transplant worlds, because we cannot have one without the other. Without death, we do not have life. And that is something that as recipients, we are all too familiar with. But I will wrap there, and I will hand it back to Mip. Thanks, everyone.
Thank you, Christy. I liked In Sync better.
We have to talk.
So I'm going to kick start the questions off, if I may. And the first question is going to go to Jen and Mary. As donor families, what is your hope for the recipient of the gift of life that you've given?
Well, I think for me, it's hearing exactly what you both just described so eloquently, but also realistically. I think when I first thought of Mackenzie's heart beating somewhere else, and really that's what let me still live, is knowing that her heart was still beating somewhere else. I had a really rose-colored glasses idea of her swooping in and life was perfect for her recipient and you would never have anything else that you would ever have to worry about again because of the gift that she gave. And over time, I came to find that that was not at all the reality that you face. But I think that means part of her is living real life. And so maybe in those early months, I wanted to think about it through rose-colored glasses, but now I'm just thankful to imagine her heart and her liver and her kidneys, playing at the park and falling down and learning to ride a bike and maybe failing a test or having her first heartbreak or doing all of those things. So it's very much what you described.
Thank you both. Really need a box of Kleenex down here. Rick passed away and donated his kidney 6 months ago, so it's still pretty raw for me. But his journey, I don't know how long he's been on an organ donor list. It's been a lifetime for him because it's been part of his plan long before we met. So 6 months ago, we went through this journey, and he's, as some of you have heard, he decided to leave this world through MAID. So everything was planned for him. He's always going to be an organ donor. Throughout his life, he lived healthily, he exercised, he didn't do drugs, he drank very little because he wanted to protect as many organs as he could because he wanted to give. When he got sick with ALS and he decided that he's going to go, he's going to leave us through MAID. I was telling a lot of our friends here in the audience that his plan was to give, but the MAID part, for me as his spouse, is, yes, I would like for you to have this dream, to be able to leave your legacy, to be able to save somebody's life. But at the same time, he does have that final moment where he could say no. And selfishly, for me, I was hoping he would say no, because that just gives me a little bit more time with him. But on the other spectrum is we knew there are people hoping and waiting. But at the end, he made up his mind long time ago. He's going to go through this through with it, and then he went to the very end. And fortunately, he saved 2 lives with his kidneys. He would have loved to have had his heart, his lungs, and more things to be able to save more lives. Jan was saying she hasn't reached out. And I thought, oh, for sure, I want to meet the recipient. And now I'm like thinking, oh, what if it didn't work out? Then I'll be devastated. So it's really nice to hear success stories. It's really inspiring. And he's here looking down, happy that there is that chance that there are 2 people walking this earth for a long time. Thank you.
I'm going to open it up to the audience. I may ask one more prompting question to Nick and Christy. I similarly, we see people acutely post-transplant, and you do have these rose-colored glasses that everything goes swimmingly. But of course, that's not always the case, especially when you leave hospital. Can you convey to the audience, like, what are your fears? Like, what has a recipient?
Biggest fear immediately post-transplant is rejection. You hear about this big boogeyman that lurks, and you know it's going to happen. Everybody warns you that it is going to happen, and you live, many, many months and years post-transplant wondering when it's going to happen and how critical is it going to be. And the other 2 considerations, Christy touched on, one is the medication, and you need it because it's how you live, but then you're also recognizing that it's taking a toll on your body. And again, if I was to sum all the issues up in one, it's constantly worried about the clock that may be working against you, and that's a real consideration. And we're at a stage in our lives where I don't think things get more busy, more demanding, and we ourselves are in very high demand from family and work and so on. So it's unfortunately a constant boogeyman that lurks in the corner is what's coming next. And every time you do a test, Christy, you kept it very real, and I appreciate you for doing that. Every X-ray, every CT, every blood work, every spiro. Even when you feel perfect, you're going in there on the edge of your seat wondering, is this going to be one where something comes up? And unfortunately, we have access to a lot of info, and we're self-aware that there's a lot of things that could happen. We try not to focus on them, but they are real. So that's from my perspective. I don't let it consume me, but it is always there.
I think for me, I am terrified of losing my heart. I know it is going to happen. I know I am not likely to live the rest of my life without requiring another heart transplant. That, of course, being said, that something else doesn't take me before, like cancer or an infection. That's a very real reality in our world. And it's hard because I know that I shouldn't be here right now. I should have died 24 years ago. But I am here. And, right after my transplant, I saw my echo for the first time. I'm laying there and I'm looking at the screen, and I just started crying because here I was looking at my donor. Even though they're inside me, it was a different sort of scenario. I'm looking back at the screen, and there they are looking back at me. And it was overwhelming. And I've done everything I can to preserve my heart for as long as I can, but we have really forces that are always working against us. You've heard about it the last 2 days. And yes, we're learning more and we're getting further along, but not far enough, not quick enough. And I think that's one of my biggest ones is I know that day is going to come, and I've really prepared for the last 24 years that day will come. And I don't know how I will handle that. The heart transplant world, we can get the cardiac allograft vasculopathy very quickly. And there's not a lot you can do to slow that down once that starts. Retransplant is about the only option there. But of course, there's a lot to consider, around the health of your body, the rest of your organs. So it's a challenge. And I know Nick and I, we do all we can. But that's one of my biggest fears.
I'll open up to the audience. Alana, you have a question.
This is a question for Nick and Christy. Thanks so much for sharing your stories. Nick, I think you alluded to it, and Christy, you mentioned your mom. I wonder if you guys could comment on the role of family caregivers and how, that transition period immediately post-transplant after that first hospitalization, what supports did your families need? How was that for you as receiving that care? What would you like to say on their behalf to a group of people who do this work?
That is huge, and that is such an important question because it is so often overlooked. There really is no support for our caregivers or our loved ones. There's barely any for us. The mental health component is severely lacking, and for me, 24 years ago, it was non-existent. It was barely spoken of. And I know I saw with my mom, it was hard. We had to move. She had to take a year off work. She was a single mom. And then even when we returned home from Toronto, every 2 weeks we'd have to fly down to Vancouver, a 12-hour drive or 2-hour flight. And that became nearly impossible. But it was so much bigger than that. I would find her crying at times. And I'd ask her what was wrong, and she struggled to articulate it. She'd say, I'm still there. I'm still in the ICU. She could hear the beeping of the machine. She could smell the smells. And that never faded. I don't think it ever does. So she carried on because that's really the only option. But even now, with my husband, I know that it's challenging. And I think that the burden of our caregivers is so often overlooked. And really loving us and caring for us does come with added weight that isn't recognized. And I think for healthcare workers to understand how important that is, that they are an extension of us. And just as we are struggling, they are too. And to not forget them when it comes to caring for us and to extend that to them as well. And again, I know resources are limited, but even just having those moments, thinking of them when you're dealing with the patient as well is so important.
Beyond everything you said, Christy, which is, the emotional toll, both emotional, mental, and physical, honestly, they do, just looking at this, trying to apply it maybe more clinical, they do serve a very practical use for us in our recoveries and in our care. Again, everybody in here has, if you are a practitioner, you have minutes in a day to dedicate. There's a lot that was done for me to speed up my recovery, to get out of hospital and shorten my rehabilitation period and essentially get me back to as normal of a life as I could have. And a lot of that had to do with those loved ones and people who were in the hospital with me, supporting my rehab, supporting my physical rehab, but also mental, having somebody there talking to you, somebody there reassuring, somebody there coaching you through it all when you're as vulnerable as we are in that scenario, I strongly believe, does help get us out of hospital sooner and help us recover quicker. So there is, I don't know if that can be quantified scientifically, medically, but I can say with 100% certainty from my side, I don't know if I would have survived, and if I would have, I don't know if I'd be here without my family being there to support me and pick me up during that time. So, and then of course, there's lasting effects. There's also worries about being left in the dark, worries about maybe downplaying the care, or, is this loved one getting everything they need? So those are all very real worries as well.
Question right there with the Doritos bag.
It's not mine.
I work in the pediatric ICU at BC Children, so this question is more for Jen. Can you comment or talk about the decision for organ donation, especially when it seems like an unthinkable conversation for so many of our families?
Yeah, it's something that we spoke about in our family openly, and I think it actually goes back. I lost my mother-in-law to ALS 24 years ago, and she wasn't able to be a donor at the time. It was rural Nova Scotia. There was no ability to do it, and we often talked about how wonderful it would have been. And so we had always talked about it in the context of adults, and if that's, that's certainly what I would want. Our extended family all agreed that's what they would want. We never imagined it in the context of Mackenzie. But I think because we had contemplated it so much when the time came, and I spoke yesterday about how quickly I came to the acceptance of her prognosis. I still don't understand it, but I did. It was just a calm acceptance, and immediately following was, and of course she's going to be an organ donor. And it was never even, to be honest with you, a question. We had to advocate, actually, because the circumstances around her death were criminal. The medical examiner said no, that because her body was evidence. And we actually had to negotiate, the homicide detectives and the medical examiner and the social worker who was sort of advocating on our behalf as well, knowing how important it was for us. They came to, an agreement that she could donate anything but her eyes. So they had to be able to, the medical examiner needed to do his job too. But that took probably like 6 or 8 hours of negotiating with the medical examiner. So I don't know why it was just a given, and we felt so strongly about it, but we did.
Jordy?
Hey, yeah, thank you all. Really enjoyed all of your talks the last couple of days. I wonder if you guys could have any reflections or anything on what you have, or what it's meant to you, or what you've gained from like finding community with each other, between like donor families, like when you met your first transplant recipient that wasn't necessarily directly connected to you, or likewise for meeting donor families for the first time.
I'll go very quickly and then I'll hand the mic down. But I think in Sue's presentation, there was a comment about if you haven't walked the journey, and I'll destroy the quote, but if you haven't walked the journey, you can't understand it. You can empathize with it, but you can't understand it. And so whether it's from the recipient side or the donation side, I do think there's a connection in that sort of circle of life that you really can't understand unless you've walked it. So that is, I think, what means the most to me, and it's something I get to do with Mackenzie. I get to come here and spend some time with her.
Well, this is the first time for me, so thank you, MIP, and everybody here, because I hadn't even done an obituary for Rick. It's that new. But to be here and to half the stuff I've listened to went over my head, but the people and the brilliance, and I feel like Rick is here. And meeting, it's incredible, meeting survivors. So it's very inspiring. And I've spoken, there's so many people who came up to me and just really pushed me to be out more and represent my husband and his beliefs, and to try to give more through our experience. And like I said, this is my first time being in this environment, reading and hearing and meeting people who have expressed everything that they've gone through. And it just kind of sort of almost came full circle for me, because I was in a cocoon, still grieving. But I knew the importance of this, so it forced me to create my. I now have an obituary for Rick when I finally decide to somehow do some sort of celebration of life because of this exposure and because of this experience. And I'm definitely moving forward, inspired to try to give more, and if I'm asked, and I'll, so that's sort of where I'm coming from. So.
This is my first day actually hearing directly from the family of deceased donors. I've met 2 living donors in the past, so this is very new for me, and it brings peace. I haven't talked about it. However, a real struggle that Christy touched on, and I struggled with it a lot immediately post-transplant, was the thought of death. And yes, I have life. However, this person who I don't know, I feel very connected to not only them, but their family, and what are their families going through, which my family almost went through. And you can't help but sit in their shoes and view it from their side. And that, it's not good for the mind, but you can't help it. There's a mourning you feel, which I still feel now. It's not as intense, like, any mourning you learn to deal with it, but it was very intense post-transplant. So there's obviously that sort of guilt you feel. Am I making the most of my life? This was life given to me, and there's a bit of a debt you feel, but also hearing from you two, honestly, that you've found your peace through that. I hope and I pray that who it was that I've received life from, their families feeling the same, but that certainly brings me some inner peace. And again, this is my first time, honestly, hearing from deceased donors, so it means the world to me to hear from you both. So thank you for doing that. And I don't know how you're doing what you're doing, honestly, so very grateful for that.
I would say that the community that we have, it comes with benefits, but it also comes with a lot of challenges and additional loss. I don't know my donor. I wrote them and I never heard back, and that is okay. Because I feel that all recipients and all donors are so interconnected. It doesn't matter the specifics. Obviously, I don't know who my donor is. They're not here, but nevertheless, when I hear from Jennifer and I hear from Mary, it's hard. It is really hard. It's, like I said, it's been almost 25 years, but that is a piece that still gets me to this day. I always think of my donor and their family. Every holiday, every occasion, I think of them. I just wonder how they're doing. So there's that piece. And then there's the piece around the community with fellow recipients. I think it's been vital to healing, to understanding and connecting with people who have been down this road, who have gone through this journey. But as I mentioned, there's loss that comes with that. Not everyone is going to make it. Not everyone does. And I've lost very dear, dear friends. For a while there, I had to step away from this world because it got to be too much. I kept losing people. But I also have come full circle, and I realized that is the reality. And I want to do something to make it better. And that's the price you have to pay to be part of it. But it's worth it. Because rewriting this narrative, I think, is important.
That's an amazing note to perhaps wrap this panel up on with all 4 of your responses. My God, I don't think I had expectations for this, but if I did, that far exceeded anything I think we could have hoped for. So, Code Blue.
Second floor, ICU.
Oh.
Code Blue, Jim Patterson, second floor, ICU. Code Blue, Jim Patterson, second floor, ICU.
So I hope we can all Give you guys a real standing round of applause. Thank you so much. All right, we've got one more talk, and it's my real pleasure and honor to invite up Rachel Dory. Rachel is the co-chair of the board for what used to be called the Transplant Research Foundation, but they've changed their name, they've rebranded. Now they're called the Organ Donation and Transplant Research Foundation. She's got a very unique perspective that I think we'll all benefit from greatly. So, Rachel.
Thank you. Thank you, everyone, for being here, and thank you, Mick. Good. Great. On March 3rd, 2022, I became a living kidney donor when I donated directly to my husband, Nilo Edwards. The experience of becoming a living donor and watching the incredible transformation of Nilo post-transplant was one of the most profound experiences of my life. I walked away from our surgeries and our recovery knowing that I needed to be involved in the organ donation and transplant space in some capacity. In addition to joining the BC Transplant Volunteer Program, I also joined the board of the Organ Donation and Transplant Research Foundation of BC. And now, one of the more enjoyable tasks that I sometimes have with the ODTRF is writing congratulatory emails to teams, letting them know that their projects have been approved for funding. And it was roughly a year ago at this time that I was lying in bed in the Four Seasons Hotel in downtown Montreal writing one such email. And I was writing, I had, out the window to my right was the Leonard Cohen mural, and I was surrounded by more pillows than any one person could ever possibly want or need. And I was writing to this team, letting them know that their project entitled Characterizing the Cerebrovascular Physiology of Circulatory Death During Medical Assistance in Dying to Optimize Organ Donation Opportunities had been approved for funding. And as I was lying in luxury, hands excitedly typing, I never, in my wildest imagination, could have predicted that in just 7 short months, that man, my brilliant husband, would be the study's 3rd participant. And I would be widowed at 37, only 2.5 years after transplant. And so you may be asking yourself, why would anyone choose to be poked and prodded and have extra monitoring and people in a room at a time as sacred and powerful as one's own death? To understand why we chose to participate and why we cared so deeply about organ donation and transplant research, you need to understand our story. How Nilo ended up needing a transplant, why I chose to be the donor, and I don't know the next point. Yeah, you just need to know our story. And oh yes, and what life is like for us after transplant, which we just heard a little bit about. And so it is my hope that over the next 25 minutes that you will all gain a deeper understanding of both the patient and the caregiver experience, and that you will also walk away with a deeper understanding that your work matters. No matter where you fit into the organ donation, and the transplant process. You are changing lives. You are uplifting patients, their families, and their communities. And so let's dive in. 2018 started off like any normal year. Nilo, who was 31 at the time, was settling into his career and just starting to find his legs as a sought-after advisor on major project development in Canada. He spent roughly 200 nights a year on the road, crisscrossing our country and our many time zones on a weekly basis. He was always on the go, always sleep-deprived, but his enthusiasm and energy for the work never faltered. It was the end of June 2018 when he started to feel an exhaustion like never before, and he couldn't seem to shake this cold. You know, nothing a short vacation shouldn't fix. And as his exhaustion worsened and the cough continued while we were away in San Francisco celebrating our 10-year wedding anniversary, it became clear that rest was not the answer. Upon our return home, and of course, one more quick business trip, Nilo finally went to our family doctor who sent him for blood work. At about 9 p.m. on Friday, July 13th, 2018, our doctor called. The labs were back. Nilo needed to head to the emergency department immediately. As we raced to the emergency here at Vancouver General Hospital, we had no idea what was ahead of us. It was not until the early hours of Saturday morning that we learned his kidneys were failing. That was a shock. He was admitted, but a biopsy could not take place until Monday to tell us why his kidneys were failing and what could be done to treat the situation. On July 17th, 2018, Nilo was officially diagnosed with a rare 1 in a million person autoimmune disease called anti-glomerular basement membrane disease, anti-GBM. Nilo received 15 rounds of plasma exchange, 3 months of chemotherapy, and 8 months of steroid therapy to halt, remove, and prevent the offending antibodies from continuing their destruction. The treatment was effective in stopping the disease, and by February of 2019, his kidney function rebounded to about 26%. However, the damage was done. His kidneys were forever scarred, and a transplant would be needed in the future. But although Nilo's kidneys were damaged to the point of needing a transplant, he was very fortunate that his need was not immediate and that there was time to find a suitable living donor and avoid dialysis. On Thursday, March 12th, 2020, World Kidney Day, ironically, Nilo and I met with the pre-transplant clinic here at VGH. It was time to search in earnest for a donor. A transplant was expected to be needed by December 2020 or January 2021 if he was lucky. After watching in awe as my best friend and partner in life fought so hard over those couple of years to recover, I knew that I needed to be a part of his transplant journey. I had long wished that I could just snap my fingers and switch places with him, taking on the full burden of his illness. A wish that would haunt me again. But here and now was my opportunity to take an active role in his recovery. When we got home from the clinic, I immediately emailed the pre-kidney donor coordinator to start the process. I completed the initial pre-screening forms, and I went for blood work on Friday, March 13th to identify my blood type. And then the world shut down. The COVID-19 pandemic had arrived. As of Monday, everything was closed. I could not move forward in the pre-screening process. Like everyone else, we spent the next number of weeks glued to the news trying to make sense of what was happening. We wanted to know what would this mean for Nilo's compromised health, and more significantly, what would this mean for his impending transplant if potential donors couldn't get screened? Finally, by June of 2020, donor testing was back on. From June until October, I completed my pre-screening assessments, And in November of 2020, I was officially approved to be Nilo's direct living kidney donor. Luck was on Nilo's side. December 2020 came and went without a transplant. January 2021 came and went without a transplant, as did the next number of months. And it was not until July of 2021 that his kidney function started its steady decline. By January of 2022, it was time to book a surgery date. After waiting so long for the transplant, Nilo and I had previously made the decision to move in January of 2020. Unfortunately, his declining health left the move up to me. And as well, because it had been so long since I had been approved to be the donor, I was required to repeat a few of the pre-screening assessments. Packing, medical testing, surgery planning, all with an increasingly sick husband, made for a very stressful time for me. While our movers were still bringing things into the new house, I received a call. A transplant had been canceled. Would we like to come in for surgery on February 2nd, just 10 days away? And I remember being on the phone, standing in the chaos of our move, staring at Nilo, who was passed out on the couch, and I made one of the toughest decisions of my life. I turned down the date. It was impossible for me to get us ready for our surgeries on such short notice, especially because of the COVID-19 protocols that were in place. We would have been put into pre-surgery quarantine as soon as I hung up the phone. When I told the transplant coordinator no, she kindly but firmly reminded me that we were at the height of the Omicron surge. Quebec had just canceled surgeries, and there was no guarantee that British Columbia would not follow suit. Therefore, she could not estimate when we would get a new surgery date. I felt like I had been punched in the gut. But my answer still, this time almost breathless, was no. The weight of the guilt I felt was crushing. The wait over the next number of weeks for the phone to ring again weighed heavily. Nilo's nephrologist even suggested that we may want to consider starting dialysis, the one thing we had all been trying to avoid. But then, on February 10th, the call came. A surgery date was offered for March 3rd, 3 weeks away. We took it. I like to tell people that I wasn't nervous at all in the lead up to my donation, but in reality, I wasn't nervous because I was so focused on being Nilo's caregiver and ensuring that he was set up for success, and that my parents who flew in to care for us were comfortable and knew where things were, like the hospital, that I didn't spend any time considering that I was about to be a living, breathing, emotional human being on an operating table and a patient myself. The morning of the transplant came fast. We had dropped Nilo off here at VGH the afternoon before. I arrived here at 5:30 in the morning, checked in, and went upstairs. At 7:30 a.m., I waved goodbye to my parents, and I was wheeled into the operating room. I remember feeling like I was floating away from myself while also experiencing a surge of adrenaline, but also a deep sense of peace and reassurance that this was the right decision. Next thing I remember, it was 1:15 in the afternoon, and I was in the recovery room. Around 5 p.m., our surgeon came to inform me that the transplant had been a success. My kidney was up and running, and Nilo was creating urine like a champ. It had been a good day. Nilo and I reunited the following morning when I slowly took my first steps down the hall to his room. Being the competitive couple that we were, it was a race to see who would be up and moving. But of course it was me. From the first moment I saw him, less than 24 hours after surgery, it was evident to me how powerful a transplant can be. His color was improving, his energy was up, and he had started to lose his end-stage renal failure swelling. He looked like my Nilo again. After 3 nights, I was discharged with Nilo following only 1 day later. My physical recovery was complication-free. I had mild pain, soreness, a bit of bruising. My energy took a couple of months to come back, but by my 2-month follow-up blood work, I had the kidney function they would expect to see at 6 months. By week 14 after surgery, I felt like I had never been through anything. My mental and emotional recovery took much longer. Living with my recipient during the recovery process gave me the opportunity of seeing his incredible day over day, week over week improvement. It was everything we had hoped for. No rejection, the kidney functioned well, Nilo was back on track to live his life. As wonderful as the recovery was in terms of giving us hope for our future, it was very challenging living with my recipient during that time. Look, it's Vancouver. Our house is small. I didn't want to complain about how much pain I was in or how tired or terrible I felt, as I didn't want Nilo to feel guilty for putting me through that. Nor did he want to express his challenges with pain and adjusting to his immunosuppressive drugs, as he didn't want me to think that he was ungrateful for what I had done for him. As much as we were trying to protect the other person, there was a resentment starting to simmer between us. And on top of that, before my donation, whenever I interacted with someone here in hospital, I was always called a hero for stepping up to be the donor. And, I always brushed it off with a, no, I'm just lying on a table, I'm doing nothing, I'm no hero. Turns out, I loved that acknowledgement. And as we started to come to clinic appointments after transplant, those appointments were, of course, focused on Nilo and his well-being. I was there as his caregiver and support person. I was no longer being acknowledged as a hero or as the donor. And so as the weeks and clinic appointments went by, I found myself absolutely seething when yet another clinician did not acknowledge my role in Nilo's transplant. That added more fuel to the fire of our resentment. There were a couple of weeks post-transplant where Nilo and I lived on separate floors of our house and only interacted with each other in clinic. It was disorienting. This was my person, the guy for whom I'd had my body cut open and willingly give a part of myself to, and yet I hated him. It's true. I couldn't look at him. I couldn't stand to hear him cough, sniffle, or exist. Like, what? Sorry for this, but what the fuck had we just done? Right? BC Transplant, when I volunteer to speak to the general public, I don't include this part. But as the weeks went by and my resentment and anger settled, I started sleeping again. That was helpful. I started moving my body again. But now I found myself completely lost. Nilo was thriving. He was in control of his health and his own appointments and blood works and medications. His already successful career took off to the stratosphere, and I felt like I was left behind. He didn't need me to care for him. He didn't need me to work on the files I'd been a part of professionally. The world was also opening up from COVID, and almost all of my friends left Vancouver during that time. My community collapsed around me. I was left standing, wondering what my identity was and where did I fit in. Had I peaked in life when I donated my kidney? It took me 2 years to come back down to earth and feel grounded in myself again after my donation. I never regretted my decision to be a donor, not once. But I had not been expecting the experience to cause such emotional upheaval and a deep questioning of my purpose. As I said, Nilo absolutely thrived after transplant. Everyone had told us life would be so much better, and they were right. His energy was back. His ambition and drive were back. He was re-engaging in life in a renewed way with more energy than ever before. Our first year post-transplant was like living in this little happy, healthy bubble of ignorance. But 1 year in post-transplant, that bubble started to show little cracks. First with a case of shingles, and then his first case of COVID. Nilo's compromised immune system was no joke. Not too long after our 1-year transplant anniversary, we learned of the passing of a fellow kidney transplant recipient. He was also young and in the prime of his life. And the passing of that patient was like somebody took a pin and burst our bubble. Suddenly, we found ourselves looking around and realizing that although, yes, everyone was so grateful for their second chance at life, and they really were doing their best, but life is not always easy for these recipients. The drugs are hard on their bodies. The isolation of having a chronic illness and a compromised immune system can often affect their mental health. And the simmering fear of constantly wondering if this month's blood work is the month that shows signs of rejection and the other shoe dropping is absolutely exhausting. We settled cautiously, but always on edge into our post-transplant life. At the 2-year transplant anniversary, Nilo was fully experiencing the slog of life after transplant. Frequent colds, deep vein thrombosis brought on a new medication and new specialists, and by the spring of 2024, new symptoms emerged. Episodes of vomiting and severe abdominal pain. A dropping hemoglobin and iron led to many trips to the emergency department for fluids and a series of iron infusions. As the months passed, the episodes became more frequent and painful. His energy started dropping, but the kidney itself remained stable. Finally, in October 2024, following a CT scan, we had our answer. Nilo was diagnosed with post-transplant lymphoproliferative disorder, PTLD, cancer. A week later, on Monday, October 7th, following his regular monthly blood work, we received a call to head to emergency as quickly as we could. Nilo's monthly blood work had changed so drastically that we could no longer take the time to wait weeks for a biopsy or a PET scan. As an inpatient, these tests could take place much sooner. On Tuesday, he had a biopsy. On Wednesday, he had a PET scan. On Thursday, we met oncology and were informed that chemo would start the next day, despite not having the full biopsy results back. The PET scan had showed a cancer that was far more aggressive and advanced than anyone had been expecting. What followed next were the most exhausting, grueling, and terrifying 66 days of our lives that included a code blue, septic shock, a week-long stay in the ICU, 3 emergency abdominal surgeries, weeks of rehab and hard work, a glimmer of hope, and a discharge home on December 1st, only to return to hospital 3 days later. On December 7th, we thought he'd had a stroke, but when the second side of his face dropped only a couple of days later, a lumbar puncture was ordered. And on December 12th, we were handed the most devastating news possible. The cancer had entered his central nervous system. Despite standing in oncology clinic on December 2nd, planning the final rounds of chemo in our victory party, We were now being told only 10 days later that he had days to weeks left if we were lucky. A 1 in a million person autoimmune disease led to transplant, which led to PTLD that affects 3% of kidney recipients, which led to CNS lymphoma that affects 2% of those patients. We were not lucky. Watching the love of your life die is the most excruciating and painful experience. It is especially heartbreaking when in the past you were able to take such a direct and active role in the recovery by donating an organ. This time I had to sit by helplessly, uselessly. I could do nothing. In Nilo's final days, I sent a pleading email to our transplant surgeon telling him that I would let him cut out any and all of me to give to Nilo if I could. I was desperate to help him, desperate to fix him, desperate to hold on to him. It was a type of helplessness that no one else at his deathbed could relate to, or I think even understood what I was experiencing. Once again, I was back to 2018, pleading to the gods to let me trade places with him. On December 16th, 2024, 76 days after he was diagnosed, 11 days shy of his 38th birthday, Nilo bravely and graciously left this world via medical assistance in dying, but not without one final act of community service. And so I come back to my question from the beginning. Why would anyone choose to be poked and prodded, have extra monitoring and people in a room at a time as sacred and powerful as one's own death? For Nilo, there was only one motivation, and that was that his participation would serve as an act of gratitude and thanks to all the patients who endured the donation and transplant surgeries before they were perfected. Because of them, our surgeries were safe. Because of them, he lived an extra 2.5 years, and he lived those years well. It was Nilo's hope that his small amount of data may go on to benefit future recipients the way data of patients of the past had benefited him. For me, Nilo's participation has meant his death was not in vain, and that his story continues. When he was in hospital, Nilo received a copy of a book entitled What Comes from Spirit, written by Indigenous author Richard Wagamese. Nilo never had a chance to read it. However, that book has become somewhat of a spiritual touchstone for me in my grief journey. On one passage, Wagamese writes, "We all have stories within us. Sometimes we hold them gingerly, sometimes desperately, sometimes as gently as an infant. It is only by sharing our stories, by being strong enough to take a risk both in the telling and in the asking, that we make it possible to know, recognize, and understand each other." Medical research allows patients' stories to be remembered. Nilo's data continues to tell his story and remind us that he was a generous, community-oriented man of service. When we think of medicine as a form of poetry and storytelling, the science becomes accessible to all. Organ donation and transplant is all about allowing stories to continue. Donors and their families get to continue to tell a story of generosity and service. Recipients and their families get to continue to tell a story of hope and possibility. By telling and remembering the stories of patients and of their triumphs and of their struggles, we can continue to collaborate, innovate, and push the envelope on what is possible through research. And so thank you, MIP, for taking a risk and asking me to share mine and Nilo's story. Thank you all for holding space and allowing me to speak and share with you this afternoon. Life is not always easy for transplant recipients and their families, but it is truly the most beautiful and tragic miracle someone can experience. Research and transplantation matter. Together, they save the lives of recipients. They allow donors to live on. They uplift the families, friends, and communities of both recipients and donors. They bring together strangers and turn tragedy into hope, love, and opportunity, allowing our loved ones to continue to tell a story. Thank you.
Rachel, that was the perfect ending to a wonderful couple of days because I think it did what we tried to envision for the symposium, which was bridge donation and transplantation, and your story with Nilo from a human aspect does that, and also highlighting the importance of research was beyond impactful. So thank you. I'll open the question period up to the audience.
If no one has any questions, I do want to say one thing. That's my actual kidney that I'm holding in that photo. Which, wild experience, but super cool.
One thing I'll mention, she was talking about I'll share maybe actually there's a question right there.
Hi. That was a really powerful story. Thank you for sharing your experience. I just had a question about your journey as a recipient. I often hear that the recipients aren't supported enough after the surgery. Is there something that could have been done by our healthcare system or any supports that could have been put in place to support you?
You mean as the donor, not the recipient? Well, I mean, any? No, seriously, I got sent home from a hospital and that's it. I get a letter in the mail saying, go do some blood work, go see your GP. I mean, yes, 6 weeks out, I spoke to a nephrologist, but that's it. Nobody checks in, nobody asks how you're doing, nobody asks anything. And like I had said, yes, I'm in clinic, yes, those appointments, of course, were about Nilo, and clinic time is small, I get it. But somebody could have asked me how I was doing. I was sitting right there. One person could have asked that question. That would have been nice.
Back over here. My brother's a kidney recipient. I did go through the workup process to try to donate to him. It didn't work out, unfortunately. I was intrigued by the comment you had made about the resentment that built up over time and so on. Mm-hmm. Did you think at all leading up during the workup process, during the first thoughts that you were going to donate, that ever would happen? Like, did you have any inkling of it? Was it a complete surprise? Can you just walk me through that a little bit?
I was not prepared for that at all. I thought it would be just this glorious moment and how wonderful it is, and we'd be connected deeply forever. And I mean, we did have that, but no, it was shocking. And it was very, I'll say, use the word disturbing to suddenly hate. And when I say hate, I mean I hated him. It's not so funny when you're experiencing it, but yeah, it was a shock. And I didn't know what to do with that. And nobody's checking in for me with clinic. Who do I talk to? Where do I express this? How do I I didn't know what to do with that. And I think when you're in it, you also don't necessarily know that you need to be asking for help. And because I didn't know where to go, yeah, it was shocking. But you should all consider living donation. It's a wonderful thing. Just maybe think about, I think the difference was, I had heard other stories, but not from anybody who lived with the recipient. And I think if you get to go home and be in your own space and be like, oh, this fucking sucks. Like, you can do that at home, but when your recipient is right there, you don't want to do it. And that was the challenge.
So is it safe to say that you really endorse non-directed donation?
I support all organ donation in any capacity.
How did you overcome that? You obviously connected back again and you reformed that relationship, but like as a message that maybe that can be delivered to living related donors, like how did you overcome that?
We had a really, really good marriage beforehand, and we were both very reasonable people, and I think it was time. It was then me sorting out what I'm doing with my life. It was getting involved in this community and feeling like I had purpose. So it was about finding myself again, and just time, and sleep, and not being in pain, and getting to move again, yeah.
Thank you, Rachel.
Thank you.
Well, that brings things to a close. Yeah, an amazing couple of days. I'd like to take a bit of time to acknowledge some people. First and foremost, as I said, this was the melding of entities working across silos, working together, donor families with recipients, Critical Care BC, BC Transplant, Cerebri. It's been a really cool event. And so first, I'd like to thank yourselves for taking time out to come and attend. I hope you found it informative, inspiring, it was cool. I'd like to thank our sponsors as well, who contributed to help supporting this event. Nurses, it's Nursing Week, thank you. And there's some specific individuals I'd like to thank. The out-of-town speakers for taking time out to come. My goodness, you all were phenomenal. Our local speakers, again, these things are hard to, in our busy lives, they're hard to put together these talks to share your experiences and perspectives. Some specific people, BC Transplant, Eric Lunn, Sean Keenan, Kieran, Nehemiah, Sean Badesha, and I'm sorry I'm missing some others too, but you guys were particularly influential and important in the conduction of the event. Critical Care BC, Ben Ridout, Hussein Kanji, Amandeep. Again, I'm going to miss some people. Badshaw, Kim Sum, a lot of these people. Kira took a lot of time to put this event together. There's one person in particular, my goodness, I don't know how she does it. She's just like a wizard at these things, and that's Zena. Organizing an event with Zena is the best, because you don't need to do shit. So I remember I was texting her. I'm like, "Hey, Zena, we got to do this, we got to do that," and she's like, "It's taken care of. It's done. I thought about it 3 weeks ago. It's fine. Don't worry about it." So yeah, you're just you're a gem. Yeah. And with that,
just wait.
We've got some door prizes.
Door prizes, but I actually
being on the receiving, I want to be on the receiving end of this. I think we should all thank you.
Thank you very much. That's very kind.
And while you're giving the door prizes, you brought together clinicians, world-renowned researchers, patients, providers, but most importantly, what you do so well, and I really truly want to thank you for, is you brought the human experience. So thank you.
Okay, we're gonna do some door prizes. I better pick Hussein's ticket, I suppose, hey? All right.
There's 6.
Okay, there's 6. Well, this one just has a name on it. Okay, here we go. 760035. 760071. 759997. 760050. 760050. No? Okay. What else? 760074. 760074. Okay. 759694. Okay, a lot of people pieced out. Oh, there we go. Okay, two more. 760059. 760059. 769689. 769689. Okay.
Soon it's going to be for you.
Yeah, I might as well just take it home. 760065. 760065. Okay. 759986. Okay. All right. I think we should just, what should we do? Okay. All right. 760052. Yay. Yeah, Matt?
Hey, if people back home missed it, are the recordings of any of these sessions going to be available?
Sean? Yes.
Yeah. All right.
Yeah, they definitely will. But yeah, anyways, thanks again. Have a wonderful evening. Much appreciated.